Right, opening up the waiting
All
room.
right, good morning, everyone. And welcome to this meeting of the Mental Health Services Oversight and Accountability Commission. My name is Mara Madrigal Weiss, and I am the chair of the commission. I want to thank you for attending today's meeting. The commission's strategic plan for 2020 through 2023 is committed to advancing the commission's vision of well-being for all Californians. Cody, thank you for putting up the slide. Now we will take roll and establish a quorum. Jeff, can you please take roll?
Yes, Madam Chair. Commissioner Bontrager,
Here.
Commissioner Bontrager,
I'm here. Here.
Commissioner Bontrager will be indicated as present. He's having a technical issue, but we see him and acknowledge his presence. Commissioner Boyd, Commissioner Brown,
Here.
Commissioner Bunch,
Here.
Commissioner Carrillo, Commissioner Carnavale,
Here.
Commissioner Chambers, Commissioner Chen.
Present.
Commissioner Chen also has acknowledged her presence, although I think we are having technical difficulties in hearing her. Commissioner Cortese, Commissioner Danovich,
Here.
Commissioner Gordon,
Here.
Commissioner Gordon has acknowledged his presence. We are also having trouble hearing him. Commissioner Mitchell, Commissioner Rolette, Commissioner Tamplin,
Here.
Vice Chair Alvarez,
Here.
Chair Madrigal Weiss.
Here.
Madam Chair, you have a quorum.
Thank you, Jeff. I want to now thank Kayleen Gilbert, Mental Health Program Manager for Los Angeles County Department of Mental Health, for joining us. We've set aside a few minutes for her to welcome us here and make brief comments on the work and priorities that are happening here in Los Angeles County. So Kayleen, we welcome you. Thank you for being here.
Thank you so much, Commissioner, and thank you all for having me here. My name is Kayleen Gilbert. I am the Mental Health Services Act Coordinator for Los Angeles County, and on behalf of myself, our Director, Dr. Lisa Wong, and the Department of Mental Health, we'd like to welcome you to Los Angeles. I certainly wish we could have brought some more sun for you, but we'll do the best we can. A quick note on myself and this role: LA County has not had a Mental Health Services Act coordinator or central role and unit for about 4 to 5 years. The last person who held this role was Dr. Debbie Innes-Gomberg, and I've been very fortunate to have access to her as well. So while I'm new to the position, I started back in September, I'm certainly not new to the Mental Health Services Act. I've worked in programs as a clinician and an administrator for some 18 years. This is my passion, and I'm thrilled to be here. So if you'll indulge me, I'll talk just a little bit about our department and our new leadership and LA County in general. Starting with LA County, which is, I think as most folks know, pretty big. We have just under a population, just under 10 million. And of that, 4.2 million are Medi-Cal beneficiaries. We also have about a $3.1 billion budget, 24% of which is our Mental Health Services Act funds. I think what most folks also know is we are pretty diverse. LA County has 13 threshold languages that we work to accommodate. And we have a very geographic area as well. So most folks know, right, our downtown areas, our beaches, our suburbs, but we most certainly have rural areas as well. So anytime we consider programming, we need to consider the needs of all of Los Angeles County. I want to take just a second to talk about our new director. We are really thrilled to have Dr. Lisa Wong join us as a director. She took on the interim position when Dr. Sharon left and was sworn in permanently, or she was appointed permanently in February of 2023. So, you know, she has identified and stated, these are really the stated goals she gave to the board when she started. And before I read them off, know if I can read them from this distance before I read them off. I want you to know they feel a little lofty, but I have to say she has absolutely operationalized every single one of these and is just so passionate about the work that she's doing. So she has that goal to build the strong, skilled workforce that is supported and valued, that knows it is supported and valued, to maximize. I'm so sorry. I can't read my slides. I apologize. It's just a little too far. Thank you. I'm so sorry. Oh, gosh. What? I'm so sorry. Thank you so much.
But we're not seeing the slides on the screen. There you go.
There we go.
Thank you.
Thank you very much. Thank you very much. So pardon me, thank you so much. The goal to maximize the utilization and impact of all funding sources. Priority projects will be thoughtfully developed, launched in a timely manner, evaluated and improved to ensure optimal utilization, efficacy, and impact, and provide the highest quality mental health services that are responsive, culturally and linguistically appropriate, timely, and through an equity lens. I think these are all things that she came in with values for. And as I noticed, she really has made strides in almost all of these areas, building our workforce, ensuring folks know that not only they are valued, but it's important that the work that they do, and to really make sure that we are thoughtful about our program implementation. Another just couple of notes about her that I haven't included in here. If you don't know her, she started her career at the Downtown Mental Health Clinic on Skid Row as a student. She was there for some 23 years, starting as a clinician, and by the time she moved into administration, she was the program manager. She will say that those are her people, that's her home. And she definitely has brought the passion from that work and the understanding of what it takes to do this job with her into her administrative work, all the way up into director. So we are really, really fortunate to have her. I'm just going to go over a couple of the priorities right now for Los Angeles County, and then some of the programs that I wanted to highlight as part of that. I think if folks are not aware, we have both the city and the county have declared a state of emergency around homelessness here in LA. And that is now really driving much of our work. And the overall goal countywide is to address encampments and make sure folks have access to quality care and housing, be it supportive housing, permanent housing, or interim housing. I've not seen such collaboration between the city and the county in some time. It's really, I think, incredible the barriers that they're working to bust. So, you know, we always hear we're trying to kind of address red tape, but I think the county has really made some strides in hiring, contracting, doing what it is we need to do to address the needs of the unhoused. So that has really been the key to the work that we've been doing. So one of our key programs is our homeless outreach and mobile engagement team. That's our home team. This is our dedicated service across LA County to do the long-term engagement, right? The folks that we know really need to be part of our full service partnership programs, but are hardest to get in, hardest to convince for services. And these folks know it can take up to a year or more, and we'll stick with them as long as it takes. And know that some folks are never going to walk into our front door, right? So if you're going to treat them, you need to treat them, even if it's there on the corner by a tent. So this is Dr. Shai Rob. He's our street medicine psychiatrist and has been training others in the practice. This photo is actually from an LA Times article a few months ago, but they have done some incredible work, really trying to connect folks with services where they're needed and making sure they get the access that they need. So in addition, we're also working on improving our alternative crisis response. Like most other counties, we're implementing 988 in place of our access hotline. But in addition to that, we just want to make sure that there is always easy access, someone to call, someone to respond, which is in our case, our field intervention teams. We are expanding those, and somewhere to go. And specifically somewhere to go that isn't always a hospital bed, right, when somebody is in crisis. So we've been expanding crisis stabilization facilities and crisis residential treatment programs to make sure that we have other options for folks who are in need of safety and support during a crisis, but of course, in the least restrictive environment that we can provide. LA County has also done a lot of work to respond to crisis in the moment in our communities and in the cultural manner. Not so long ago, just as an example, we had the shooting, the Monterey Park shooting at the senior center, which was really a hard hit for the API community. So of course, our crisis folks were there on site that night, but in the weeks and months that followed, Dr. Wong has really made sure that we've brought out a lot of our staff members, our API language speaking, Mandarin, Korean, making sure that we're out there. And instead of going out with badges and trying to get folks to come into mental health services, we've established tea times. Just established space for folks to talk and engage. And we have found that to be so successful that we're really working to expand that work. So it is that, just meeting folks where they're at. We also have our school threat assessment team under prevention and early intervention. This is not only identifying risk and assessing risk, but these teams also consult with schools to help them identify risk, mitigate risk, and create their own programs. And so they can do their own self-interventions and bring in help when it's needed. And then finally, we of course have so much more, but I think this is just some of the things that we're doing now. One of the newest programs that we have is our United Mental Health Promoters. This program is based off the success of our innovations project with our community ambassador network, and also off the Promotoris model that we had held for some time. This is community members engaging community members in their language, in their neighborhoods, in their culture. And a lot of the services include trainings, referrals, stigma reduction, really trying to get out there and connect people and lower the stigma around mental health, get folks talking and being more comfortable with it. And we found that to be quite a success as well. So we're looking to expand that and do some cultural translations so that, and we can't just replicate the model in every culture. So really making sure we're meeting the needs of our API community, our Middle Eastern community, even our African heritage, African American community. So we've got community members out there engaging folks. So that is where I think, because I know I have such limited time, I don't want to take up too much. I know you have a lot to cover today, but I just again want to say thank you so much for letting me just come up here, introduce myself, and say a few things about LA County. So thank you.
Thank you, Kayleen. We appreciate the welcome and thank you for sharing the work.
Madam Chair, I don't know if this is the right time, but I just wanted, as part of this, to say what an incredible site visit day we had yesterday in Los Angeles. I think for all of us, it was incredibly moving. You know, we listened to national debates and a lot of black and white conversation. And what we experienced yesterday was incredibly complex, nuanced, problems and opportunities and hope and community organizations that are working so hard and spending a lot of time with the police department and understanding the challenges of their jobs and working with a complex picture of gangs. But out of that, I just have to say I learned so much, and it was such a moving experience to meet so many incredible people working so hard here in Los Angeles. And of course, we were in Watts in particular, and just to see what reality is was a whole new experience for me. So thank you for that opportunity yesterday.
Glad you had that opportunity.
And actually, Kayleen, the program that we went to, the REACH program, they're going to be presenting later today. I'm not sure if you're aware of it, but it's through Children's Institute. So they're contracted with LA County, but it might be a good program for us or LA County to look into as well.
Commissioner Mitchell, did you want to make a comment? Yep,
Oh, I have to hold it.
you have to hold.
Multitask here. Good morning, Kayleen. Again, to acknowledge what my colleague here said, we had an amazing day yesterday visiting all of these wonderful programs in the area of Watts. And so, as Commissioner Bunch said, the REACH program who will be presenting, amazing, but all of them were, hats off to your law enforcement who are working diligently in these communities to support the youth, families, and their struggles. So at some point, I would love to know what the county, is doing in the city of Watts. Again, maybe not for this meeting, but for down the road, because these are programs that are on the ground, doing the work, making significant impacts in these areas that have just been forgotten. And they're doing this with their hearts and very little resources. And so I think for all of us who made those visits yesterday, we're like, where's the money? Where's the meat on the bone? So at some point, I think that's a discussion that some of us would like to have regarding how can we better support these programs that are doing so much with so little. But thank you for the work that you're doing as well.
I would be, if we have the opportunity to hear a little bit more about that visit and the program itself, and would be happy to come back and talk about our South LA, some of the work we're doing there. Absolutely.
Thank you, Kayleen, and thank you, commissioners. We were going to share. Happy that we're sharing that now. Very impressed with what's happening there. And I will say, between the city attorney's office, law enforcement, community-based organizations, and grassroots efforts. There was one group that we visit, the Sisters of Watts, and they have their pulse on what's going on in the community. And yet I don't think our bigger agencies necessarily know about them, but they're making the change. And so I think we need to do better about communicating what's out there, knowing what's out there, and just working more in collaboration with that. So I think pockets of excellence are great, but how do we replicate? Because that's just one community that we got to see, and what, the effect and the trauma that's happening there is happening elsewhere. So thank you, commissioners, for sharing your thoughts. Appreciate that. And thank you again for being here.
If I could, I think one of the initiatives that we have right now is certainly to support a number of our CBOs out in the community with prevention work. So I would again be interested to hear about some of the work that is there, but that is a part of our focus right now, is bringing up more of these smaller agencies that are really doing the work in the community, not just in Watts, but elsewhere. So making sure they have those opportunities. So again, glad to come back and talk about that.
Perfect. And we will make sure that staff shares with you where we went in the different programs so that we can have a conversation about it. Great. Thank you so much, Kaylee. I would now like to make some announcements. The April 2023 commission meeting recording is now available on our website. And for the June meeting, as you all know, we normally do not have a June meeting, but due to a few county innovation projects that have funds at risk of revision and are needing review, we had to schedule a meeting for June. So it will take place on June 15th from 9 a.m. to 12 p.m. and it will be virtual via Zoom. And now some updates on staffing. I'd like to make a few staff announcements. I am happy to announce that Lester Robancho and Lindsay Thornburg walked across the stage last weekend to accept their master's degree in public health. Well done, Lester and Lindsay. We look forward to all the knowledge you'll share as the commission discusses next steps for our mental health advocacy effort. And next, Sarah Yeffa, our communications officer, will be out on maternity leave. We congratulate her on her newest addition. We also have a personnel change to announce. Congratulations to Tom Orrick as he joins our executive team as the new Deputy Director of Operations. We look forward to his leadership. So congratulations, Tom. Also, I want us to have another opportunity to say hello to Alicia Dotrieve, the commission's first Sally Zinman Peer Fellow. Alicia had some technical difficulties last month when we introduced her, so I wanted to make sure we all had an opportunity to say hello and welcome her to the commission. Alicia will be working with the community engagement and grants team on various projects. So we're very glad to have you here with us, Alicia. We look forward to your valuable perspective on the commission's projects. Would you like to say a few words?
Can everybody hear me?
We can hear you. There's a little bit of an echo, but I think we are going to address that.
Okay. All right. I just want to say thank you for the info and the introduction. I'm definitely really excited to be here and I look forward to this opportunity. I really like to be part of the effort to create, more pathways for peer respite, sustainability for sure. And any peer services, peer certification. I'm always happy to have the lived experience input on this. So thank you very much.
Alicia, we had technical difficulties. Now it's our turn. So we're going to own that and we are trying to fix that momentarily and we'll try this again. So please be patient with this. Oh, Dave, online, could you please say something? So we're trying to test out.
Morning.
Thank
Can you hear me? Can you
Yep,
hear
we
me?
hear you fine. Perfect.
Okay.
Alicia,
Yes. Can you hear me?
is it possible for
So I'm muted. I can't hear anybody though.
Hey, Alicia, I think we're working on it on their end,
Got it.
but we can hear you on Zoom though.
among constituents to promote inclusion of underrepresented perspectives to ensure that all communities have a voice in public forums. This collaboration is an exciting opportunity to build bridges with UC Riverside and the Inland Empire region. While the tool is still in its early stages of development, it has the potential to be something we adopt for committee, subcommittee meetings, other community engagement meetings, and even our full commission meetings. We will report back on this project as it progresses. The Client and Family Leadership Committee will be meeting on Wednesday, June 14th at 1 p.m. The agenda is still being prepared, but there will be discussion of the governor's proposal to modernize MHSA, a discussion on care courts implementation, and a discussion of the commission's efforts to understand the current state of full service partnerships and evaluate their impact across the state. The Cultural and Linguistic Competency Committee will be meeting on June 27th at 2 p.m. This meeting will include an opportunity for further review and discussion of the governor's MHSA modernization proposal and an update on the commission's full service partnership work. I want to let everyone know that the commission approved an additional $560,000 of innovation spending authority for Marin County's innovation project. From housing to healing, a reentry community for women. This project was originally approved by the commission on May 27, 2021. This project had a significant amount of community engagement, not only at the local level, but also through the commission's process, which is outlined in the documents in your packets. Cody, could you please share the slide reflecting that approval? Thank you, Cody. The documents are also included in your packets and can also be found on our website. At this time, I want to welcome everyone again in today's meeting. The plan is to end around 4:30. I understand that we started late with some technical difficulties. You know, as we travel and try to get around the state, we will experience difficulties. So please, let's just show one another grace, and we will do the best we can, as we always strive to. Commissioners, if you leave the teleconference meeting for any reason and decide to rejoin, please make sure to use the raise hand function so that the commission staff can make sure you are co-host again. If you have a comment to provide, please unmute your line and seek recognition when it is convenient. I also want to point out that we have a full agenda and we are scheduled to take a short lunch break about noon. Because commissioners and staff are required to remain here for the meeting, we have arranged for lunch to be brought in. I would encourage members of the public here in the room to make similar arrangements if you plan to stay for the entire meeting. It is now time for agenda item 3, general public comment. This time is reserved for comments on the item on items that are not on the agenda. If anyone is interested in making public comment regarding the announcements or other items, please make those during this general public comment time. If you have any technical questions, please contact us at 916-500-0577. At this time, I will ask Amariani to go over the public comment procedures.
All members of the public will have the opportunity to offer comment as described in the agenda. If you would like to comment on an agenda item, please wait until that item starts. You may request to make public comment by clicking the raise hand icon on your computer or the app, or if calling in by phone, push *9. You will be placed in a queue to comment on that agenda item. When it is your turn to comment, the moderator will unmute your line and announce your name or the last 3 digits of your telephone number. When you are unmuted, we are able to hear you. We will do our best to take comments in the order they are received. Please note, once the public comment period for the agenda item starts, we will close the public comment queue, so please make requests to comment now. The moderator will insert the word last comment next to the commenter's name or number to identify the last public comment. Members of the public should be prepared to complete their comments within 3 minutes or less, depending on time constraints. When we have reached the end of your time, our staff will let you know, but we will let you finish your thoughts. We don't mean to cut you off, but we do want to help everyone keep time. We truly appreciate your understanding with this process. Lastly, if there are any members of the public using translation technology, please notify the chair, and at least twice the amount of time will be given to you during the public comment period. A live meeting transcription or closed captioning is available for anyone participating in the meeting. If that option is not currently visible, please activate the closed captioning feature located in the control bar at the top or bottom of your screen. And we can now open up the public comment queue.
Yes, thank you, Amariani. Let's start with comments from members of the public in the room, then move to online attendees.
Okay, we have one in-room comment from Linda Hobbs.
Good morning, honorable members of the commission. Because of the unexpected death of my significant other on April the 27th, 2023, I drove 4 hours round trip and sat in the office for 2.5 hours to obtain mental health services from Los Angeles Gay and Lesbian Community Center. I am a member of that community. I was promised 5 services, 3 online groups. I would have to wait 6 weeks for individual counseling, and I was going to be provided crisis counseling immediately while I was waiting for a weekly therapist. 2 weeks later, the entry-level clerk, and I have his name, called me to tell me all my mental health services, called to tell me that all my mental health services were rescinded. It was a mistake on his part, and that was the only explanation I was given. No referral to anything else. I went online and attempted to look up executive staff or the board of directors meetings. When I could not find an agenda of any of the board of director meetings for the Los Angeles Gay and Lesbian Center, I contacted Miss Sharon Brown. She's their impact officer and she's a member of their executive staff. I've asked her 3 times by email, and I have the emails available for you today. When are the board of directors meetings? They refuse, Ms. Brown has refused to provide that. I know the board would, the LA Gay and Lesbian Board would find what has happened to me to be unconscionable. And I needed to state that here today for your support in obtaining services from them. Thank you very much. Shall I sit down?
Yes, please. But thank you, Linda. First, I'm sorry for your loss. And we have a representative from LA County, so I hope that they will follow up with you. Thank you, Kayleen. And also I will make sure that staff follow up with you. Thank you so much.
Thank you very much for your time.
Thank you. That was our last in-room comment. Online, we have Stacy. Your line is unmuted.
Good morning, Commissioners. Stacy Hiramoto with REMCO, the Racial and Ethnic Mental Health Disparities Coalition. I hope you're having a nice day in Los Angeles and wish I could be there with you. I had prepared comments, but I'm trying to gather my thoughts because I just heard that the CFLC and the CLCC will be meeting, which I am delighted. I am just a little surprised because in the past, there have been periods of 2 years for the terms for these members, and I thought that this was a new term. I have nothing against the old members or the former members of the committee, so I'm fine because there are urgent items on the table. So I just hope, in addition to the governor's proposed changes to the MHSA, that the committees also be brought into other things such as the strategic plan, and that these committee meetings, of course, I assume will be open to the public. REMCO strongly supports the commission not be brought under the California Health and Human Services Agency as proposed in the governor's proposal to modernize the MHSA, and we will make this position known to the administration. One of the primary reasons is, in addition to the commission remaining more independent, is that currently the commission offers more opportunity for dialogue with the public, not just little 3-minute increments, but in committee meetings, there have been opportunities for dialogue and more discussion. So again, I am delighted, and I hope that we can hear more information about who's on the committees, how long their terms are, and I didn't get the dates. I tried to write them down, but I hope I can, I'll contact the staff later for the dates of those upcoming meetings. Thank you so much.
Thank you, Stacy. And the dates are in the packet as well, but staff will happily share those with you.
All right, next we have Steve Leone. Your line is unmuted.
Hello, thank you. Can you hear me?
We hear you fine, Steve.
Great, thank you. First of all, I want to contextualize what I'm about to say by saying that I agree with everything that Stacy Hiramoto just said, including the fact that the commission is more open to people than a lot of the departments, et cetera, have been in this state. However, I'm quite upset, and this was triggered by the announcement that was just made. I'm a member of the California Behavioral Health Planning Council. Now, I'm speaking for myself. I'm not speaking for the council, but I am a member. And our meeting is on June 13th, 14th, 15th, and 16th. We have that meeting a week earlier from usual because we usually tag our meetings by the third Wednesday. And the third Wednesday this month, or that month, was followed immediately by the fourth Thursday, which is your usual commission meeting time. So we set these quarterly meetings about a year in advance. And we moved the whole thing a week earlier so we would not conflict with the commission, the presumed date of the commission if you chose to have one. And yet here we are, both the CFLC, which I often would like to attend, and the commission itself. I won't be there. And anyone else who has interest in both will have to choose one way or the other. And it's not just this one time. This has happened repeatedly. You may have recalled me ad nauseum coming up with this. It's a mistake, a repeated, just check our schedule before you do something like this. I mean, as much as I want to support what Stacy just said, you guys are more open and you provide more opportunity. After a while, it begins to feel like you just don't care about our existence. And I don't think that's really true, but got to do something about that. Thank you so much.
Thank you, Steve.
Next we have call-in user 1. Your line is unmuted.
Hi, this is Mark Carmet, and there are a couple of things that I'm concerned about, and so other consumers, and that is the progress of Senate Bill 43, which has to do with forced hospitalizations and such, and also basically we don't want it to pass. It's now on the floor of the state legislature in the Senate, and we are not wanting it to pass because it expands the use of clear and present danger and grave disability. It's a forced treatment bill, and we want it not to pass. The reason the reason for that is because it takes away our choice in treatment and takes away some of the empowerment of mental health consumers. We need to have that empowerment in order to be able to operate. Okay, and another comment I have is there's Project Return Peer Support Network along with the Mental Health Association of San Francisco and the California Mental Health Services Administration has now what's called the California Association of Peer Providers. And the California Association Academy of Peer Providers. It's an 80-hour training and has guest experts, an option to have peers to provide peer partners, I'm having trouble speaking. There are concepts of hope and recovery and confidentiality, conflict resolution, co-occurring disorders, crisis and safety planning, cultural and structural competence, digital literacy, documentation, employment services, group facilitation, motivational and interviewing, systems navigation and referrals, psychiatric rehabilitation, the role of advocacy, the role of consumers and families, self-disclosure, workplace, self-care and self-awareness, trauma-enforced care, welcoming and great equalization, and peer-centered language. We need to have that in, and we're trying to get that going. Project Return has what's called a CAPS program.
Thank you, Mark, for
Cultural
your
and
comment for your
Linguistic
time.
Competency Committee. No, I'm sorry.
Thank you.
So please consider them, maybe have them speak before you.
Thank you, Mark.
Next, we have Richard. Your line is open.
Good morning, commissioners and staff. I attended the CARE Act work group and was surprised to learn the budget for the CARE Corps of $100 million for the counties this year, that's starting in October, with the exception of Los Angeles County that starts in December, and they're getting additional $15 million because of the size of the homeless population and need. And for next year, for all counties, will be $290 million for all counties. That is a lot of money at stake when a lot of counties do not have the resources, the housing, the programs, the psychiatric beds to place them in, especially where I live in Santa Cruz County. We only have 16 beds for 5150. According to a report, 818 individuals are unhoused or with the SMI unhoused community. Where are they gonna go? They're gonna place out of county. It's a crisis that's going to fail. And I know that the counties prefer to use the MHSA dollars relating to CARE Court instead of the general fund because they cannot afford to pay with the general fund because it's going to be a financial issue with the counties. As if I told the Secretary of the Health Human Services Commission and the work group is that MHSA was not intended for CARE Court. That was not the sole purpose of the use of CARE Court. Of course, it's happening with the changes with the MHSA Modernization Act, and it's going to happen, including with the Oversight Commission being transferred under a state agency. They already made up their mind. It's very obvious. Changes that we don't like to see, but it's going to happen. I'm disappointed with the misuse of MHSA that's going to be happening relating to CARE Court. Secondly, Medi-Cal will be facing cuts, not due to work requirements relating to the debt ceiling, but also additional cuts to Medicaid and all other programs because they want to scale back the budget allocation money for those programs. Is going to be significant, which means people will be cut off Medi-Cal, people will not be able to get certain services that's covered under Medi-Cal, that's an agreement between the state and the federal government when it comes to optional services like vision, dental, and it just goes on and on. It's a very long list. We're just gonna get the bare minimum. I'm currently on Medi-Cal right now, and I cannot find a mental health worker or therapist because they're just swamped with the need. There's not enough going around. I've been looking for a month with no luck. It's been frustrating. It's a shame that it's happening. So just keep up the good work, commissioners. Thank you.
Thank you, Richard.
That was our final public comment.
Thank you, Mariani. Thank you for all those that shared your public comments with us. At this time, the commission will now move to agenda item number 4 and consider approval of the minutes from the April 27th, 2023 commission meeting. At this time, I would like to invite commissioners to offer comments or ask questions. Please.
Yes, excuse me, on page 20, second paragraph where it's paraphrasing my comments, 1, 2, 3, fourth line. Could I ask that the word local jails and in be inserted between in and the state prison system? So that the sentence would read behavioral health that occur in local jails and in the state prison system.
Thank you. We'll ask staff to correct that. Any other comments or questions regarding the minutes? Okay, at this time, members of the public may request to make a public comment on agenda item 4 by clicking the raise hand button on your computer or the app, or by calling by phone, push *9. Once the public comment period for this agenda item starts, we will close the public comment queue, so please make your request to comment now. Also, please limit your comments to 3 minutes or less. Amadiani, are there any public comments?
We have one online. We have Richard.
Good morning. I reviewed my comment section of the packet and found errors regarding my comments. I will have to go back and review it to determine the correct wording or language that I used. But I want to let you guys know that an error was made. Thank you.
Richard, I'm going to ask that you please submit those in writing to staff. Your corrections when you can. Thank you so much. Now that public comment has closed, I would entertain a motion that the commission approves the April 27, 2023 commission meeting minutes as modified. Thank you. Commissioner Danovich makes the motion. Vice Chair Alvarez seconds. We have a motion and a second to approve the February meeting minutes. Are there any additional the April meeting minutes? Are there any additional questions or comments from commissioners? Seeing none here in the room, seeing none online, I will ask Jeff to please take roll.
Commissioner Bontrager,
Aye.
Commissioner Boyd, Commissioner Brown,
Aye.
Commissioner Bunch, Commissioner Carnavale,
Aye.
Commissioner Carrillo, Commissioner Chambers,
Aye.
Commissioner Chen, Commissioner Cortese, Commissioner Danovich, Commissioner Gordon,
Aye.
Commissioner Mitchell, Commissioner Rolette, Commissioner Tamplin,
Abstain. I was absent.
Vice Chair Alvarez, Chair Madrigal Weiss.
Aye.
Madam Chair, the motion passes.
Thank you, Jeff. Jeff, at this time, I'd like to ensure that we have a count of all commissioners. I know we were having some difficulties in the morning, so earlier, if you could just verify commissioners that came in.
Madam Chair, you still do have a quorum, and the record shall reflect that Commissioner Chambers has joined the meeting.
Excellent, thank you. We will now move on to agenda item 5, the items calendared for consent. This includes the approval of innovation projects for Monterey and San Bernardino counties and an innovation budget correction for Imperial County. Commission staff have sent the documents related to these projects to all commissioners at the time that the May agenda item was posted. And a copy of the staff analysis for Monterey and San Bernardino have been provided in your packet. These projects had a significant amount of community engagement, not only at the local level, but also through the commission's process, which is outlined in the document in your packets. Additionally, in the handouts, you will find 2 letters of support for Monterey County's project. As a reminder, any commissioner can remove an item on the consent calendar. That item would then be considered as a regularly scheduled agenda item. At this time, I would like to invite commissioners to offer comments or questions. I see none here in the room, and I see none online. So now is the time that members of the public may request to make public comment on agenda item 5 by clicking the raise hand button on your computer or the app. Or if calling in by phone, push *9. Once the public comment period for this agenda item starts, we will close the public comment queue, so please make your request to comment now. Also, please limit your comments to 3 minutes or less. Mariani, are there any public comments? Please raise your hand now as the queue will be closing.
Madam Chair, before we go to the public comment, I wanted to mention that we had received an extra a letter of support for Monterey County from the Monterey County Sheriff's Department. I just want to make sure you all are aware of that. Thank you.
Yes, thank you so much.
For public comment, we have one comment online from Hector. Your line is open.
Good morning, buenos dias. My name is Hector Ramirez. I'm a volunteer with Call Voices, which is a stakeholder advocacy group. I really wanted to thank you for this presentation, and I wonder if perhaps within the report, there's any clear indication of the actual number of consumers from your local behavioral health department that contributed to this particular plan and the opportunities that they were given as direct stakeholders to develop that, particularly your equity-seeking populations, your Native American and Hispanic population. And I just had a question where in the document that said note that individuals that participated in this process were provided with disability accommodations, material in Spanish, and plain language opportunities. Those were some of the things that I was kind of looking for, and I wasn't completely clear. And I'm not really sure how this commission evaluates proposals, if there is a particular metric or they just kind of vote on consent and how everybody feels. So I wasn't sure if there's actual operating standards on how these proposals are evaluated. If it's similar for all counties of the state, or if different counties get preferential or discretions that other counties don't get, given the fact that there's no clear matrix on how these documents are evaluated and voted on. So I just wanted some clarification as a stakeholder. I am a consumer of the Los Angeles County Department of Mental Health, Native American and Latino. So I've had some definite questions regarding my community members in that particular area, whether or not they had an opportunity to participate and comment to this particular document. Thank you.
Thank you, Hector.
That was the final public comment.
Now that public comment has closed, I would entertain a motion that the commission approves the consent calendar, which includes a budget amendment for Imperial County's EHR project in the amount of $114,481, funding for Monterey County's Rainbow Connections Innovation Project, and funding for San Bernardino County's Progressive Integrated Care Collaborative Innovation Project. Thank you, Commissioner Mitchell. Do I have a second?
Second.
Thank you, Commissioner Tamplin. We have a motion and a second to approve the consent calendar. Are there any additional questions or comments from commissioners? Seeing none here in the room and none online, I will ask Jeff if you could please take the roll.
Commissioner Bontrager,
Aye.
Commissioner Boyd, Commissioner Brown,
Aye.
Commissioner Bunch, Commissioner Carnavale, Commissioner Carrillo, Commissioner Chambers, Commissioner Chen, Commissioner Cortese, Commissioner Danovich, Commissioner Gordon,
Aye.
Commissioner Mitchell, Commissioner Rolette, Commissioner Tamplin,
Aye.
Vice Chair Alvarez, Chair Madrigal Weiss,
Aye.
Madam Chair, the motion passes.
Thank you. Congratulations to those counties. Congratulations then to Monterey and San Bernardino. And I just want to make comment. Questions, we can't answer all those now. However, I would encourage everybody to go back to the report, the staff analysis, and if there are very specific questions, please always feel free to reach out to staff who then can facilitate conversations with those counties to ask those specific questions regarding community engagement and who participated. So thank you for that. Next, we will move on to agenda item 6, Governor's proposed 2023-24 revised budget action proposal, the CYBHI grant program and commission expenditure authority. So moving to agenda item 6, the commission will hear a presentation from the governor's proposed budget revisions for 23-24 and hear an update on the commission's 22-23 expenditures, a revised spending plan, and associated contracts from Deputy Director Norma Pate. We will also hear a presentation from Autumn Boylan, Deputy Director at the Department of Healthcare Services on the Children and Youth Behavioral Health Initiative Grant Program. At the March Commission meeting, our community partners raised concerns about the community engagement process for CYBHI grants. I would like to thank Vice Chair Alvarez for working with DHCS to address the concerns raised at the March meeting. Autumn is here today to provide an overview of DHCS's community engagement process. So at this time, I'd like to start with Deputy Director Norma Pate to share her updates.
Sorry, I was pushing the wrong area. Thank you. In your packets today and also on our website is a list of the items included in the governor's May revision this year. And today I just wanted to highlight a few things that might be of interest to the commission that are included in the governor's May revisions that further our initiatives or where funds were switched from general fund to Mental Health Services Act funds this year. As you're aware, in prior years, the commission provided funding to support Cal Hope. The May revision maintains funding to temporarily extend support for Cal Hope program. The May revision includes 50 million one-time mental health services funds to support this program. The governor's May revision also includes 500 million one-time mental health services funds to support behavioral health bridge housing program. This program provides immediate housing and treatment needs of people experiencing unsheltered homelessness with serious behavioral health conditions. This year, the commission allocated 20 million to support older adult programs in California. The May revision provides an additional 50 million over 4 years for the Department of Aging to support the continuation of the older adult friendship line that provides crisis intervention and emotional support for California's older adults. The May revision does not include Mental Health Services Act funds for outreach and engagement, technical assistance and advocacy for older adults. The commission requested that staff seek funding to support these efforts, and we were not successful in obtaining funding to support advocacy efforts for older adults this year. The May revision includes an additional 1 million for a total of 10 million for the Health and Human Services Agency to create an innovation accelerator initiative for a public and private partnership. According to the May revision budget summary, an initiative to create an environment for researchers and developers to create solutions to the greatest health challenges facing Californians. The May revision includes 141 million in opioid settlements funds over 4 years to support naloxone distribution project. This further supports the governor's proposal in January of 93 million. I also wanted to let you know that we are continuing to monitor legislation, governor's modernization plan. Currently, there is no language available for the modernization plan. However, the governor's May revision proposes an allocation of 20 million for the Department of Healthcare Services to implement the modernization plan. We are hoping to see language in the next few days regarding the governor's modernization plan so that we can provide more information to you. Also, as the chair mentioned in March, the commission heard presentation from staff regarding the Children and Youth Behavioral Health Initiative and the role of the commission in administering a portion of the initiative. As you recall, the commission approved the expenditure of funds for its portion of the CYBHI estimated to be approximately 150 million. Concerns were raised during the March meeting about the community engagement efforts for this program. The chair and asked staff to work with a vice chair and DHCS to better understand the community engagement process. Over the last few months, staff worked with the vice chair and Autumn Boyle from Department of Healthcare Services to better understand the process. And today we have Autumn Boyle, Deputy Director of the Department of Healthcare Services with us, and she will provide the commission with an overview of the community engagement activities for the CYBHI. I'm going to go ahead and turn it over to Autumn now, and then I will resume and go over the commission's internal budget after Autumn has spoken.
Great. Good morning, everybody. So glad to be with you. My name is Autumn Boylan with the California Department of Healthcare Services. I oversee the department's work related to the Children and Youth Behavioral Health Initiative, which includes multiple work streams to address the emerging and existing needs of young people in the state of California. So lots of work is underway. We are have regular webinars and updates that are provided, and the next opportunity for a more in-depth overview of what's happening with the Children and Youth Behavioral Health Initiative will be on June 9th. We could drop a link to the registration in the chat, but encourage folks who want to know more about other work streams to check out that webinar and updates on kind of what's happening across the initiative. Today, I wanted to share a little bit of background based on your request about some of the work that we've been doing with one of the particular work streams, which is the granting initiative to scale evidence-based and community-defined evidence practices across the state. So I'm going to share just a couple of slides with you today to help answer some of your questions, but also we'll do this quickly and happy to take any questions that you have after today's presentation as well. So just a little bit of background, and not to go into too much detail here, but the work stream is part of the overall Children and Youth Behavioral Health Initiative, which, as you know, is a $4.7 billion investment in youth mental health to increase access for young people across the state and to intervene earlier to provide opportunities for youth to get the help that they need before their issues escalate to a crisis point. We really want to kind of address the needs of our youth, take pressure off of the overall delivery system, and make sure that there are opportunities through multiple venues for youth to get the help that they need. That includes also, of course, parents and caregivers and support for families as well. As part of this work, we are scaling evidence-based and community-defined practices through a series of grants. And there's $429 million dedicated to this particular work stream that will be funded through these grants to communities across the state to really expand access to evidence-based interventions and community-defined evidence practices. We went through a fairly rigorous and comprehensive process to select the practices that we are scaling through the granting initiative. We convened an expert panel think tank of members from across the state, including representatives from multiple sectors: education, healthcare services, community-based organizations. We had folks representing large payer systems, hospital systems, behavioral health providers from across the state, as well as representatives from the California Reducing Disparities Project, academia, and others to help inform this process. In the think tank, we really focused on identifying what is the strategy that we want to use to scale these grants. What is the focus area? Who are the populations of focus? What are the outcomes that we are driving towards to really meet the objectives of the Children and Youth Behavioral Health Initiative, which was really founded in, and even in the statute, says that we'll scale practices that will have an impact on racial equity and address system issues and really be data driven and collect data on outcomes. So I'm summarizing and paraphrasing there, but even from the beginning, there's really this focus on equity in this work. So we convened the think tank to help inform that work. We also convened a public working group and that had over 50 members who participated in a process to select practices. Through that effort of the two groups, we reviewed over 100 different practices that were recommended by the community across the state of California and generated through stakeholder input. That also includes parent and caregiver groups, youth focused and youth-led organizations, and really trying to center, the population that we're trying to serve in doing this work. and went through this, very extensive process to get where we are today. Many of you, I know, were a part of that process, and we thank you for your efforts. The commission was also represented in our work group, and so just really do appreciate, the opportunity and feedback that we got through this process to help shape the work. We wanted to, through this process, what we heard from our community partners is that we want to prioritize 3 primary outcomes. So we want to increase protective factors for children and youth by scaling practices that have measured improvements for well-being for children, youth, parents, and caregivers. We also wanted to make sure that we're building capacity of the system to provide access, integrated services, and uptake of those selected practices across the state, including in non-clinical settings. So not just in the clinic walls, the 4 walls of the clinic, but also really focused on the community, really focused on upstream services that are very much in the categories of prevention and early intervention. We also wanted to support practices that could be adapted or normed with populations of focus, as we recognize that not all evidence-based practices are really evidence-based for all populations that they are meant to serve. So a lot of times the research base is not inclusive of a diverse demographic. And so we recognize that and want to be able to account for that in some of the work that we're doing here. We really, heard clearly from our partners and are committed to having an equity-driven approach that will impact and reduce disparities across the state by providing access for marginalized communities and for children and youth who are unserved, underserved, or not appropriately served in the traditional behavioral health delivery system. We also incorporated youth and family voices, as I mentioned, are focusing on really those upstream practices that will help to prevent escalation and need for kind of those higher impact services in terms of the system. And we want to make sure that we're providing access to timely care in communities that are accessible and high quality and appropriate for communities as defined by the communities. And really focus on destigmatizing community support and thinking about how we make sure that the right type of care is made available to children and youth and families that need it. And of course, having a data-driven approach. So part of all of this will be to collect data from all of the grantees and to share that data publicly so that we can demonstrate the impact of these evidence-based and community-defined practices in terms of the overall delivery system. The populations of focus that were identified through our community engagement process included those that are the focus of the California Reducing Disparities Project. So making sure that we have practices that are specifically appropriate for African American or Black community members, Asian Americans and Pacific Islanders, Latinx communities, LGBTQIA+, and Native American populations, as well as youth who have justice involvement from low-income communities, and youth with physical, intellectual, or developmental disabilities, refugees and immigrants, rural communities, non-English speakers, those experiencing housing insecurity, and children in the foster care system. We published a grant strategy overview document that is a comprehensive overview of everything that I am sharing with you, and it's linked in this presentation so that you can take a look at that if you haven't seen it previously. Ultimately, what we heard from our partner organizations is that there are many areas that we need to focus on in order to achieve the outcomes that we set out to achieve. And so what we heard is that we wanted to really focus on practices in 6 primary areas. So, and this slide kind of shows you the timeline for when those service RFAs will be released. So we already released 2 out of the 6 rounds of funding. The first round was focused on parent and caregiver support and training programs. That RFA was released in December. We initially had planned to make award announcements by the end of April, but we got a lot of applications, and given that it's the first round, we wanted to make sure that we're making the right decisions. So it's taking a little longer than anticipated, but we plan on getting those award announcements out by mid-June. We released the second round RFA focused on trauma-informed practices and programs, and those applications closed in April. We have not yet released any additional RFAs, but are preparing to do so. And part of that preparation is really the work that we are doing with the Mental Health Services Oversight and Accountability Commission with Toby's team to make sure that we are getting right the scope and impact for rounds 4 and 5, which are focused on youth-driven programs, specifically peer-to-peer support programs and youth drop-in centers, as well as early intervention programs. And I will say, in the early intervention, really focused on first episode psychosis and coordinated specialty care programs. And we had the pleasure of joining the commission in a site visit last week at the UC Davis Coordinated Specialty Care Clinic, which was really illuminating and eye-opening, and good work is being done across the state, but more needs to be done. And so investments will go there to really focus on early intervention to make sure that kids are getting the care that they need before that crisis point, as I said. In July or August, we will release an RFA and grant strategy that includes scaling community-defined evidence practices specifically. So throughout each of the other 5 rounds, there is built into the RFA process an opportunity for people to request funding for community-defined evidence practices in each of these categories, and that is true. And we did get some applications that are still under consideration for community-defined evidence practices in rounds 1 and 2. Round 6, however, will focus exclusively on a strategy for scaling community-defined evidence practices. And we're working with the California Department of Public Health Office of Health Equity to really think about what that strategy should look like. And we're looking at kind of the system at large to better understand how we can maximize not only the funding that we have available, but think through strategies for scaling these practices from a system and policy level as well. So some additional work being done there, but that's kind of our early thinking. So just a quick overview, you see in pink in the middle here, some of the specific practices that are included for rounds 4 and 5, which is the focus of the work that the commission will be doing. Youth-driven programs specifically include drop-in centers such as the Alcove model, as well as other practices that are being vetted around fostering healthy futures for preteens, peer respite, and the TIP model, which is the transitional services model. And then for round 5, focused on early psychosis services, specifically coordinated specialty care, but also other programs, including Family Unitas, RAP, and the Blues program. The interagency agreement that we are finalizing with the Mental Health Services Oversight Accountability Commission really outlines the grant administration activities that the commission will lead for rounds 4 and 5, and specifically includes their role and expertise in continuing the work that the commission has already done and are really experts in leading the work around expanding the Alcove model and coordinated specialty care for first episode psychosis. So we really recognize that in these 2 grant rounds specifically, the commission has done a lot of work in these areas and has the expertise to lead the state in these efforts. And so that's the scope of what we are working through in the final details with the commission. I'm sure that Toby and the team have shared this with you previously, but through this partnership, the commission will leverage existing contracts with Stanford and UC Davis to provide technical assistance to grantees who are expanding the Alcove model and coordinated specialty care respectively. And we are finalizing the details of the interagency agreement now. So hopefully that answered some of your questions. I know you probably have more, but wanted to just give you a quick overview, and I'll stop there and see if folks have questions or see if anybody from the commission, Toby, Jeff, or any of your team has anything that you'd like to add.
Thank you, Autumn. The commission is happy to be collaborating with DHCS on this very important program, which reflects the governor's strong commitment to children and youth mental health and in improving access to care for children and youth who are from Black, Indigenous, and people of color, BIPOC, and the LGBTQ+ IA communities. At this time, I would like to invite Vice Chair Alvarez to say a few words about the Children and Youth Behavioral Health Initiative community engagement.
Thank you, Chair Madrigal Weiss, and good morning, everyone. I want to take this opportunity to thank Autumn Boylan and provide her and our commissioners, as well as our audience, just a short summary of our previous discussions to remind folks where we've been. First, I want to re-emphasize how historic the Child and Youth Behavioral Health Initiative is, not only for young people in California, but really for the leadership our state is providing to states across the country. Our work to address the crisis impacting young people, and in particular, young people of color and LGBTQIA communities, is of highest priorities. And this initiative has offered an opportunity to work and to create a partnership between the commission and the department in new ways. This is especially true as we consider that the CYBHI is a $4 billion one-time investment, while the crisis of our young people is going to continue. Ongoing collaboration will be critical as we work to sustain initiatives that are funded by this money, and that we work to strengthen availability of services in the community, that we're supporting children from infancy to adulthood, and that we uplift community-defined healing in our systems change work. Earlier this year, as a reminder at our March Commission meeting, when this collaboration was announced, there were a variety of concerns raised by our stakeholders that I believe were addressed today by Autumn's comments. I want to thank Deputy Director Boylan for being with us. Having DHCS representation at this commission meeting is a clear indicator to us all of the dedicated willingness to partner and work together, but also of the work ahead that will further emphasize that partnership. To recap, generally, the concerns expressed were as follows. There were questions that arose around the process that led to the collaboration, with an interest in greater transparency around that process, and specifically about the commission's role in round 4 and 5. Again, I believe the deputy director's comments addressed that process and the work ahead to distribute rounds 4 and 5. Second, we heard some concerns around the important opportunity to uplift community-defined evidence practices. And although CDEPs were mentioned on the outline and in the slide presentation, the comments that we heard expressed concern that they were not called out clearly enough. Thank you again, Deputy Director Boylan, for addressing the importance of CDEPs and how they are prioritized in rounds 4 and 5. And then finally, we also heard concerns or questions around eligibility for applicants, with concerns that rounds 4 and 5 were limited to models like Alcove and coordinated care clinic models, respectively. While yes, the commission has tremendous experience with these two models, what we heard from Deputy Director Boylan today is that they are absolutely eligible, and so are additional programs and initiatives. So we have worked with Autumn to be at this meeting to address that collaboration with the commission and to provide this program overview in response to the feedback that we received by our public. We look forward to continuing to have her with us as we work together to keep the public informed about the services that impact their lives and their organizations. Thank you.
Thank you, Vice Chair Alvarez. Again, thank you, Autumn, for being here and for joining us. At this time, I would like to welcome back Norma to provide an update on the Commission's 22-23 expenditures. Norma, please go ahead.
Thank you. And I just wanted to apologize to Autumn. It was a long day for us here yesterday, and I called her Boyle instead of Boylan. So sorry about that, Autumn.
No problem.
All right, in front of you today, Commissioners, is the budget for May. Includes adjustments that have been made since January, as well as the May revision increases to our budget. Under the personnel item, we were successful in requesting 2 positions for our IT and security unit. We've had increased workload for the unit because of our data work, and also being in our new building and not having any other support from another department. We have all of the IT responsibilities ourselves, so this will help us keep our environment secure. We also had additional salary savings. We are continuously recruiting for our vacancies. Some of our vacancies are more difficult to fill than others, especially in our research team. And so we had more salary savings this year. And we've made some adjustments in our budget and distributed those funds to some of our other initiatives. Under core operations, again, like I had mentioned earlier, our IT costs have gone up. And we shifted some of our funds from our salary savings to cover some of our IT additional costs this year. We also spent more in communication activities this year and moved some of our salary savings to cover our communications. For innovation, I asked for approval for $100,000 for an innovation summit this year. And so we have those funds set aside. We're trying to work to find a consultant.
Sorry, Norma, excuse me. Madam Chair, I would like to, in this particular topic, I'd like the commission to consider raising that original $100,000 budget item to $500,000. I'd like a moment to explain the logic behind that, if I could.
Please.
Since that original idea was launched in January, I've been involved in a bunch of work with some other commissioners and with the staff and in conversations with a lot of other organizations to explore this idea about an innovation summit. And I believe we've stumbled across some huge opportunities and also some real threats that I think need to be addressed on a larger scale than what we've been talking about. And without going into a lot of the details, I think that what we're really exploring is this idea that there is a huge gap that exists between the public and the private sectors, and the private sector is investing billions of dollars in new innovations, which the public sector is not seeing. And likewise, the public sector is not really organizing itself very well to give access to the private sector. And there are a lot of other issues between there, but what ends up happening is there's a huge equity gap that exists. And I believe there's an opportunity to close that gap. And if you close that gap, we could take a leadership position to facilitate and unlock the potential of billions of dollars of additional money that could support the work that we're trying to do, that we know is not, we're not doing the work adequately to meet all of the needs. And so there's that. And then what's really emerged in the last couple of months that's changed this landscape that we're all seeing is the artificial intelligence, and AI presents certainly opportunities for innovation, but I think it represents a huge tsunami. We've seen this one tsunami hit us through COVID, and I believe there's another one behind us that is going to take all the problems we have and take them up to another level. And we've really got to start grappling with that issue as well. So I've been working with some other organizations in addition to our own, even in some other states who are interested in seeing California lead a summit effort, and with some private organizations and some nonprofits who are now gaining interest in a mental health summit. And so we're talking about potentially a May 2024 Innovation Summit. But to lead that effort, I'm recommending that we invest $500,000 in that, and that would be looking for additional matching funds of at least that amount from those organizations to do this on a much larger scale. Thank you very much.
Thank you, Commissioner Carnevale.
Chair, if you'd like, I could work with Commissioner Carnevale. We anticipate to have additional salary savings this year because we still have some vacancies. And so if the commission approves the additional funding, I can work directly with Commissioner Carnevale on this.
So I would appreciate that. I would like some discussion. Any questions or comments from my fellow commissioners around this?
I have just one question.
Please.
And you are the businessman on the commission, Commissioner Carnevale, but is there any way we can get just a little bit more specificity of some of these ideas?
I think the idea is that our role as the commissioner is to catalyze those ideas from the public and from a variety of organizations. So there is on the order of $2 billion annually that is being invested by the private sector and venture capital backed companies that are investing in a whole range of technologies, from early identification to early intervention to treatments after the fact that produce new and innovative outcomes that are both more cost effective and are hopefully have a higher level of evidence accomplishment. So that's the objective on the private sector. On the public sector, we all know the complexity of the system really requires companies to go county by county in order to try to in order to offer what they are trying to bring into the system, which makes it very challenging for small venture-backed companies to do. And so I think we also have to look at our own side of this partnership and try to figure out how to make our needs more public and available and give greater access to those being served. And those are just examples of what we would try to attempt to do at this Innovation Summit, where we would expect to bring together hundreds of different parties who would bring all of their ideas to the table, and we would vet those to figure out how we can best leverage those. And the commission, I think, is serving its role as the a leader in innovation of mental health and in catalyzing that large conversation. Does that help?
Yeah, thank you, Commissioner Carnevale, and thank you, Commissioner Mitchell, for the question. Toby, this isn't the first time we've heard about the Innovation Summit, right? This is historically, we've talked about this. So Toby, I'm going to ask you to give us just some background on that history again, please.
Thank you very much. And I saw Commissioner Danovich also wanted to weigh in. So, when the commission really began to support counties on the innovation component back in, I think it was 2017, 2018, we had organized an innovation summit with about 300 community members. We partnered with some of the tech sector, philanthropy, community organizations, and others. And the goal at that point was to sort of jumpstart counties' support for innovation. Many counties had not been spending their innovation funds. There was hesitation and uncertainty about the process, the definitions, and so forth. Over the past 5 or 6 years, we have been supporting counties to co-invest innovation funds into multi-county collaboratives under the argument that if 5 or 6 counties co-invested and identified a successful strategy, it would be more likely that that innovation could scale statewide. We wanted to see, and we wanted to help counties share risk associated with tackling new challenges. Commissioner Danovich and Commissioner Boyd took a lead on that. We engaged a consulting organization to come in and talk with us, talk with commissioners, with staff, with counties, with community organizations, with peers and others about what's working and what's not working and how we could streamline this. Among many proposed modifications to our process and other reforms was this idea of bringing together a broader cross-section of California, reflecting academia, research, the tech sector, corporate sector, out of recognition that the private sector is doing a lot in innovation, but it isn't necessarily tapping into or addressing the needs of the public sector. And so in addition to the funding that is available in the private sector, we really wanted to continue to elevate the innovation component of the Mental Health Services Act in ways that could leverage the strengths of the different sectors across California. And so the vision has really been around 3 core opportunities. One is to celebrate where we have come in terms of innovation and share the progress that has been made. And I'll just highlight a couple of these. Solano County did an innovation plan that increased access to care for underserved communities by as much as 300%. You have authorized us to provide funding to scale that strategy, and there are as many as 40 counties working to learn from what Solano County did. The early psychosis project that we kicked off with a $100,000 proposal grant, sort of a planning grant, led to I believe 6 counties co-investing about $8.5 million, and that project is now at about $50 million. And with the CYBHI funds that you just heard a presentation on being eligible to support the expansion of early psychosis strategies, we think there's an opportunity to, over time, get to a place where all Californians have access to effective evidence-based care for early onset of psychosis. So 1, celebrate the progress that we've made, really highlight and share the impact that innovation has had. I think this is important, given the governor's proposal at the moment would do away with innovation. And what we're trying to do is shape this recognition that innovation is a tool that we can use to address some of our most pressing challenges. So that the second goal really would be to have this community dialogue about what those most pressing challenges are. And the third would be to recruit traditional and non-traditional partners to really deploy both public sector and private sector innovation investments in ways that can be responsive to those really pressing challenges that the governor's highlighted. And so our original proposal was $100,000, recognizing where we were, but I think in conversations with Commissioner Carnevale, as he's pointed out, if we really want to tap into the opportunity that the private sector brings, and we need to scale this up a little bit. And so, that's where the proposal comes from. But again, I want to point out that Commissioner Danovich was very engaged and playing a leadership role in those early conversations.
You answered, your this item. Maybe I'm the same thing, yeah. Press and hold, Al, press and hold. But that there seems to be a natural correlation between that bullet item and what Commissioner Carnevale was just talking about. And then lastly, I'm very interested in this. I had a colleague who recently was talking about the implications of AI in behavioral health and sat in on a presentation in which some of the largest corporations in the world, i.e. Nike, were talking about AI. And then they talked about healthcare and that was the next tidal wave around AI. So to be part of that is very, very exciting. So if there's a place where a CBO, non-government organization could be involved, I would be very excited to do so.
Highly supportive of this initiative, and if the time is right, I would make a motion for us to go ahead and fulfill this proposal.
Thank you, Commissioner Danovich.
I would second the motion, Gordon.
Thank you, Commissioner Gordon. We will, we just need to work out the process correctly to make that motion. And I just want to acknowledge Commissioner Brown, please.
Thank you. Just before we vote, could you just clarify again what this expanded 400,000 would be for? Is it essentially to subsidize or to underwrite the expanded summit itself? And so we would open it up to more people and organizations and so forth. And that's what you're proposing.
So the answer was yes. Toby, did you want to say something? Please.
Yeah, I just wanted to clarify in terms of the timing. So Deputy Director Pate was laying out kind of some modifications to the budget. Want to remind 3 times a year, we present our budget publicly at the beginning of the year when we're seeking your permission to authorize us to pursue an expenditure plan. Typically, there's a mid-year report out. This is our very close to the end of the year report out. We wanted to give you an update because there are some changes that we want you to approve as we approach the end of the fiscal year. And again, these are changes from what we had proposed back at the beginning of the fiscal year. And so the amendment, I guess, to Norma's proposal, which is laid out in your packet, would be to increase funding for the innovation from $100,000 to $500,000. But Norma, if you could kind of continue the presentation, and then if you have questions about the overall budget, we'd be happy to answer any of those. And we do this because first, the legislative process approves our budget, but the law and our rules require you to monitor and be aware of the dollars that are spent and for us to have your permission to do so. And this is how we feel we can be most efficient in giving you an overview of a budget that is, in excess of, in some instances, $100 million. So thank you for your patience as we walk through this.
Please go ahead. All right, thank you. All right. And then continuing on the research side, there was adjustment in our budget for the research funds. We had additional activities for our PEI project. And then we also started our new project for the firearm violence prevention. And so there was a little bit more to our research this year for our community engagement for these processes. And so we've adjusted our budget for research. We also had budget directed items for our California Behavioral Health Outcomes Fellowship Project. We received $5 million. We released an request for qualification for the project and awarded $5 million to the University of the Pacific. That project is underway. And then we also received for our SB 465, which is our evaluation of FSP outcomes. We received one position and 400,000 ongoing funds to evaluate FSP programs. Those we're currently recruiting for that position, and we've also have funds today that we'll be asking you for to approve to work with a contractor to implement the outcomes and evaluation project. The MHSA evaluation and admin line item, we still have a remaining 15 million for that item. Those funds are spent over 5 years, so you'll continue to see that, but we will draw from that over the next few years. As far as our local assistance, for the Mental Health Wellness Act, we had with the Mental Health Wellness Act, with the old language, as you recall, we had language that just allowed us to hire staff for the mental health wellness program. We've modified that language. We worked with the legislature and the administration, and that language has now been modified and it's a little broader now. But we did have about 16 million funds that were unspent from that project. We worked with the administration, and in the May revision, the administration has agreed to reallocate those funds for additional empath programs. They were very impressed with the empath programs, and we received more applications than we did funding. And so the administration has approved additional funding for those programs up to 16 million. So we will, if approved today, we would be allocating those funds to those applicants that we were not able to fund because we didn't have enough funds in our budget for those programs. And also the Mental Health Services Act, we are on track with our Mental Health Services Act program. And our community advocacy programs, we have 6 RFPs that we'll be releasing the next year, and we'll be coming back to you with proposals for those programs. And for our Children's Behavioral Health Initiative, we heard from Autumn, and we've continued to work with the Department of Healthcare Services on that initiative. So today, I'm asking for expenditure authority for additional funding for our strategic planning efforts. We need an additional 75,000 for our strategic plan consulting contract. And then we also are planning to engage with our communities on our strategic plan and other activities, and have consulted with UC Davis on a contract for community engagement. We haven't finalized that agreement yet, but we're still continuing to work with other organizations to see how we can improve our community engagement efforts for all of our projects and specifically the strategic plan. We also have an additional 50,000 for our communication activities. And then, as I mentioned earlier, our full service partnership program, we are in the process of entering into agreements with Healthy Brains and third sector partners so that we can implement our FSP evaluation. And then for schools mental health advocacy, we are asking for up to 90,000 for a youth partnership engagement event, and then 100,000 to conduct the Breaking Barrier Symposium. In addition, to the CYBHI funding that we will allocate out to communities, we will receive 15 million for technical assistance and for staff to administer the program. So we'll be able to hire some limited term staff to help with that project. And then we would enter into an agreement with UC Davis and Stanford to further the technical assistance for the ALCOVE program and the early psychosis program. And that completes my presentation for today. If you have any questions, happy to answer your questions.
Thank you, Norma. So at this time, I would like to invite commissioners to offer comments or questions, other than those comments or questions that we already talked about regarding the innovation expenditure. Seeing none here in the room. Seeing none online. At this time, members of the public may request to make a public comment on agenda item 6 by clicking the raise hand button on your computer or the app, or if calling in by phone, *9. Once the public comment period for this agenda item starts, we will close the public comment queue. So please make your request to comment now. Are there any public comments? Please raise your hand now as the queue will be closing. We would ask that you please limit your comments to 3 minutes or less. Mariani, please open the line for public comment on agenda item 6. And let's start with comments from within the room. If we have any.
We don't have any comments in the room. We have 4 comments online. The first comment is Hector. Your line is open.
Thank you. My name is Hector Ramirez. I'm speaking for myself. I'm a resident of Los Angeles County and a consumer of Los Angeles County Department of Mental Health, which has served almost 250,000 people with mental health conditions, many of which have been served through Mental Health Services Act money. I'm in shock at this conversation of how easily money was dealt and just handled taxpayer money that is meant to serve some of the most vulnerable and fragile people like my peers who are out on the street dying from fentanyl or in prison because they can't access appropriate services or even basic disability accommodations by MHSA funded services. It really concerns me, the partnership that you have with GHCS for our children, because I love the work that they're doing, but this commission has a long track record of really being discriminatory towards people with disabilities, towards Native American Alaska Natives, towards our Two-Spirit communities, and the fact that it's moving forward with that same type of foundational, it worries me about the danger and the harm that they're going to do to our youngs in our system of care, just like it has happened to the adults in their system of care. And I say this as a person who has been very active with this commission and has seen the retaliation when trying to get accommodations or even mentioning the lack of accommodation to the executive director. So I know that discrimination happens, not only to the individuals who bring up the issue, but from the executive director that currently runs it, and even to the organizations that we volunteer, like Call Voices. So as somebody who's in LA County, I worry that the lack of accountability, the lack of oversight, particularly how money is giving out, given the fact that so many of my peers are dying on a regular basis. And we come to this commission asking for help, and it continues to fail the most marginalized people. There's so many conflicts of interest issues happening within the commission about the people sitting around the board and the contracts that are going up, particularly around Painted Brain in LA County, that those conversations need to happen because it creates significant disparities. As the Mental Health Services and Oversight seeks to reduce the disparities that Native American, Alaska Natives, Latino, LGBTQIS individuals, Black and other equity-seeking populations have been trying to get. This particular body has created significant disparities within our community, particularly for those of us, that have additional disabilities. And so I'm really concerned against, with the proposed budget and the way that it happened without proper justification or community input, given the significant disparities that my peers have. And I know that for a fact, as somebody who's not paid or does this voluntarily, watching all of you sit in this beautiful room in this very expensive hotel, surrounded by my peers out in the streets, who are dying from opioid, drug abuse, trying to get services that the Mental Health Services and Oversight Commission promised voters that it would fund almost 20 years ago when it asked for this voter approved measure to take taxes to pay for the services. Now Governor Newsom is going to do the same measure to try to bring up the same issue, and yet, we're still dealing with the compounded ethical and problematic issues that this commission has created for all of the people of California that were trying to look for help. The law was good, but it just never happened because this commission really never had it. And I feel bad because I know more of my peers will die tonight, while somebody's pocket gets bigger after they vote on this.
Thank you, Hector.
Next, we have Richard, your line is open.
I believe that the commissioners should make a priority with the savings from the budget for not being spent because of no hirings or lack of hirings or retention issues for peer fellowship positions to help the commission to make sure that there is transparency, that the numbers are being reached, that they're supposed to be reaching with the contracts with the counties. They're being funded with MHSA funding, and that data reporting is being done. I'm surprised how much is being contracted out for research and evaluation when it could be used for better purposes such as peer programs or meet the unhoused needs community. Part of the intent of the MHSA Act was to serve the SMI unhoused community. Where is the transformational change in that? It seems like way too much money being spent on that. Talk about misguided priorities. I am a consumer. I know what's happening in my communities. I know consumers are dying in my communities. That's why I do work with Miracle Friends, because of a blind, traumatic brain injury individual died in the streets in Northern California with no help, no support, and failures on the part of the county. I'm shocked by it, truly disappointed. Thank you.
Thank you, Richard.
Next, we have Mark, your line is open.
I have a question, and the question is, for the Innovations Summit, will consumers be involved in that, and when and where will it be, if it takes place? And do they have will there be accommodations for those consumers to be there at the meetings? That's my question.
Thank you, Mark.
Next, we have Steve, your line is open.
You are unmuted. Hello again, folks. I wanted to bring up something around the budget here. I noticed the HHS Innovation Accelerator Initiative. We talked about that. And there's a concern here. It talks about public-private partnership to create the environment for researchers and developers to create solutions. And at the same time, we're talking about, in the governor's proposal, possibly eliminating innovations through you guys And those innovations go through a stakeholder process in the counties, including consumers and family members. And my experience has been, yes, I mean, I'm not saying there shouldn't be a place at the table for those researchers and developers, but they don't always know what questions they should be asking and what problems they should be answering. Community often knows the very best, and we need to have a wonderful discussion involving all of those people. And it was worrisome to me that they seem to be moving away from asking people who live the life, who know the issues, and towards asking people who are regarded as experts, probably from academia or the corporate world. And they're supposed to provide the solutions. It's been commented upon by more than one person that generally in our society, we're moving more and more in the direction of asking the experts and not asking the people who live it. And I'm very much concerned, and I thought I would point this out. Who are the custodians at this point? Perfectly or imperfectly, you are the custodians, the MHSA is the custodians of having both ethnic communities, LGBTQ, clients, consumers, mental health, family members, etc., speak up and be heard. Thank you.
Thank you, Steve.
And that was our last public comment.
Thank you, Mariani. Now that the public comment has closed, I would entertain a motion that the commission approves the fiscal year 2022 to 23 updated expenditure plan as modified by increasing the innovation expenditure from 100,000 to 500,000 and associated contracts.
Chair Madrigal, I so move that motion. And also just to the comments that were made by during public comment, there was a commitment to make sure that peers and family members are involved in this process and on the Innovation Summit. So you can count that to be on our agenda for the CFLC when we meet, and then opportunities for more involvement from our peers and family members. I just wanted to share that while I made the motion.
I greatly appreciate that, Commissioner Tamplin. Thank you for making a priority there. And we also have your motion. Do I have a second motion? Thank you, Commissioner Mitchell. We have a first and a second to approve the motion. Are there any comments or questions from commissioners?
To Commissioner Tamplin's point, so how will we be informed or assured? Because Mark did make that point, like, is this summit going to include the public or?
I think what Commissioner Tamplin says is that she will make it a priority to have it on the agenda for the committees, and they will be discussing it. And that will be informing also as we plan out the summit.
Okay, thank you.
Is that my correct interpretation?
Yes, definitely. We have a good representation, and of course, we'll make it, put the word out more around the CFLC meetings and the addition of this item, because it is a high priority. And as some said, again, with everything going on with the modernization and talk about innovation, I think it's really critical that our peer and family voices are at the table. Thank you.
Thank you.
And I'll lean on your offset.
And Commissioner Rowland, please.
Well, at this point, I'll just say ditto, because everything that I was going to say has been said. I completely endorse what my fellow commissioners just articulated, and it speaks to the commission's commitment to the kind of transparency that was talked about in public comment, and the commission's ability, I'm restating myself, to be an expert convener in bringing constituents from all across our communities together to talk about this very, very important issue.
Thank you, Commissioner Rowland. Are there any other comments or questions from commissioners? I see none. Jeff, I will ask that you please take roll.
Commissioner Bontrager,
Aye.
Commissioner Boyd, Commissioner Brown,
Aye.
Commissioner Bunch. Commissioner Carnavale.
Aye.
Commissioner Carrillo. Commissioner Chambers. Commissioner Chen.
Aye.
Commissioner Cortese. Commissioner Danovich. Commissioner Gordon.
Aye.
Commissioner Mitchell. Commissioner Rolette. Commissioner Tamplin.
Aye.
Vice Chair Alvarez. Chair Madrigal Weiss.
Aye.
Madam Chair, the motion passes.
Excellent. Thank you.
Thank you, Commissioners.
Thank you, Norma. Next, we will move on to Agenda Item 7, the 2024 through 2027 Strategic Plan Outline. In January, the Commission reviewed progress made under the 2020-2023 Strategic Plan, challenges in accomplishing some of the goals, and identified 4 priorities for 2023: data, full-service partnerships, impact of firearm violence, and the development of the 2024-2027 Strategic Plan. Commissioner Carnavale was appointed as the lead commissioner for the 2024-2027 strategic planning efforts, and approval was given for a consultant to be selected to support the development of that strategic plan. In May, Boston Consulting Group was engaged to work with internal and external community partners to collect perspectives on the commission's projects, to assess the commission's model for catalyzing transformational change, to develop a decision-making framework to guide the transformational of mental health care, and provide an outline for the new strategic plan. We will hear from Commissioner Carnavale and the Boston Consulting Group. At this time, I would like to invite Commissioner Carnavale to say a few words about this work.
Thank you, Madam Chair. I have a history of having worked with BCG before. So I'll just start there and talk a little bit about this work and why we've moved in this direction. BCG is one of the preeminent consulting firms in the world, and they hire the best and the brightest, and they do work both for large corporations and for government. And I've had the pleasure of working with them on a number of initiatives in which they have provided pro bono work that's been very important. One with a dyslexia report that they worked on for the state of California that showed that it's costing the state $12 billion a year by not addressing young children's learning needs. And they were extremely involved in the more recent paper that HHS commissioned, the Breaking Barriers organization, to convene experts to recommend an integrated system of care for children and youth in California. And I think that's really taking on a life of its own. So it's been important work. And in this context, I asked BCG to give us a proposal, and they gave us a proposal with a very generous offer of discount in order to support this work, because they understand the important work that the commission is doing. And I appreciate that consideration. I think the general idea here is that the commission, I've talked to many of my fellow commissioners, and our frustration in our thinking about our meetings and the work we do are that we do a lot of important work. We pass a lot of important bills related to funding, a lot of important work, and yet we sometimes struggle to understand the broader context of that work. And so that's part of what this current strategic plan is going to attempt to do, is to create more of a framework that allows us to understand the context of the impact. We know that we can't address all of the issues that we would like to address because of funding limitations, but it would be very helpful to understand what impact we have and what is the basis upon which we can understand our decisions and our future priorities. And so BCG is going to lead us through a process in that. What I wanted to emphasize about the process is, by design, this is just the beginning. We're not debating all these issues today, but we are exploring the issues. We're trying to make sure that we've gathered input, that we have different perspectives, that we understand the topics that should be debated through this process, and that we'll have a lot of opportunity for more input individually as well as the community throughout the course of the next 9 months. So this is not the beginning of the end, but the end of the beginning of this process. So I'll leave it at that.
Thank you so much, Steve. Let me just make sure that my mic is on. Can I get a thumbs up from someone? Thank you. Over here too. Great. Can you hear me? Fabulous. Wonderful. So at the risk of tripping ourselves, I'm actually going to try to lead this as a little bit of a facilitated dialogue, if that's okay with the commission and the members of the public that are here today, and kind of move around the room just a little bit. My name's Nicole Bennett. I'm here with my colleague Anna Silk. We're both from BCG. BCG stands for Boston Consulting Group. We are not from Boston. We are not even based in Boston. It's an old name, but so we'll call ourselves BCG. We're actually from here. Anna's here from here in Los Angeles. I'm originally from Los Angeles and now live in Oakland, California. I'll do a short introduction for myself and our firm, and then what I'd love to do is just jump in with you all. As I mentioned, Nicole Bennett. I lead our public sector work on the West Coast. I have a long history of doing work in the behavioral and mental health space, both on the provider side and also working with state agencies in other states as well as in California. And then additionally, Anna and I were both very much involved in the paper that Steve mentioned that Breaking Barriers put out for HHS on CYBHI in particular. It's a deep area of passion for me. I've also led literally hundreds of projects for strategic planning for all different types of organizations. My work tends to be in the public sector and social impact space, but have done quite a bit of work in the corporate space as well. Anna, want to introduce yourself a little bit?
Absolutely. Pleasure to be here with you all today. I'm Anna Silk. As Nicole mentioned, I'm a principal in our Los Angeles office, which is just a couple of blocks away, walked over prior to this. My work also primarily focuses on supporting state and local government clients in capacity building and really thinking through how to drive strategic outcomes for the long term, in addition to the critical and important work you all are doing today. My work also particularly focuses on emergency response and crisis contexts, so everything from vaccine delivery to the homelessness crisis in Los Angeles are topics top of mind in addition to the mental health crisis in California. So it's a pleasure to be engaging with you all on these topics today, and we're excited to create some open dialogue on all the work you're doing and what's to come.
So Anna and I are two members of the team. We represent a bigger team, some of whom are in the room in the back there, but we also represent a broader group of experts that we can bring in and leverage both in the healthcare space, in the behavioral health space, also in the public sector space as well. So kind of the full breadth and weight of our firm is behind this project, and we're really excited to engage. As Steve mentioned, as we start the discussion, we are just kicking off. So our intention here, because, and we love the transparency of the commission and the way that the intention is to engage the public from the very beginning. So rather than doing this behind closed doors, this is our real opportunity to be, really immersive with you all and start the strategic planning process together. We'll have a lot of other touch points. So whether it's through meetings like this or also through one-on-ones with the commission or with the commission members, we are an open book and very available for follow-ups. And this will be, this will not be the last time you hear about this strategic planning process. We are not going to go away in a room, write something and present it out to you all. This is just our first opportunity to say, what are the success factors for this project? What do we want to see together? And what are some of the roles we should be thinking about? Okay. Any questions before we jump in? Okay, hopefully this can be a dialogue. We'll have some specific time for public comment as well at the end. And we'll be leading this through, we'll share a few slides of context, but very little. Almost all of this is geared toward dynamic discussion with commissioners. Okay, so just a little bit of context, which I think we mostly know. We do want this effort to both reflect the commission's really good work to date and the lessons learned from the last 3 years. Realize you all are in the last year of your 20 to 2023 strategic plan. So that is the starting place where we've been. And then what we're looking for here is an opportunity to really articulate how our work fits into a context that is changing rapidly. right? We'll talk about some of those ways that the context is changing, but it's changing in ways from broad, historic, and technological to more specific ways about funding in California. We just saw the governor's May revision, and there are important ways that the commission's work may need to shift and adapt in relationship to that. Most importantly, how we're shifting and adapting to the evolving landscape of mental health in California and the needs of the individuals we serve. And we want to really surface and elevate the opportunities to catalyze transformational change. So what is the role of this commission as distinct from the other providers and actors and stakeholders in the broader ecosystem of folks that are working in mental health and mental and behavioral health in California? So we want to make this a collaborative process. There will be other opportunities. We'll be engaging community partners, experts, and the public throughout. Diverse opportunities for input. The plan will be, the draft will actually be publicly released on November 30th. And then the plan would be considered for adoption in January 2022. So that's the broad timeline. We're going to do actually the bolus of the planning work actually over the next kind of 6 to 8 weeks. So you'll see a flurry of activity in this early portion as well. Okay. Couple of objectives. These are all in the packets that were provided as well, if anyone can't see the screen, but we're going to do a little bit of context setting, discuss and collect some feedback, and then get some input. Pretty basic. Okay. So what does success mean in this effort? And Anna, if you want to jump in as well, I'll cover the first 3, maybe you cover the second 3.
Fabulous.
First, design an understandable and accessible strategic plan for the commission and community partners. Understandable and accessible, I think, is really important here. So this is not just about transparency, but this is about putting together a strategic plan and a set of talking points and documents that are easily articulatable to the full range of partners that you all work with. Next, be collaborative and inclusive. So to develop this in partnership, reflecting a breadth of perspectives. And next, and then I'll turn it over to you, Anna, being forward-looking and innovative. As I mentioned, and as we're going to talk about in depth, the context in this space is changing very rapidly. We're looking 3 years out. The world looks very different today in 2023 than it did in 2020 when the original plan started. And if you think about versus 2019, when the development effort for that plan started, the world has changed dramatically. The next 3 years may bring equally dramatic changes. Hopefully, we will not have another global pandemic that leads us to the kind of crisis that we are facing today. But that said, we need to be ready and kind of future-proofed to be able to agilely adapt and respond to the changing context. Anna, do you want to cover the last 3?
Happy to. The next priority is to be very rigorous and analytical in how the commission thinks about prioritizing opportunities and thinking about initiatives for impact. We recognize your portfolio today is broad and robust in nature. And how do we continue to meet those changes in the coming years with a set of robust principles for evaluating the opportunities that come across your desk? The next is to be mission driven. As the commission has been designed to support and guide the implementation of the MHSA, how can this strategic plan and the next era of the commission continue to fully live up to that promise and be consistent with your vision, your core principles, and your mandate, many of which we'll discuss today? And then lastly, to be outcome oriented. And I want to recognize the great work the commission has done in the 2020 plan on paper and also in practice around trying to advance the outcome-led work and to evaluate progress. So this plan should help deliver transformational change, outline the steps that the commission is taking to improve outcomes, and also recognize and acknowledge the work to reduce disparities in everything that the commission is doing. So what we've done is start to begin to outline today the key components of the strategic plan. Some of these you'll be familiar with from the 2020 document, and many are, or a few are new and will evolve to reflect the changing context and the conversation that we'll have today. We're going to focus in for the discussion in the hour or so we have before open comment on 4 core topics. We're going to discuss the emerging trends, which I know Commissioner Carnevale has raised earlier in the discussion, so eager to discuss with this group. We're going to talk about how the commission really drives transformational change and what your roles are in supporting that change. We're going to introduce the concept of a decision-making framework to support and guide the investments that you make towards that transformational change. And we're going to engage on your priorities and objectives for the coming years by reflecting a bit on the priorities that you've outlined in the 2020 plan. So that's a little context for the effort before we dive in. Nicole, anything you want to add?
No, just that you'll see, actually, it may be off the screen in the room, but on for those of you online, a word that says pre-decisional on the top. I don't think pre-decisional is a word. And yet I wanted to just be very clear that none of the things on these pages are decisions that have been made in any room that anyone in this group has not been in. This is actually the way that we work is actually put things on a page and have a starting point for conversation. So as we work together over the course of, the next few months and longer, the words on the page are just a starting point and a straw man for a discussion that we want to have. So we expect you to disagree. We expect you to add. We expect to have things not be quite right because we want to shape this together. Okay. Let's talk a little bit about the emerging context and the trends in mental and behavioral health care. Some of these, we have some things on a slide that I'll talk through, but mostly this is the first place I'm going to want to open it up for conversation in the room with the commission. So number one, a few things that were top of mind for us, the increasing awareness of and need for mental health care. I don't think this is a surprise for everyone, but there's pros and cons in here. So we have really like a massive opportunity. At the same time, we have some real challenges that are increasing in our society that we need to be able to meet. One is a significant increase in public understanding and reduced stigma, right? It has changed a lot over even the last 3 years, the willingness to talk about behavioral and mental health care, the kinds of groups and the kinds of discussions that we're having as a society now are actually a positive thing that have come out of COVID-19 in some ways. But where that comes from is actually a massively increased incidence of illness, which has been obviously worsened by the pandemic, but let's be honest, was already on a rapidly increasing trajectory far beyond the pandemic. I'm sure that everyone in the room and on the phone, has heard about, knows that the Surgeon General of the United States talked only this week about, issuing the alert around the mental health crisis amongst youth and teens. Obviously, we've been talking about that. You all have been talking about that for a long time, but the awareness and discussion is at a different place right now. There are growing structural threats, right? Whether it's about poverty and a diminished social safety net, or, and about kind of continuing issues of inequity in our society that seem to be only growing worse and dramatically exacerbate mental and behavioral health issues, and a lot of obstacles for marginalized at-risk folks. So especially those folks with involvement in the criminal justice system, but also folks that are at risk for any number of issues and systems involvement. So we see very, very high overlap between folks that are involved in different systems and have a lot of need for real integrated whole person care. The next one, mental health as a result of this has been elevated as a shared priority across the state and across the nation. So that gives us an opportunity to act. There have been large investments. We just talked earlier today about CYBHI and the large investment, $4.7 billion that comes with that. But I do want to call out that a lot of the investments that have come are one-time investments. So our work as a group is to think through how to use this as a catalytic moment to be able to change those one-time investments into actually transformational change and ongoing care. One-time investment doesn't for the person at the center of this is a lifelong issue, and therefore we need to be able to serve those individuals for their lifetime and for the lifetimes to come. Public agency and community resources are increasingly directed toward mental health. And of course, we know that the modernization of the MHSA funding is out there as a change that may happen over time that will impact the commission as well. Evolutions in treatment and care delivery. So this one I think is very exciting and quite hopeful, but a growing focus on prevention and early intervention. And the care delivery model, a greater focus on integrated care, with no wrong door models that are out there, or at least that is the goal of many of the models that are out there. And that is a change for how folks were talking about this before. The innovation in diagnosis and treatment. So precision medicine is actually playing a role in this. Advances in neurology and neurobiology are playing a role in mental and behavioral health care that's very, very exciting. Now, how quickly those reach patients is a separate conversation, but there are more treatments out there. The research is happening quickly. We are learning more and more about the brain and the underlying causes of this illness. We also have an expansion of delivery models, right? The explosion of telehealth, the explosion of startups in the private sector. Now, our work is there now separating what of that is going to be most value add for the individuals in need and most value add for the broader public, and not just only serving the private sector, but also serving the public sector. And I want to call out, I don't think you can have a single conversation about mental health in California or anywhere in the country right now without talking about the strain on our caregivers and the workforce issues that are at play right now. So we have a massive shortage and burnout of our behavioral health workforce. So when you do the analysis of this, this is actually at every single level. So this is at the social worker level, this is at the peer support level, this is at the psychologist and psychiatrist level, this is at the physician level, right? So this is at every stage of kind of the pipeline. There is a very significant shortage, and we're losing our caregivers daily to burnout and other issues. We also have shifting needs for those practitioners, which exacerbates their capacity gaps. They're expected to do more and more, to cover more and more of the need, and not just as they shift towards whole person care. Now, in some ways, this is great. In other ways, it really makes it so that the job of a practitioner in that position is very challenging. We know that reimbursement rates and difficulty with billing insurers is one of the core causes. It is not the only cause. And so I don't want us to think that money is the only answer to the workforce crisis, but it is a part of it, right? You can't do it without it. So low reimbursement rates, low salaries for some of the most demanding jobs on the planet is a real challenge. And then finally, a lot of our hospitals are actually under severe financial strain. So we've got many hospitals in California, and this mimics some work that's happening across the country that are having real challenges, financial challenges, and that further squeezes areas that are less profitable to them, let's be honest. So it further squeezes behavioral health disproportionately. And those hospitals that are servicing our highest need individuals are those hospitals that are in the worst financial condition, right? Which is not a surprise to anyone, but one of the underlying causes here. What we haven't talked about yet on this page is also some of the broader things that I think Commissioner Cannavale, you mentioned around AI, around other looming threats, whether it's social media, around both the opportunity and threats of AI in the behavioral health space, how it may impact our brains, but also how biases can be written right into those algorithms, and the ways that we should be thinking about that. So let me pause. I've talked quite enough. Let me first ask about, did some of these trends resonate? But I actually want to hear from the commissioners. What's top of your mind if you are looking 3 to 5 years out about what we should be thinking about as a commission and the trends that yes, Commissioner Danovich.
Well, first, if you're going to capture the context and trends on the existing slide, on a slide, this does a really, really good job of doing that. So you've covered a lot. Most of what I would think to add is it already fits in, within these bullets or sub-bullets. There's one piece that I think is important that is worth calling out, even though it's in there too.
Yeah.
Which is really the complexity of our system.
Oh, I love that. Yeah.
Complexity of how we finance and our regulatory framework and our service delivery system. And it's a problem because it creates barriers and obstacles everywhere that we try to innovate and develop solutions. And it gets in the way of our ability to simplify and reduce things to levels that are intervenable. And so I think that also part of the role of the commission is to embrace and lean into areas of complexity. It's why we're sort of outside of government and why we're positioned to straddle the private and the public sector.
Yep.
And so I think that that's a threat and challenge because complexity seems to be accelerating faster than all the positive things like stigma reduction. But an area that represents both a threat and an opportunity for us if we can simplify some challenging areas in a way that permits sort of new and effective approaches.
Love that. I wish we had a flip chart in the room. We don't. We do have team taking very detailed notes. So let's capture complexity. But I think that you make a good point. Some of these things we've put out, even as the increase in funding opportunities actually increases complexity. And I heard you talk about complexity on two levels, right? One level is on the work of this commission and the role that the commission can play between these two things and how funding complexity can really be a challenge to effectiveness. I also know that from the perspective of the user, of the person who's trying to navigate the system, right? Complexity is a massive issue. Commissioner Rowland, I see you're nodding.
So I was going to start with again, sometimes the language is not particularly the best, but the end user.
Mm-hmm.
And it is again, unique role of the end user that the commission has some responsibility to advancing and making sure that they are not only an integrated part of the work of the commission, but also in terms of our service delivery system, that because of the nature, complexity of behavioral health in the state of California, the perspective of the end user or the consumer is oftentimes minimized, and that we provide care simply for the sake of providing care.
Mm-hmm.
Second, the unique challenges associated with workforce. While we can advance innovation, you cannot advance innovation with a workforce that is hemorrhaging human beings, and we are. And not only that, the expertise associated with doing the work of behavioral health, and then understanding the important role of diversity, equity, inclusion, and access, and that work, and making sure that community-defined practices and inculcated feature of what I describe as diversity, equity, inclusion, and access is also very called out. And then my overarching sort of perspective on all those last three is transparency. The work of the commission to advance greater transparency in the behavioral health community for constituents has to be an important feature of our strategic plan.
Thank you. I appreciate that. Very, very insightful comments on the workforce and the need for a diverse and culturally relevant workforce at the same time that we have a massive workforce shortage is incredibly important. It also is going to force us to look outside our traditional pipeline to a much broader set of folks that might be able to be in caregiving roles and professional roles in the behavioral health space. And I that is so, so important as we're talking both about workforce, and then we'll come back actually, the diversity and equity as not an initiative, but as something that must flow through the entire strategic plan and all of the initiatives in our role is something I'd like to push us on quite a lot as we go forward in the next set of conversations as well. So I appreciate you bringing it up now as well. Other thoughts on trends, on what's coming and what's impacting what our role should be? We're going to go to roles next after this.
I'll just jump in and say
Yeah.
briefly, I think we're, as best as one can look into the future, the next 5 years economically is likely to be more challenged than the last decade. And so we're likely to see more government, spending constraints, which we're already seeing the beginning of debates of at a national level. And so we have to consider that in this backdrop.
I think that's a great point. CYBHI is a huge amount of dollars. was passed in a moment of surplus. We are in the moment that we are entering a deficit financing and deficit budgeting in California, and many counties will be in that situation as well, and not be looking to expand at the same moment that we have a massive need expansion. Very much hear that.
And I'll just add to that, I think the complexity jumps out big for me, and I think the challenge is, we heard some of this today, I get it, you know, an individual human being is not being served, and they don't understand why are we talking about all of these system level things when we can't serve people, and yet the dynamic tension is we have to invest in systems that are going to be more efficient in order to be able to scale and serve more people. The only, you know, the private sector solves these problems of shortages by automating more. And so how we can automate and still deliver humane solutions is a dynamic tension here that we have to figure out. I'm personally very optimistic that this whole sector is underinvested technologically, and we can make a lot of gains that way, but there is that open question of time frame.
Yes, Commissioner Brown.
Let me just preface this by saying, I'm gonna give you some input, but I'll preface it by saying I'm generally not a super big fan of the formal strategic planning process when it comes to government.
I will not be offended by that.
I think that the reality is, you know, and I've seen, you know, I've been involved in many strategic planning processes. I've been on the commission 12, 13 years. We've had at least 2 formal strategic planning sessions that we have done. But, you know, life has a habit of interfering with your strategic plans oftentimes. And I think that it's, in government in particular, decisions oftentimes unfortunately get made as a result of emotion, politics, and then also as a result of available funding. And economic ups and downs, you know, will exacerbate all of the above. And I think that whatever we do with this, it's very important that this not be seen as a cast in stone plan, but has to be something that is nimble, allows us to be nimble, and is adaptable to the inevitable changes that will come in the future. And we didn't see the pandemic coming. We didn't see, you know, the Great Recession coming. We've got, you know, who knows what's in the future. We know that there are some economic white waters ahead that we're going to be going through in all likelihood. But anyway, having said all that, I think that I'm also concerned about the question of timing. The governor's proposal to modernize mental health care is kind of the elephant in the room right now. We don't know how it's going to finalize. We don't know, you know, how it's going to, as it proceeds through the political process, to become a reality or not. There's going to be an awful lot of rhetoric that's likely to be flying around, and it's going to be a tumultuous time in that respect. But I do believe that the governor's ideas there's some very sound parts of what he's trying to accomplish. And I noticed that nowhere in the emerging contexts and trends, which I agree are for the most part very good, but there's no mention of homelessness. There's no mention of substance abuse, fentanyl deaths. You know, these are things that are at the forefront of the governor's concerns and frankly mine and others as well. And I think we have to recognize that those are huge priorities. I think traditionally there has been major concern that they are priorities that may lessen the priority of some other types of mental health services that are given, and that creates a lot of angst and a lot of concern with stakeholders. I don't know what has been done in terms of, have you reviewed the 2 prior strategic plans that have been developed? And, you know, I think it would be an interesting exercise, particularly for those who weren't involved in any of the preparation of them, to see, okay, how did they fare? How did they do? You know, in other words, this was done in in 2000, and then by 2005, how did things shake out? Did it work? Was it a good plan at the time? Or was it, something the size of a phone book that sat on a shelf and gathered dust and really never got used? And so whatever we do with this, my recommendation would be that it be very succinct, that it be very general, and point out priorities that if the current situation or the future situation allows for it, that we should pursue those. But we have to be able to adapt to varying things as well. And I think those are my major concerns.
So let me reflect three things, because I think that there are places that we would action some of your comments directly. The first one on agility, I think, is really, really important. It's something that came up and something Commissioner Danovich said as well. And I think when we talk about roles next, I want to push on this issue of it may be a unique differentiator for the commission. And so I would actually go so far as to say on the agility point, we should include that in our principles for success of this project as well. This does not only need to be understandable and relatable and evidence-based, et cetera. It also needs to be able to be agile, right? And so would put that actually really specifically, and I think is very important. Point taken about the growing needs for our individuals experiencing homelessness and housing instability, the substance use disorder issues. Like, this is a massive, massive issue, and some of the both structural and societal changes that are happening that this group will be responding to and that are impacting behavioral health. So can certainly call that out very, very directly. And then the last piece, actually, assuming that we have time today, actually our third question or fourth question today is actually looking at where we are against the previous strategic plan. So would really welcome your comments there. Okay. Shall we move on to talk about roles a little bit?
Absolutely, Nicole. And I think it pulls on a lot of threads that were introduced in the trends discussion, and Commissioner Brown, directly to your last comment, it pulls from, what did we put in our 2020 document? And the conversation today should be to reflect and say, is that the most representative of where the commission is today in terms of how we're differentiated and how we can drive transformational change? And based on what we think is coming, is it agile and flexible enough? But what we have on the screen and in your packets is the 5 roles that you outlined in the 2020 plan. And I recognize that this is an active topic of conversation for the commission. And just in January, when you discussed these similar roles, you included things like capacity building, like communications, and a broader set of roles that we know commission staff and their partners in counties are doing day to day. And so the hope for this conversation is not to get to, a decision on the 5 or 6 or 4 roles that the commission plays, but to elevate a conversation on how the commission intends to drive transformational change and how our roles help support that. Nicole, anything to add before we dive in?
Questions, actually, because I want to start us out with the question around what is differentiated about us? So what is our role today? And what is the role that only we as a commission can play?
I'm sorry, can I just make a comment? Because I had stepped out and I stepped back in. I heard the tail end of what Commissioner Rowlett was saying regarding diversity, equity, and inclusion. And I want to agree with that completely. And I don't want it to just add it like another thing on our plate. I want it to be the plate of what everything else comes out of from this commission. I think what we have learned and what we continue to see, and I think additionally with the stressors of the pandemic, it's not changing for our people of color. It continues to get worse. So I think everything as we talk about mental health in this state, it really does have to be the plate from which everything comes in our work. The other thing I want to talk about when we talk about trends, there's opportunity in how our youth have really engaged in mental health and the discussions. I think that is an asset. And I think that how they have become more engaged, involved, and really want to have control of their future. And so I think that's a positive trend. I think that's something that we need to tap into and support. And I said this probably 100 times since I've been on this commission, not doing things for them or at them, but really with, because it's a wonderful opportunity. We have young people in this state who are on fire and want to change not only the system, but just really the trajectory of lives for everybody in our state. So I think that's a positive trend. So I wanted to add that, and could not agree more with Commissioner Brown. I think the fentanyl crisis that we're seeing, and I specifically to say fentanyl, I'm in San Diego County, it's ground zero. We're losing at least 2 people a day to this. And it's something that we absolutely have to address. Why is it that, I know why, but there's a lot of people who are in pain and who are engaging and, and dying right there and then. So I think we have to address that. So I just wanted to make sure that we talked about those things and wanted to add those. So thank you.
Thank you so much, Commissioner. Of course.
This is a beautiful conversation. I absolutely agree with Commissioner Brown and Commissioner Danovich, as well as Roulette and my dear colleague, Commissioner Madrigal-Weiss. I mean, just beautiful. But also, can we add a priority to look at simplifying the access? Somewhere in this discussion, there has to be some simplicity, because at the program level, the complexity drives the way we do our business. So just looking at the requirements with the reforms in CalAIMS, the Medi-Cal requirements, all of that drives the way we approach our clients, our consumers. And so for some of us who are on the ground level, delivering direct service, we've got to figure out a way so that it's just not so darn hard for people to get the help that they need. And all these other issues of fentanyl and of homelessness, I would also like to include, if we could insert in our goal to ask more questions. We've got to figure out that part. We're just not delivering services, but when we are in front of that consumer, we're asking the why.
Yeah.
The why and how did you get here? Because if we can do that, we're going upstream so we can deal with some of the reasons. So and I don't know how you do that or infuse that in a strategic plan. I don't know.
One thought on that, just of how that can inform our vision is, earlier this meeting, we were it's push. We had a member of the public show up to this meeting because they had been unable to get services and had made their way all the way up to a state commission meeting to have their grievance be heard and get a response. So I think we can formulate a really clear vision that anybody that wants to get a service, should have a mechanism of being able to get a response and being able to get served. It shouldn't be that hard. And with all the technology and with all the means, it shouldn't require representatives of the city, county government to have to intervene at this level to be able to respond to it, because we know that's not an exceptional example.
And I would suggest to these points that going to your second question, I think that is a differentiator. We are standing uniquely able to look at a system that's very siloed. And, everybody's stuck in the system and people aren't intentionally trying to have these outcomes, but it's very hard for people in their individual viewpoint to see how to break through. And we have this unique independence to be able to see across the system. So simplifying complexity for me is a potential unique role for the commission.
Okay, I hear that, and that's coming from your role outside, in some ways outside and inside the system at the same time, right? That you're able to see the way the systems interact to drive complexity and make recommendations to be able to simplify. Important, very important differentiator there. Commissioner Rowland, I thought that.
And that end user that came in and spoke today, that's the reference that I was making regarding the end user.
Yep.
And to Commissioner Brown's point about strategic plans that are thick as phone books and gather dust, he must have been in our senior leadership meeting in the organization that I'm privileged to lead, because that's what I say about our strategic plan. And that's what you don't want. What you want is a strategic plan that the end user can pick up and has agility and utility. Now you're nodding, so I understand. And then the other point then that Commissioner Brown made, and it is the elephant in the room regarding the articulated modernization of MHSA and what that does to the role of the commission. And does that somehow compromise its ability to do what we're doing right now?
And actually, it's for that reason that I think understanding what makes us be able to do what we do now, understanding what's actually kind of at the core of it, and then understanding also what barriers we have to what we want to be doing now will help us move past a question of is this a threat or opportunity, but how do we maintain the things we know that we are differentiated at to maintain a role, and you know, what is the need in the broader ecosystem for what's missing? What, you know, if MHSA OC didn't work, SC didn't happen, what would be missing? What would be the vacuum, right? And that's an important thing to articulate so we can kind of ensure that the best things about us are maintained. Yes.
Thank you. I think one of the most important roles that we have is bringing the discussion to the public.
Bringing the discussion to the public, yeah.
Engaging the public in this process is significant, because a lot of times, you know, folks don't have access to other entities or may have it at only one point of a meeting. And in the commission meetings, not just the commission, but actually our committees also are all about how do our stakeholders also feel about something and contribute to it. So the process of engaging our family members, our peers, our people with lived experience, and our experts in the community that are providing the culturally responsive services help enrich our discussions and knowledge about what is working in the community and what's not. And I think that is really a unique role that the commission has continued to do and should continue to do is the making sure, obviously the public is involved, but the committees too. And the reason why part of this was, you know, brought up is because, you know, last year we dealt with, you know, the care court process going through our legislation really, really quick without actually knowing details. It was out of our control, obviously, as a commission, but we hosted opportunities where people can talk about it. And I feel like a trend that is we're seeing in the peer, you know, a lot of our peers and family members talk about, or at least specifically the peer community, the trend of more our services being court ordered. And what does that mean when we're seeking services and we're not in like a court order? Or we want to pursue it, but not necessarily through the courts, because that has not always worked in communities of color in our favor.
Right.
So there's feelings about that, and I think part of our because you did ask about trends too, so I think that's an important area to look at and see how does that impact everything we do when we're trying to reach people and prevent situations from getting worse.
Yeah, I appreciate that.
Commissioner Tamplin, I also hear your articulation of the commission's role in engaging communities as maybe a way that you do your oversight and accountability. What was coming to mind is, what does that end user understand and know about the commission? And more that they understand and know your true role, the more value they can get from the commission existing. And that oversight and accountability is bringing those topics to the public, giving them sufficient space to engage, and looking for opportunities to reduce that complexity in a way that's agile and responsive. And so just knitting some threads together here.
And that engagement is sometimes on topics that are outside even, that are on, on the broad range of topics that impact the users, but might not be specific to a decision that this group has made, but maybe broader in terms of how broad you see your role of engagement and communication. Okay. Other thoughts? Oversight and accountability, it's in the title. What do you see as your role there? This group doesn't have an audit function, correct? Which is one way of reading those words. What are the ways that you see your oversight and accountability role unfolding?
I think one of the ways we get to that is through data. We're very focused on elevating data and making it more data publicly available, and that it's not about us auditing the system. It's about allowing the public to audit the system and creating greater transparency.
Transparency. Yeah, thank you.
Yeah, please, Commissioner Bunch, and then we have Commissioner Gordon online who
Great.
also would like to say something.
I was actually just going to go backwards a little bit more toward engagement. Just because people who come here know about the commission, and they come and, we had someone come in earlier and did the research to get her needs met, but working in a clinic and working in the community, a lot of people don't know about the commission. So I wonder if we can actually do a better job of engaging the community to know that this is somewhere that they could come and be heard.
Great. I appreciate that. And we heard that Commissioner Gordon's on the phone. Is the audio working for the phone participants right now?
He's on Zoom. Is that correct? Okay. Commissioner Gordon, please.
Yes, thank you. And for the consultants, I work principally, I'm a school superintendent. I work principally with our schools. And I think for the schools, the three biggest issues are, number one, ease of access. Schools are the place where we require children to be there from now pre-K through 18 years old. So that's a potential point of access, which I don't think we take nearly enough advantage of. Prevention and early intervention, I think, is the thing that we really have never tried, especially in our 0 to 5 population with families and their young children. But not only that, with prevention, as Chair Madrigal-Weiss rightly pointed out, right now we have huge numbers of our youth who are very engaged and focused on mental health. So teaching about prevention, they are a willing audience, and they will carry that message to their peers. And as they grow up and have families, that's a place we can emphasize prevention if we were really willing to commit to prevention. Then thirdly, I just wanted to point out the notion of financial sustainability, particularly for schools, is a real pain point, because they have seen the cycles of one-time funding come and go, and it comes and goes, and you're excited, you have a clinician on staff for a while, but then the money runs out. No more clinician, no more access to folks in those systems. So I think those three areas, if we could really more sharply focus on those, and mainly the prevention and early intervention, because we're great at treatment. We're not really too good at prevention and early intervention. So thank you.
Really appreciate that perspective. Thank you. So heard three important strategic priorities there from Commissioner Gordon. I do want to take the opportunity. Is there anyone else on the phone who's been trying to, any of the commissioners on the phone? Okay.
Commissioner Danovich wants to add on there as
Thank
well.
you. Thank you, Commissioner Brown.
Oh, I just wanted to respond to your question about what we're called, because I think it's important. And this is just representing my view. the terms oversight and accountability to me are total misnomers because they represent and suggest that we have authority and control over the $2 to $3 billion of funds that flow through the Mental Health Services Act. Whereas in point of fact, we're kind of facilitators and monitors. We can monitor things that happen to variable success, and we try to facilitate our actual capacity for oversight and accountability pertains to a really small percentage of those funds that flow directly through the commission. So I think, you know, in the spirit of simplification and identifying where there's opportunities, we really have to be mindful of our limitations and our capacities because we frequently get distracted by the enormity of the problems and our own wish that we could have oversight and control over the $2 to $3 billion that flow through and that we wish could make a direct impact on all Californians.
Yeah, I'm glad you brought that up. That is actually why I was pushing on that, knowing that your role's limited and in that particular way, and that therefore the work that you all do on oversight and accountability, we need to be thinking creatively about what that actually means for us and defining and articulating it. You know, our name is our name. Who knows if that could change or not, but the point is we need to be articulating very clearly what that means to us. If it is about monitoring, if it is about transparency, how are we able to do those things most effectively to make that clear? And obviously providing oversight to those items that do flow through our own dollars. That actually, oh yes, please.
Sorry, I know you're trying to move us on. But to that point, I also think it offers us an opportunity to strategically think about what role we play in working with our partners that do hold that accountability position. Because as we've heard from the public, the commission continues to be a place where people trust that they are heard, that their voices can be part of the conversation. That is an asset to our collective work as a state to improve the mental health of our communities. And how do we step into that power and position of the commission in ways that our agency partners can leverage it?
So that influence role. And I don't want to put words in your mouth, but there may be an influence role to other agencies. We haven't talked about policymaking yet, but I assume I wanted to ask, like, is there an influence role on the policymaking side as well?
And the advisory element to that as well, which oftentimes doesn't get put in there and probably should be.
Is there anything, we're going to move on to the next question and recognize that we might not get through all of our questions, and that's okay, because this is the beginning of a process. But I want to ask the group, what do you not do? You don't have the authority to audit. We talked about that. What are other things that this group is not equipped to do that are done by other things? I'm going to throw out another very, very obvious one. You don't deliver services, right? We're not a hospital. We're not a provider here. What are some other things that we don't do that are off the table in terms of our role in this broader ecosystem?
Well, I think Commissioner Danovich said it, we don't have authority over, so we don't impose sanctions.
Great.
True, there's no enforcement arm.
Okay.
So we can go back and look at, or in some manner, in terms of oversight, like just do a site visit to programs that are funded. So we have that ability to review.
Okay.
But that's probably the depth of it.
But this is helpful. This is how we get to the model of what are the activities that allow us to influence and what does monitoring mean to us? So we know what the edge is.
And you elevating that grant making is one of those levers that you are able to do your monitoring and transparency work. I think is an important thread to pull. Thank you.
There is a certain power of the purse, right? Other thoughts on what we don't do? And again, this isn't the question is not what we should do. It's actually what we should not do. Don't and should not, because it's outside our scope. Anything else? Okay.
And Nicole, I think maybe that's a good thread to connect to the next conversation. So if folks are still thinking about that topic and want to elevate in a minute here, But one of the goals of the next strategic plan is to help the commission articulate how you do decision-making around opportunities. To start to standardize the approach to how you collect data and measure impact, which I know is a large priority in the 2020 plan and is a real challenge in many contexts. To help you prioritize across the initiatives to maximize your impact and to make funding decisions. Commissioner Brown, as additional funding comes in or additional funding changes, how you make those marginal trade-offs that are difficult. And how you look across the full portfolio and design and monitor programs in a way that will really maximize outcomes for the target populations that you're trying to serve and that end user, that end consumer in the room. And so what we hope to have as a discussion for a few minutes here this afternoon is to really understand, what are the critical components that you individually or as a group use for decision-making today, and what needs to be added to that decision-making to make informed decisions in an increasingly complex world going forward. I'm gonna sort of open the floor here for thoughts on how we strategically make decisions about the specific initiatives.
I would throw out a big part of our decision-making process is our staff, and relying on our staff and the size and the capability and the leadership and of our staff is both a big part of what we do and is also creates limitations because, we only have so many resources to go there too.
Very important. Other thoughts on kind of how do you today and how could you be thinking about trade-offs? Yes.
Oh, so another way that we make decisions is when we're directed to by legislation. So
Yeah.
It sounds like that's not going to change. That's an important function that you all play.
How do you think of the set of criteria that you use? Are you thinking about impact, feasibility? I'm sure that you are, but how do you think about that set of criteria and how you balance the trade-offs across those?
I'll elevate some topics that came up in the prior discussion as well, thinking about fiscal sustainability of investments that you make if you're just using one-time dollars or you expect they might be. Thinking about target populations that the dollars go to serve.
So our intention here is to kind of co-develop with staff and with you all, a decision-making framework. To the point that you were making, Commissioner Brown, this is very far from something that would sit on a shelf as kind of, and you made it as well, Commissioner Rowlett, on a shelf somewhere and never be opened again. I would propose that a decision-making framework or a set of criteria might be something that you would have in front of you as you're having all of your commission meetings. Be used every time, be a live document. And honestly, not a static document, not something that once is set in stone, but is something that you would be discussing dynamically around having to tee up the conversations around impact and how you measure it, to be teeing up the conversations around feasibility, to be allowing a really robust conversation of trade-offs. If we do this, what don't we do?
One of the things that jumps out at me is this commission, because we're supposed to be innovating, we do a lot of pilot programs, and that's part of the dynamic tension. If you're, I guess, HHS, you're thinking about how do you create a program for sustainability forever? And so almost by definition, you're not going to be as innovative because you're going to be more conservative about what you're going to take on. But since we're trying to push the envelope, we have different criteria, I think, because of that. I don't know. I'd like to hear what other fellow commissioners think.
Yeah. What's your role in this is a kind of role plus criteria because this should go together. Your criteria should flow from the role that you play. I'm hearing a very important role as an accelerator of innovation and a tester of new ideas. So what does that mean for how important is that from the perspective of other commissioners in terms of your role and then also how that should play out in decision making?
So I just want to go to your example of, how we should have criteria right in front of us, and this is our agreed upon, these are how we make decisions. The closest thing we've had to that is we approve innovation plans, and you can't get us to decide on how to define innovation from me to 2 people over or 3 people that way. And so I think when we were having conversations around this process, that's something I think we would appreciate, because when we make decisions, sometimes it's because of what we hear. Sometimes it's because it's trend, sometimes it's because that's a hot topic like. So, and I think I mentioned this on the call, we have to stand for something or fall for everything. And, you know, if we're going to be held accountable, then as we should be, then we should have a criteria to make those decisions, because it would not seem necessarily like it's being fair from one ask to another. So I think we're hoping to get there. But just in that example alone, how do we define innovation? You know, where some of us are like, that is not innovate, right? So I didn't answer the question. I think I just made more questions.
No, I appreciate that. No, that was exactly the kind of thing that we're looking for.
I'd like to add to that, but also I think our decisions are made with the influence of our stakeholders. So we don't make decisions in a vacuum. So our stakeholders, when they speak on an issue, the decision may be delayed to review what that issue is that's brought up.
Yeah, I think that makes a lot of sense.
So.
So maybe we move forward to a little bit of, how are we doing on time?
We've got about 15 more minutes till the intended end of this session, and I recognize folks need to have lunch to refuel for the afternoon. So perhaps a couple minutes here, and then we need to create some space for public comment and anything else the commissioners want to share that we didn't get time for in this facilitated session.
Okay, so this is our last
kind
kind
of
of big topic of question where we'll open it up, and then we'll open it up much more broadly. So, Anna, why don't you take this one actually?
Yeah, happy to. So what we've got on the screen here and in your packet, and I recognize it's a bit small, it comes from the 2020 plan, is the 3 core strategic goals and objectives that support those strategic goals. And I want to recognize and acknowledge that when the commission met in January, you all refined your focus for the rest of 2023. And I recognize that all of those are not on the page here. But I think that creates a great starting point for dialogue on these 3 topics and the others that you've introduced, like firearm safety, for example, to ask ourselves as a commission, you know, which of these priorities and strategic goals have we made significant progress on, and so can move forward in prioritizing others, and where are there places where we really need to double down or add to our portfolio of focus topics to be successful in the coming years. And I recognize and acknowledge the need for agility in that process.
So how do you think you all are doing on the first one, advancing a shared vision? There's certainly a lot more discussion about behavioral health and mental health in California today than there was 3 years ago. I know you all have played an important role on that. You know, I'm curious, you know, none of these are, this is a massive, massive challenge. We're not going to say like declare win and move on. That's not our intention. But how have we done in the last 3 years against the advancing the shared vision goal? Any reflections?
I'll just speak to the develop and advance a strategy aligning public and private resources and actions towards the prevention and early intervention kind of efforts. And I think we've done a lot, but now it's clear we need to do more in this area because of the fact that we're in a situation where our resources for prevention and early intervention can be cut by a third.
Very important.
And so there was we've done, you know, and that's a good focus on for our commission, but it's something that's going to need to continue to stay part of our strategic priorities, I feel.
Okay, important. Other specific points on this one?
To the things that I can recall, I think in terms of advancing the shared vision, when I came on in 2016, I don't think there was a real serious data tracking tool that the public could click on and see what's going on. We did the criminal justice report. That was a very big project that went forward. There was the suicide prevention report. schools and mental health. So there have been some shared vision and cross collaboration, and I'm sure there are others that just aren't coming to mind. So I think the vision has been expanded. It's just getting through the weeds of, again, the complexity and how the public has benefited or has not benefited from the work. But there has been lots of shared vision and lots of reporting out on that. So, and I know I'm missing some, but
So I mean, we can look on the website, but just offhand, right? So I think that advancing the shared vision and the mental health needs, we've done so much around school mental health, right? The MHHSA, we are in, I think, 57 of our 58 counties, if I'm not mistaken. That project itself has unified our county offices in ways that not even our Department of Education has done. And so I think that's huge. The Ken Burns films that we've promoted, that's another way that we've done it. Cal Hope is something that tapped into, I think, all 58 county offices of ed, which is unifying social emotional learning in schools. So, advancing the strategy, prevention, early intervention, we put the report out there. We continue to have conversations around that, which no other entity has done, right? That came out of the commission. And then the adoption of the standards in the workplace. Nobody else went forward to move that. Now we have entities that are starting to develop implementation guides to get those into the workplace. I know my county office is doing that because I'm ensuring that they are. And I think that's just critically important. We spend more time at work than we do, for many of us at home. And so the fact that we're modeling, what we put out there and not just talking about it and not just putting it on the shelf, I think is important. So I think we've done an amazing job with advancing the shared vision. And I think, again, they're just not reports. We're actually living this. I think that's.
And the examples that I'll go back to, all of these should go back to role, which is, I also heard in there another role that you all play, which is both best practice sharing and creating kind of communities of practitioners, like on the MHHSA work, right? Where there's some unity or some convening that you're able to do through some of your work on shared vision.
And we don't just, I think, share it and wait around to see who's going to pick it up. We share it and execute because it's the urgency. So I think with practicing what we preach and not just waiting around to see, again, who's going to pick that up, but let's put it together. Let's put the funding together and then execute the practice. So the flexibility that we have and the agility that we have like no other, I think is critically important.
Commissioner Bunch, I think you had a comment.
We also,
Sorry. Oh,
let's
sorry.
let's go with Commissioner Bunch, please. And then we also have Commissioner Gordon online again.
Okay.
I was gonna say exactly the same thing. Just, I think we've done an amazing job of following through with the vision. And I was specifically gonna mention the workplace mental health and the role that the work that OAC has done. But not just that, later today, we're gonna be talking about the gun violence and the amazing amount of work that's been put in just a year. And that is huge. And I think we continue, we have this vision, but I feel like our vision is constantly evolving because we're constantly doing more. And everything that we do is, I feel like just everything that the OAC, the staff does is so positive that it really, it's sticking to what the vision is, but it's also making sure that the vision it doesn't stop, it just keeps getting bigger.
Commissioner Gordon.
Commissioner Gordon, please.
Thank you. Yeah, I agree with Chair Madrigal-Weiss, but I think in doing all of the good work that we've done, we basically whetted people's appetites for answering the question, well, are you really going to continue this? So for example, in my county, we have 320 schools and we've put now mental health clinicians in 40 of our 320 schools, and people are saying, this is great. When do we get to the 320 schools? So I think I think that's where following through on changing the culture and the way that we make services accessible is really the financial sustainability and the sustainability of the willingness of the systems to keep sustaining these good works.
Thank you. Appreciate that.
I would just point out with what I've heard that in terms of a common principle, I think there is this bias to action that all the commissioners feel that you don't tend to find in a typical kind of a government organization because of how we are organized.
Quite unique.
And I'll just add the piece to the advancing a shared vision. We did get involved in SB 803 and all the peer support specialist certification bills prior to that too. And so really helping bring, uplifting peer support services and showing the value of it. And then also helping create, for California joining the rest of the nation and creating the certification. I think that was a big push that came from the commission and the public. And so I think that's something that something to be proud of and helping move forward.
Absolutely. How are we doing on leveraging data and analytics?
I think that both on that and on the other elements within here, there's a lot that we've done at a tactical level. There's a lot of accomplishments. I think part of why, when you ask the question, sort of the first response is a pause, is because we struggle with translating the impact and telling stories around the tactical things that we do in a way that clearly connects them with these high-level goals. And that's a problem and opportunity, both because we need that translation and communication to be able to create momentum, and also because the perception of ineffectiveness constantly threatens this whole construct. So it's an area we've gotten much better. The communications division of the commission has been doing great work, but it's an ongoing challenge how to accurately and validly but effectively translate the work we're doing so that we all can really easily, coherently convey these kind of impact statements and including to our stakeholders.
Other thoughts on shared vision? Maybe we'll open it up as well on policy and practice.
So I would just like to speak a little bit about the data, because I think, the transparency suite, I think, was one of the first concrete things that I understood as far as the data and the advancing data collection. So it was the transparency suite. But now, we had talked about a dashboard as well to see, okay, it's great that we know how much the spending is, but how are we doing with the spending? So I think now, as there's conversations around the modernization, there's mention of, yes, we need dashboards, but we've been saying this for 5 years. And so it's great that now it's included in the plan, but that's something that I think this commission influenced, even though we didn't create the tool. It's conversations that were 5 years ago that this commission influenced and it's now understood that that's part of it. So I think in that way, we do advance data collection, whether by creating the tool or by influencing the conversation that now becomes part of, plans moving forward. So I think that's important as well. And then I think it's also influencing the county level, right? Or even county and state level, because it's raised conversations that we don't even have common definitions. And so I think that's going to start a change in practice, because I can't collect data if I can't define an apple to an apple, right? You've got Jazz apples, I've got Fuji apples, and so that's not going to work. So I think that is also influencing the conversations.
Okay. What's the barrier, in your view, to going the next step on the data and on the standardization? And is there a role you believe that you all can continue to play there?
I think the barrier is that there's not. I'm not gonna say that correctly. Toby, I'm gonna ask that you assist me with that.
Of course. So the data stuff is hard because there's a sort of a retail front side of that, right? The presentation that we do, the engagement that we do, the organizing of the data. And I think, relative to when the strategic plan was adopted, we've made huge strides in updating the fiscal transparency work, some of the experimentation that we did on a program reporting tool that we've now taken down. We've actually released other dashboards that sort of connect the data that we have. And on the infrastructure side, we have data use agreements with lots of our departments, but I'll tell you, it'll take 3 years.
Yeah.
To negotiate that and to get some of the data, just to find out that we have Fuji apples and shoelaces, right? We'd love to have Fuji apples and jazz apples.
Yeah.
So, I think, we have really made progress on the objective side, and I think we've made progress in elevating the strategic goal side of the importance of data and analytics as reflected in the elevated conversations in the administration and the legislature about how important this is. But this is the one where I think we've made the least progress relative to what the opportunity is. And so your specific question is, traditionally or historically, data has not been important for accountability and oversight. Data has been important for finance and billing. And so our data systems have been built around payment, not built around outcomes. To the point where, in public session, we've had conversations around, for example, the No Place Like Home housing bond. During a recent budget hearing, the Department of Healthcare Services representative was asked how many people have been housed by the bond, and the comment was, actually, we don't track that. That's not a data point we track. We track more how many of the dollars have been released. And this is a very genuine response from a representative, because, agencies don't always see themselves as delivering that retail frontline service. And so, we can be really good at what we do, and we still fail at achieving the goal that we're having. And that gets at what Commissioner Carnevale talks about in terms of the complexity, the regulation, or Commissioner Rolette, all of the challenges that we have. But admittedly, this is one where I think we've made less progress than we'd like to.
Appreciate that.
I have a process comment related to that. What I experience, especially regarding, I'll use a specific example, the financial accountability tool. And let's say that that's a tactical representation of some great work done by the commission. Who's responsive to that tool? Well, essentially, nobody. And as a result of the commission not having, because the data in the tool is accurate. But does the commission have the authority it needs to influence the kind of outcomes that are not responsive to dollars or fiscal financial measures? And to say to the 58 counties or the state of California, hey, are we really serving the end user as well as we should be? And from my point of view, we don't. And so what the tool does is it highlights that there's an area in particular, in one specific example, Commissioner Carnevale said to, I believe it was Nevada County, oh, you based on the data I'm looking at, you spent your resources, you've used your resources well. And that's it. And should we have more influence and impact around when people spend their resources well, at recommending that resources be redirected, and when people don't spend their resources well?
I think that that's a good transition, right? Because data and analytics is not just about that. It's what you do with them. And that gets to the second point here. Are you using your data and analytics to catalyze improvement? right? Are you using your data and analytics to change or not change, influence policy, right? Influence practice. And that is the metric by which we need to be thinking.
I just said, well said, and that is
Okay. I do recognize we are running short on time. Any final comments on the catalyzed improvement in policy and practice, and then we can open it up. I heard Commissioner Taplin, when you were talking before, actually about a few very specific ways that the work that you all did influenced policy. And Commissioner Carnavale, you also mentioned some pilots, right, that are demonstrating influence, that are demonstrating success that theoretically could and should be scaled up. Other ways that we see ourselves catalyzing, so piloting, direct engagement for influencing policy on areas that are important to us. Other ways that we're catalytic in policy and practice.
Partnering, well,
Partnering.
by creating partnerships
Mhm.
of many different kinds, we catalyze a lot.
Perfect.
So our multi-county collaboratives, I think, is the summit. And then we've also hired experts that will support our counties with different questions as they come up.
That's
So
direct
I think
technical
that-
assistance,
Mhm.
essentially.
Yeah.
Capacity building. technical
Yep,
assistance.
we will provide technical assistance. And I think even now, for example, with the MHHSA grant, going beyond and understanding the technical assistance, just again, because we have this great opportunity. So being really thoughtful of building in technical assistance to it, which I think is, we're always thinking with the end in mind. So how are we building the sustainability? We don't have the dollars, building the capacity and the expertise within those counties with the county offices of ed to support the LEA. So really thinking about building that sustainability for when the funds do go away, that they left something in every one of those counties.
And that crowds in funding because there's that capacity to take more from other places. Absolutely.
We've
Exactly
also
right.
built in the capacity or the requirement for people to do evaluations on the programs that we fund, right? And that's a new expectation that starts to get people to think more about outcomes and not just the transactional nature of the money.
In that design process when it really matters. Absolutely.
Well, on to the next item, we'll open it up.
Absolutely. So, commissioners, anything else that you want to share more broadly, places that we didn't touch on across those 4 topics or on strategic planning before we open up the room for public comment?
Okay. Yes.
Is there a commissioner on the phone?
Yes. Commissioner Bontrager, please.
Yeah, well, first of all, I appreciate the conversation. I think it's great for us to have a thoughtful conversation that's also self-reflective. I do have a question, however, as one of timing. Is there any way to look at this in a different time parameter? Because as it's been mentioned several times, you know, contextually, we were created by the will of the voters, and our mandate and our structure may change by the will of the voters here in about 15 months, potentially. And I just wondered, in that context, is there any way to modify this time period in that context, just given the fact that that is looming out there and is so foundational and fundamentally different?
Yeah, I think that might be a question for the chair, for Toby.
Toby, please.
Thank you for Commissioner Bontrager. You know, as we work with our partners at BCG and with Commissioner Carnavale, who's the chair has asked to take the lead on this, that certainly has come up. And we've sort of treated this a couple of ways, right? One, we could sort of sit back and wait and see what the world looks like in, you know, at that point in time where there may be a measure on the ballot and then revisit this. Or we also could just move forward and really identify key priorities that are important, not so much for the commission in terms of, you know, the authorities that it has at the moment, because as Commissioner Sheriff Brown has pointed out, you know, these authorities do change based on legislation or budget decisions. Instead, could we have a robust conversation about where California's behavioral health system is at the moment and the key tensions and pressures that we have, and to begin to, lay that foundational framework around what this opportunity is, and then use that information to shape the conversation independent of the decisions that are made by the people of California with regard to the commission's authorities. Because it may be that this commission may gain or lose some opportunities or authorities, but if we identify what those opportunities and needs are, we can certainly make the case that they need to be addressed, whether it's something this commission is doing or someone else is doing it. And so with that in mind, it felt like the right thing to do was to plow ahead and bring in all the information that we can, recognizing that we'll have to be agile in terms of our specific role on what those opportunities are, but that doesn't mean that those needs that we identify through this process will change based on the functional differences that may be imposed on the commission at a future date.
I'd like to point out too, though, that Commissioner Bontrager said 15 months. It could be as soon as 9 months. The potential is that it could be on the March ballot, the primary ballot as well. From what we've heard, it's a potential for that at least. So it's something that could be theoretically very imminent. And I just wonder if we might not be better served trying to shape the proposal, to try to have influence on the proposal and maybe use a planning session around that rather than what is to be our strategic plan for the next 3, 4, or 5 years.
Appreciate that input. And I think that one thing that hopefully we can do, our team can be agile to support the direction that you'd like to take this, first of all. So it's that is easy. The bigger question is one for you all to figure out about what's the strategic right moment. And what we can also commit to do is really work with you all to distill the elements that make you all distinctive and where the gaps are in the current ecosystem that no one is playing today. So to be able to take a broad enough view that we're not only thinking about the commission in a vacuum, but we're thinking about the commission both today and what it could be in the future relative to the needs that exist. So that hopefully those kind of distilled elements are relevant regardless of what comes in the future.
Yeah, I see them connected because I think, and I agree, Commissioner Brown, but if we have this unique voice to be able to highlight all of the problems, regardless of whether we control them or not, as Toby said, and if we can highlight that in the course of this conversation, which we hope doesn't go in the direction that it's been leaning, then we can influence it through that education.
Yeah, and I think we might need to front load some things that might normally be done later in the process, but it may be a little non-traditional, but I think that could be used. But whatever we do, we have to do it like right away.
Yeah, agreed.
And I think that's why you'll hear a lot from us over the next 2 months. It's a little bit of a big push at the beginning.
All right, so I think we're going to now open up the room to questions. Or it doesn't look like anybody's at the podium, but I want to confirm if there's anyone in the room before we go to.
So we have 3 public comments.
Great.
There's 2 in the room and then 1 on Zoom. First, we have Steve McNally in the room.
Hello, my name's Steve McNally. I'm from Orange County. I'm a family member with a son with schizophrenia. All his relationships have been restored. And I'm also on the Orange County Behavioral Health Board. My comments are my own. I found last month's meeting to be one of the first meetings I saw you all take an active interest in representing your areas and giving a little pushback to being forced by the governor to do X, Y, and Z. And so as I sat and watched this, when it first started off, I thought, well, that could have been written for any group. And I'm glad that we got to certain elements. One is you have to model the behavior you want. So you want stigma, then everybody has to be free to explain publicly at their own comfort level what their relationship is to this. When you can't do that publicly, makes it harder for others. I think we told everybody stigma is over, but what we haven't done is create a change agent that allows people to identify their self-stigma and get on with it. There's so much stuff you all covered. I couldn't do it justice in 3 minutes. But I think it's the roles within the commission and the roles outside the commission. You obviously have a lot of respect and influence across the state going upward. You have less going downward, the Behavioral Health Planning Commission and to local boards that give you 900 people, including 59 electeds, and you're not touching us and you're not using us. And we're not empowering the 40 million people in California. We're allowing people to work in silos. We're allowing an executive branch to allow those silos to happen. In the private sector, you'd put it in somebody's compensation plan. You can't do that in the public sector. So one thing wasn't mentioned, and I broke my phone walking down here from LA Union Station, so I don't know what time it is because I don't see a clock. Is our the definition for end user is family and loved one. That's what the end user is. You've left them out at the table, even though it's legislated. I agree totally with what the chair said about youth. But you know what? That's the way families used to think on the ladder of peer engagement. When Cayenne came here, they said, we don't want to be at your table if you're just going to make us a token. And we've literally we've let everybody out of the system that really matters. And so a lot of times a receptionist will know the most of what's going on in a company, whoever interfaces with your customer. California doesn't want to talk to those people. And whether you like the way the message is delivered or not, you are seen as being safe. And you know what? It's not that hard to navigate our system. Once you do it, it's done. And so I could go on, and maybe I'll have the opportunity to do that another time. But I'll leave you with one example, because we don't talk implementation. So CalAIM, beautiful aspiration. Children's Youth Behavioral Health.
Thank you, Steve. We're at time. If you could please wrap up your comments.
Well, beautiful aspirations. As soon as it gets to the implementation stage, pushback, confusion, delays, we're almost a year behind peer certification going live when it was supposed to be legislated. And we only have in LA County less than 200 people certified. And with that, I just think we need to watch the process. And while you don't have accountability, you don't have authorization to abdicate and not bring it up, so someone has to deal with it, is just as allowing it to happen. And the public's been trying to tell for a long time, and no one's listening. So thank you.
Thank you, Steve.
Next in room, we have Pia.
Good afternoon, commissioners and Toby and colleagues and public present today. My name is Pia Escudero. I'm Executive Director of Student Health and Human Services for the Los Angeles Unified School District. I want to echo how amazing it is for me to be in this room. I was very much part of how MHSA was shaped 20 years ago. We did stellar work raising trauma and how it affected children back then. And we had just finished our CBITS project, and really what we're able to influence the language of MHSA to be really innovative and targeted to populations that were very much underserved. And I sit here 20 years ago and I see the disconnect. I did not know that you had meetings, and I'm here supporting our DMH and our partners that are going to be presenting this afternoon. And I wish the public knew. So hopefully we can raise that information. And then you could hear of some great work that we're doing across the district, but really multi-sectoral. One thing I want to mention is that 20 years ago when we brought in trauma,
and we realized how it was impacting so many children. Today, we have had to be very innovative in our school district. We started doing surveys of social influencers of health and education. Back in the day, they were called determinants, right? The higher social influencers you have, food, housing, employment, and so forth, the higher your health and educational outcomes. What we're learning today, I just wanted to share with you informally, but I guess it's a formal, it's about 6,000 surveys. 60% of our families want food and they have food insecurity. Second is housing, and then it becomes mental health. So I feel that 20 years ago, we could focus on mental health and really highlight that focus, but today it has to be mental health and everything else. So I think the challenge for you as commissioners is how to look for multi-sectoral opportunities. Especially in LA, I wonder if I think you should proceed with your strategic planning because the landscape is changing dramatically. I know when I go to DCFS meetings, they're transformational and they're changing. And we know that in our juvenile camps, they're changing, but everybody's changing in their own lanes. And maybe MHSA has that one leverage of really doing cross-sectional conversations and knowing that if we influence one area, it definitely impacts mental health, right? So I wanted to share with you just whatever happens with the electoral process, my advocacy is for children and families. Whenever I go to a lot of these systems meetings, it's always adults, adult beds, adult housing, right? Where are the children? We know.
Thank you, Pia. We're at time. If you could please wrap up your comments.
Thank you. I just wanted to highlight one thing that just struck with me this week. I attended our 2023 graduation for our homeless students. Those students are graduating and they were ninth graders when COVID hit. So their whole high school experience has been very different than any other generation. Our current third graders, and we know the studies are, if you're reading by third grade, there's just a lot of studies that that's our aim. They were kindergartners. So our third graders are like no other generation. And then our middle schoolers. So you have this opportunity to live prevention, early intervention, like no other system. And I really support and thank you for your work and your good thinking. Thank you.
Thank you, Pia.
Next, we have online comments. We have Richard, your line is open.
Hello, can you hear me?
We can.
Yes, I just wanted to talk about the peers and peer support workforce. CalMesa has 5,000 slots for the peer workforce throughout California, both grandfathering in and training. And I truly believe that the commission needs to expand their peer fellowship to help them do some of the work that needs to be done. I mean, when I look at the jobs of the openings with the evaluation and research, how much those individuals are getting paid. They're getting paid so damn well for work they can't even do with the Oversight Commission about data and reporting and transparency altogether. Majority of these MHS funded projects are contracted out for data and reporting. What does that say about the commission? I mean, that needs to be improved. California, the MHSA should have not waited until a state became a bill. We could have had programs and services throughout the state to meet the unhoused community, the SMI community. It could have been done. We shouldn't have to wait. Secondly, MHSA modernization will change how things are done at the commission and how the funding sources will be dropped to just 3 buckets. It's going to change significantly. What we need to make sure is read the fine print and vote no if it's going to go against or backwards with the MHSA funding. Like I've been saying all along, where's the transformational change? Look at the families who are being destroyed. They're not getting the mental health services of their children, adolescent with intellectual disability and mental health. They can't get it through the regional center because they're not a mental health agency. But yet they can't get it through the counties because there is no service available for that target population to serve the families like there is one in Santa Clara County with MHS dollars. All other counties need to copycat what this program does to help families. They are in crisis, they're being destroyed, and it's causing breakups. So I hope that's part of the plan, and it needs to be part of the plan. Thank you.
Thank you, Richard.
Next, we have Stacy. Your line is open.
Hello, Commissioners. Again, Stacy Hiramoto with REMCO, the Racial and Ethnic Mental Health Disparities Coalition. I really want to commend the facilitators and the organization of this session. It was easy to follow and allowed for good open discussion by the commissioners. The facilitators did a really good job and seemed to know the background of the act and the work of the commission. I would like to also support and thank Commissioner Rolette for his comments on the importance of the perspective of end users and how these are often minimalized and they should not, as well as his points about workforce and transparency. But what I would really like to support and build upon his comments are on diversity, inclusion, equity, and accessibility. And these were also supported by the chair later. I heard the facilitator say something like DEI is not an initiative, but must run through all the initiatives. Yes, we in the BIPOC community have heard things like this before, but REMCO hopes that the new strategic plan focuses more directly and explicitly about reducing disparities for BIPOC and LGBTQ+ communities, or that is just not going to happen. Focusing on systems such as schools and justice systems, or other populations such as those marginalized or at risk, and assuming that because most individuals in those systems or other populations are from BIPOC and LGBTQ communities, that reductions in disparities will take place automatically is folly. That will not result in disparities. The words race, ethnicity, sexual orientation, and gender identity must actually be used in the text and the goals to either prioritize serving those in those communities or to reduce disparities must be specifically written into the plan. I know this makes some people uncomfortable, so we should work on that so they are not uncomfortable and not shy away from using these terms and making explicit goals in the plan. Lastly, I want to support Commissioner Gordon's comments on PEI and other commissioners' proposals on innovations. I'm so afraid of losing these in the governor's proposed changes, and REMCO looks forward to working with the OAC to prevent their loss or being diminished. Thank you.
Thank you, Stacy.
Next, we have Mark Carmatz. Your line is open.
Question I have is this: how will this information get down to the local stakeholder process, such as the committee leadership teams meetings here in Los Angeles County, or to the SALT meetings in Los Angeles County and in other counties as well? How does it get down to the local community, and how does the information go back up to the Oversight and Accountability Commission? I'd like to hear an answer on that one.
Thank you, Mark. Next, we have the phone number ending in 319. Your line is open.
Can I just interrupt? Mark, I'm sorry. If you can ask the question online and we will have staff respond. Thank you. Next call, please.
Hi, this is Steve Leone on the 319. Can you hear me?
We can.
Good, good, good. I'm using a phone, not my own, because my regular phone ran out of charge. Commissioner Mitchell and Madrigal Weiss brought up the idea of simplicity versus complexity. And I want to pick up on that briefly because the MHSA, the full service partnerships, the village, the original of that, and you heard Dave Pallon talk about it last month so very well. And basically, that model was called an integrated service agency. And the essence of that agency was simplicity. Simplicity to the clients, simplicity to the family members, out of the complexity. It's like people had to do this, do that, do the other. And so not only should you push for simplicity over complexity in what you do next, but you are the actual custodians of that model of simplicity that has been largely forgotten as we complexify our world. Somehow, you know, the full service partnerships in particular, Toby has mentioned this, they're not performing well. There have been many changes over the years. Administrations, governors, initiatives, et cetera, have changed things around, and they wound up being neglected with no one doing a whole lot of oversight, not even DHCS. And as a result, you have full service partnerships that are supposed to be wraparound, and their contact is twice a month. I mean, that's ridiculous. And so you were actually formed as a commission to help defend that clinical model at the start. Now, there's plenty of other things you're doing, there's good things. But at the start was that full service partnership and that idea of simplicity over complexity at the iView level of the client. And I think that should be a very high priority in what you're doing. And by the way, the whole issue of oversight and accountability, that also has been made subject to change in legislation. And sometimes not very, very subtle changes as well, that has stripped the commission of much of its effective authority, you know, and other state bodies. And that's how we wound up with these various programs sort of drifting. And I really commend actually, Toby, you know, you've spoken up wonderfully in recent months about how the full service partnerships are not performing the way they used to. And all of this is at the core. So I think that should be a priority. Thank you very much for listening.
That was our last comment.
Thank you, Mariani. Thank you, ladies. We appreciate you being here and we look forward to working with you in the future. And Commissioner Carnevale, thank you for getting us started. All right. So at this time, we are behind schedule. So we are going to take a 15-minute break, stretch, do what you need to do. We do have lunch here provided for the commissioners. Then I'm going to ask for us to return and work through our lunch. But please take the 15 minutes to stretch, bring back your lunch. We have panel presentations, so cameras won't be on us while we're eating. So we'll make sure that they're pointed at the panel members and not us while we eat. So we will see you back. In 15 minutes. Okay, 1:15. See you back here. Thank you so much, everyone.
I would say for our. Yeah. And we'll connect. Okay, sure. All right. Thank you. Okay.
Good. Sadly. Respect.
Just can't do it. Well, I can, just choose.
Okay, we're going to go ahead and get started. Kendra. Hello. We're going to move on to agenda item number 9. Kendra Zoller, Deputy Director of Legislation, will provide a brief overview of the legislative priorities the commission will be considering today and introduce our 2 guests who will be presenting on those items. So Kendra, please, you're up.
Hello? Good afternoon, everyone. As the chair just mentioned, I'm Kendra Zoller, Deputy Director of Legislation. The commission has prioritized an active role in policy making related to mental health policy and practices and is routinely asked to provide guidance on legislative proposals that would impact the commission's operations or result in new duties for the commission. We are 5, almost 6 months into the 2023-2024 legislative session, and we will hear about 2 bills today whose goals and objectives are consistent with the priorities of the commission. Both bills are moving through the legislature with the hopes of being passed by the legislature in September and signed into law by the governor by October. For your reference, I've included the 2023-2024 legislative calendar, as well as a chart showing how a bill becomes a law in California, so you can follow along where we are in the process. First, we will hear a presentation by Brady McCarthy, Legislative Director for Assemblymember Lowenthal regarding Assembly Bill 1282, a bill the Assembly Member's Office reached out to the Commission for guidance on related to the impact of social media on youth mental health, followed by Leandra Clark Harvey, CEO of the California Council of Community Behavioral Health Agencies, who is the sponsor of Senate Bill 509 by Senator Portantino, related to behavioral health training in schools, an effort the commission has supported in the past. We will start with Brady of Assemblymember Lowenthal's office. Welcome, Brady. Please tell us about your bill.
Hi, everyone.
Hello,
Can you hear me?
we can.
Wonderful. Thanks for allowing me to join today and talk about AB 1282. I'll start by letting everybody know, as Kendra referred to, the legislative process that AB 1282 just passed the Assembly floor with bipartisan support, and it's on its way over to the Senate now. AB 1282 follows along with one of Assemblymember Lowenthal's top priorities as he's come to the legislature, which is taking a look at the impacts of social media use on mental health. And he is particularly concerned with the impacts that have been reported and that are still being researched with regard to youth and adolescents. I think the need and import of this bill was really highlighted by the Surgeon General's advisory that was issued on Tuesday of this week, which really pointed to the reason why we're running AB 1282 and highlighting the fact that, broadly speaking, children are using social media and social media platforms more and more and more. Our lives, are a lot of the information that we receive, the way that we communicate ideas is now being conveyed and through social media, and that has become one of the primary platforms through which we're absorbing information, and none probably more so than children these days who are now utilizing social media platforms that are designed for adults. And many of the platforms themselves would recommend that a user be 13 years of age. However, it's clearly evidence that users are much younger than that. A lot of users are starting as early as 8, even younger. And so while we've seen legislation that has been used in order to help regulate social media further, which remains a relatively unregulated space, we don't currently have a statewide strategy or game plan in order to address the impacts and the potentially negative mental health impacts that young children and adolescent users are experiencing as a result of their interface and interaction with social media platforms. And so in collaboration, and I would definitely like to thank both Toby and Kendra for their input and help in developing and crafting this piece of legislation, and to the commission as well. We feel that implementing a game plan, and if you take a look at the bill, it does require robust stakeholder involvement and engagement in developing the game plan and getting feedback from both children and adolescents who are being impacted from their own use of social media, as well as the scientific and data-backed information that we need in order to have a really informed game plan for the state to implement in order to reduce the potentially negative impacts of social media use among this population of users. And so I'll keep it brief in that regard, but that's really what we would like to see here in order to make sure. I think one of the conclusions that's drawn in the Surgeon General's advisory from this week is that we simply don't have time to wait. There is still more research that needs to be done in order to really understand the full impact that social media use is having on children and adolescents, but we don't have time to wait in order to see what that impact may be. We need to be able to be acting right now, both through additional regulation of the social media platforms, but also having strategies in place in order to make sure that we're reducing any potential harm or making sure that parents, teachers, communities, and other stakeholders have the tools that they need in order to keep this current generation, who really have kind of been the guinea pigs of an unregulated space from experiencing significant negative outcomes as a result of their use of these platforms. With that, I'll go ahead and conclude and turn it back over to Kendra.
Thank you, Brady. At this time, I think it's for commissioners to ask questions about the bill.
Commissioner?
Just question, how much has artificial intelligence been factored into this bill?
Currently, the bill does not address artificial intelligence explicitly, but those are amendments that we are working on presently. And we do plan to include the impact of artificial intelligence with amendments that will be taking over in the Senate.
Could we ask, could we just get a little more detail of what exactly the bill does? What does it prohibit? What parameters does it set?
The bill would require the commission to develop and deliver a report to relevant policy committees in the assembly that provide a game plan. This is taking a look at best practices, current research and data surrounding social media platform use, particularly use amongst children and adolescents. Through that process, in developing the report and the game plan, it requires that the commission engage in a stakeholder process to make sure that there is sufficient feedback from both the users themselves as well as researchers and individuals who are engaged in collecting data surrounding social media use and potential impacts.
Please, Commissioner Danovich.
Yeah, I think that the impact of social media on teen mental health has actually been very, very well established. And there are many, many factors that contribute to the incredibly high rates of depression and suicide rates and other mental health problems in kids. But there's really strong evidence that the current increase that we see correlates strongly to the moment in time in 2010, 2012, when social media usage became a majority rather than a minority, when it crossed from 50% to 80% among kids. Also, among the public health factors that contribute to teen mental health that are controllable, very few, many of the things, the socioeconomic issues and loneliness and all these are very difficult to control, but social media usage can be directly controlled policy. So I'm 100% supportive of this. I'd like to see us take more decisive action. I believe that there's several states that are passed legislation prohibiting use of social media among kids before the age of 16. I think that there's really good grounds to take that type of action and push out access to social media, given all the known harms and the emerging harms.
Thank you, Commissioner Danovich. Commissioner Carnavale, please.
I'd just like to add to that. I agree with that. We need more action, and to me, it's more nuanced. The source of the problem are the algorithms that the tech companies are using that are basically controlling the kids' brains through dopamine addiction. But there's also good social media as well. So it's a double-edged sword, but I do not see an effort to engage with the private sector companies that are providing these algorithms. And really, you have to get to an algorithm level if you want to address this problem. That's the drug that is the substance abuse. That's where it's happening. So I think I would encourage that kind of action happening in California. And if we can't do it in California, I mean, who's going to do it? All the companies are here.
Thank you, Commissioner Carnavale. Vice Chair Alvarez, please.
Thanks for the summary and for the additional information. I think this conversation actually links to our previous conversation around a strategic direction and the commission's role. So if I'm understanding correctly, you're asking the commission to write a paper that outlines recommendation for how the state should address concerns with social media and its impact on adolescent mental health. Is that right?
That's correct. Yes. We are asking that the commission take a look and receive feedback from both users themselves as well as the scientific community, those that are engaging in research, and then report out best practices, strategies that the state can implement in order to ensure that we're addressing, not only what we view, not only the way that we regulate social media, and that's important, and that is definitely key to the conversation that we're having in terms of policy and regulation. But we have a generation of kids right now that are using these devices as we speak, and we don't have a game plan or a strategy at the state level that's saying, how do we make sure that those users that are already experiencing mental health impacts, how are we making sure that they're supported? How are we making sure that we are trying to reduce or mitigate the negative mental health outcomes that we're already seeing? The CDC report that came out earlier this year, really points to the anxiety and depression that are being experienced by children in school, and social media is a contributing factor to that. And so we want to make sure that through this report and the game plan that's established through the report, that we have a strategy moving forward in order to address the impacts that are being experienced by children and adolescents right now.
Thanks, Brady. And I don't mean to imply can do in response. Is this on? Yes. Okay. My question was more so around where the commission's responsibility stops and starts, and the opportunities to collaborate with other relevant agencies, such as the Department of Public Health, the Attorney General's office that has also initiated an initiative around this work and expressed serious concerns. And again, trying to think through, as we think of our strategic direction as a commission, how can we be more influential as a leader by working in collaboration with our partner agencies? So thinking that through as part of our technical assistance could potentially help then move action items forward so that it's not a report that sits on the shelf, but actually has actionable next steps.
Wholeheartedly agree with that, and sorry if I'm speaking out of turn, but definitely think that it would be worthwhile to collaborate with other agencies that are working in this space. And then, as a requirement under the provision of the bill, we do ask that the report is delivered directly to relevant policy committees so that any policy recommendations can be taken under consideration by the legislature. And then the assembly member himself is currently working on developing a select committee that will take a look at the impacts of social media use on mental health. And we really view that there's a strong correlation between the work of the commission, what will come out of this report, and what subsequently we will be working on through that select committee once it's authorized. So we do hope to collaborate continually in an ongoing fashion with the commission.
Thank you, Brady. Any other questions or comments from commissioners? Okay, seeing none. Kendra, I'm going to ask you to go ahead and please introduce our next guest.
Great, thank you. Next, we will have Leandra Clark Harvey, also virtually, to present on Senator Portantino's bill, SB 509. Welcome, Leandra. Please tell us about your bill.
Thank you so much. Thank you, esteemed commissioners. Thank you for the opportunity to present to you today about SB 509, which is authored by Senator Portantino, and I will share my screen as instructed to. I also want to thank Kendra Solar for the work that she's done in organizing the presentations today, reaching out. It's always great to acknowledge good staff work. So you all should know that she's working really hard and we do appreciate it. All right, can you see my screen?
Yes, we can.
Wonderful. I'm like, somebody talk to me. I'm in virtual land here. I can't see you well, but thank you. So Senate Bill 509, as I mentioned, is authored by Senator Portantino, and it is sponsored by CBHA, the California Council of Community Behavioral Health Agencies. We were founded by Rusty Seelix, who's a co-author of the Mental Health Services Act, Proposition 63. So really feel fondly about the commission and your mission and how you're enacting it. And thank you for the time to present to you today. Our members, as many of you may be familiar, are mental health and substance use disorder services providers across the state, serving approximately 1 million Californians each year. And our members do it all. They run 988 call centers, inpatient, outpatient care, hospitals, outreach on the street care. They work in hospitals, etc. They do what I call God's work. So definitely want to acknowledge them. They are the reason we exist. And over 40% of our CEOs of our membership and our leadership at those agencies identify as BIPOC. So always wanting to highlight that because it's important and rare in this day and age. And we work hard to make sure that we continue to diversify the folks that belong to our association. Senate Bill 509, it may look familiar because, as was mentioned in the opening comments, you all have supported similar legislation in the past. Senator Portantino has worked alongside CBHA for a number of years. I think we're going on our 5th year of working on passing legislation and really promoting legislation around youth behavioral health and how to help those that are in their school environments, their teachers, the cafeteria lady, the PE instructor, the bus driver, really recognize the signs and symptoms of a behavioral health disorder. And with the pandemic, upon us and still with us, it's even more important, as many of you are familiar with the statistics around how youth were really transitioning back to school and having a lot of behavioral health difficulties. And on top of that, teachers who say, I studied to become a teacher, not a mental health professional. I need more help. I need to know if this is a behavioral concern or if there's something deeper, and I don't know how to see that. The truth is that right now, schools can ask that their LEAs at schools provide training on behavioral health, and some do. Some have great training programs, but not enough do. And we're hearing from more and more teachers and personnel in school settings that say they want to know more, they want to be prepared for what they're seeing in the classroom. So what does this bill do? This bill would require that 75% of certificated and classified staff would have to take a training. Now, which training? It's up to them. We did have a bill, SB 14, a couple of years ago that focused on directing CDE, the Department of Education, to create a list of kind of, gold standard best practice trainings for schools to consider. And then this bill will really build upon that by saying, okay, there's a list of trainings that you might consider, and let's make sure that that happens, that 75% of your staff by 2027 have taken a training course. We really do believe that just as folks are required to take sexual harassment, other trainings, CPR, first aid, that they should also take a mental health first aid or similar type of training and provide that to everyone in their school community. This bill is not targeted just at teachers. It's targeted at everyone that's going to have an interaction potentially with a young person on a school campus. We did exclude licensed mental health professionals if they would like to be. And if there's someone that has already, let's say, recently taken a training, they can count that towards this requirement as well. We're asking that schools have some accountability and report the percentage of the staff that's trained as part of their already mandated school safety plan, really just adding this data in there so we have an opportunity to look at that and measure the effectiveness. And then also there's a portion in the bill, language that talks about pupils grade 1 to 12 receiving some type of mental health education at least once in junior, high or middle school, and elementary as well, and then at least one time in high school. And this language, I want to credit it to the to NAMI and the California Alliance of Child and Family Services. They did have this language in a prior bill that Senator Portantino authored, and we have agreed to include that language this year in this bill. So I want to give them credit for that good legislative idea. This is our support coalition, organizations that have been working closely with us to promote this legislation and really support it as it goes throughout the process. And at this point, we have a list of supporting organizations here, over 25 organizations that are also writing in letters and registering their support. And we hope to have the commission support as well. That's information for folks on our policy team who you can follow up with if you'd like to. But I'll stop here to take any questions that may arise. Thank you for the time.
Thank you. Commissioners, any questions, comments? Please, Commissioner Rowlett.
I will state for all transparency that in addition to having the privilege of being a commissioner, I'm also the board chair for CBHA. And so enthusiastically support this and the work that the Senator and Leandra and CBHA is doing. I recognize that as my friend and colleague, Superintendent Dave Gordon said, that schools are a place where many manifestations of stress, anxiety, all the things that we sometimes refer to as the social determinants are recognized firsthand. And so again, I think that this is a step in that and ameliorating some of that, supporting children, supporting teachers, supporting staff, supporting parents, and most importantly, supporting the core of our society, families. So again, I enthusiastically support this.
Thank you.
Thank you, Commissioner Rowlett. I have a question.
Sure.
So it says 75% of certificated and classified staff take training by January 2027. And then what? Is it, do we expect them to take it again and then how often?
So this is where policy meets politics, right? So this is a one-time requirement that we're starting with. Of course, we would love to say this has to happen all the time and forever. It's a negotiation that happens between the author of the bill and the committees and the other folks in the legislature. So this is where we're at this point. But I will say that, you know, CBHA is very supportive of the policy of continuing to require this type of training, but that's where we're at this point. So,
thank you. I'm sure you know my position, my heart and my mind are 100% with this. I think when we can build just the capacity and open up the eyes and knowledge of our staff on any school campus to look at behaviors with a different lens. I think this is critically important. So I applaud this effort and thank you so much for being here today. Any other questions or comments from fellow commissioners? Commissioner Mitchell.
I am curious if this bill calls out specifically mental health first aid, since that's so popular, that's used in private and for sure in private.
I think she answered and said that they're letting them choose which curriculum, but I could be wrong. Is that correct?
No, this bill, it's a great question because it is a popular training and our state has recognized that training and provided grants through the Department of Education. So it is top of mind for many of us. And obviously our association in all candor is a member of the National Council for Mental Wellbeing, which is the trademark association for mental health first aid and youth mental health first aid. But the bill is written in such a way that other programs would be eligible. And we also made some amendments with SB 14 so that if schools already had, for example, I believe it was LAUSD and another school district that had come up with their own training and were able to, verify that it was, community defined and it was best practice for the students in their school, that they were allowed to utilize that training as well. That was a big part of our conversation with SB 14 as it directed the Department of Ed to create a list of trainings that we also make sure that we weren't excluding community defined best practice interventions that could also be utilized within school settings. So we did add language into SB 14 that would allow for that. So.
Commissioner Gordon also has his hand up online.
Thank you. Commissioner Gordon, please.
Thank you. I just have a question. How was the mandated cost aspect of this handled? What would be the mandated cost estimate of requiring this?
So we leave that to our colleagues in appropriations to put a price tag on that. And this bill is still going through the process. It did pass the appropriations committee and it will go on to the second house where we'll get the final cost that's estimated. But what we do want to highlight is that the Department of Education has had several grants for different types of training, including youth mental health first aid and others. And so with those grants, they have been able to fund several districts across the state to provide this type of training gratis at no cost to them. So we do believe that there are opportunities for schools to offer this at low cost. And then because our association, CBHA, we hold an annual mental health first aid summit for many of the trainers across the state. And we know that the trainers are open to negotiating with lots of schools to provide low cost training options as well. So it can range in terms of per person at these trainings, or schools can go in for like a larger discount rate, at least with youth mental health first aid, and hopefully with the others as well. So I don't have a direct answer to the price tag that has been or that will be affixed to the bill, but we know that there are lots of opportunities to get this training to the community and schools at a low cost.
Commissioner Gordon, was your question?
Yeah, yes, thank you.
No problem. And I'm happy to provide updates to the commission. And I know your staff is tracking various legislation as well as it goes through appropriations and other committees in the respective houses that will give them their final price tag.
Thank you. Any other questions or comments? Okay, I see none. So at this time, I want to thank our presenters for being here today. I want to thank Kendra for putting this panel together, and we are going to move to comments from members of the public. You may request to make a public comment on agenda item 8 by clicking the raised hand button on your computer or the app, or if by calling by phone, push *9. Once the public comment period for this agenda item starts, we will close the public comment queue. So please make your request to comment now. Are there any public comments? Please raise your hand now as the queue will be closing. We are going to ask that you please limit your comments to 3 minutes or less. Mariani, please open the line for public comment on agenda item number 8. And let's start with the people in the room, please.
We have no in-room comments, but we have 2 online comments. The first one is Stacy.
Hello, Commissioners. Stacy here. Oops. Let me turn myself on. Hi, Commissioners. Stacy Hiramoto with REMCO, the Racial and Ethnic Mental Health Disparities Coalition. I'd like to urge the Commission to support SB 509, sponsored by CBHA. It was a great presentation. I'd also like you to consider in the future a bill sponsored by the Children's Partnership and REMCO, which is AB 289 by Holden, which strengthens the participation of youth and BIPOC communities on local planning, in the local planning process in the MHSA. So I hope you consider that bill. It's very popular. I would also hope that the Commission will keep abreast of SB 326 by Eggman, which is the vehicle that we believe that the governor's proposed changes to the MHSA will be amended into. And so I hope that you will be able to meet. I know you don't have a ledge committee, but if the language goes into that bill, I hope the Commission will be able to make comments on it expeditiously and, during the committee process or wherever. Thank you.
Thank you, Stacy.
Next, we have Danny. Your line is open.
Hello, my name is Danny Therical. I am the Public Policy Coordinator for the California Youth Empowerment Network, also known as CIAN. We are a youth-led program of Mental Health America of California, which is also a peer-run organization. I'm here to I'm here to ask your support for SB 509. Behavioral health challenges can start at a young age and when recognized, can be addressed with support and services that foster healthy early childhood to transitional age development. The ability to recognize those signs and understand what they mean requires consistent education and training. This bill could help our teachers identify and even our youth self-identify some behavioral health challenges and seek help by establishing that consistent behavioral health education from elementary to high school. As our youth understand more about themselves and ask to seek help, it's important that we have a strong support system in place as well. And under this bill, school employees would also receive behavioral health trainings on the signs and best practices. This transforms our school into a safe and nurturing environment for our youth and child development. Thank you.
Thank you, Danny.
That was our last public comment.
Thank you, Mariani. Now that public comment has closed, I would entertain motion on AB 1282 that the commission supports AB 1282 and directs staff to communicate its position to the governor and the legislature. After that, we will vote on AB 509.
I'll move support.
Thank you, Commissioner
Dave?
Gordon. Thank you, Commissioner Bunch. We have a motion and a second to approve the motion. Any additional questions or comments? Seeing none in the room, I would ask that Jeff please take the roll.
Commissioner Bontrager,
Aye.
Commissioner Boyd, Commissioner Brown. Aye. Commissioner Bunch,
Aye.
Commissioner Carnavale,
Aye.
Commissioner Carrillo, Commissioner Chambers,
Aye.
Commissioner Chen, Commissioner Cortese, Commissioner Danovich. Aye. Commissioner Gordon,
Aye.
Commissioner Mitchell, Commissioner Rolette, Commissioner Tamplin,
Aye.
Vice Chair Alvarez, Chair Madrigal Weiss.
Aye.
Madam Chair, the motion passes.
Thank you so much. I want to congratulate and thank Kendra Zoller, first time in front of the commission. You did an excellent job. Thank you so much for doing it. Oops, and that's not all. Next, I would entertain a motion on SB 509 that the commission supports SB 509 and directs staff to communicate its position to the governor and the legislature. Do we have a motion?
So moved.
Thank you, Commissioner Carnavale, and a second.
Second.
Thank you, Commissioner Brown. Are there any additional questions or comments? Seeing none, I would ask that.
So we don't know the cost.
We don't know the cost.
We don't know the cost of the legislation. Just the reality is we're I'm asking about the cost of the legislation, just recognizing that that's an important consideration to keep in mind as we're in our budget situation.
So as mentioned during the presentation, that you're correct, we do not know the cost. But at the same time, we recognize that the need is there. And this is consistent with conversations we've had with young people over the course of the last 5 or 6 years. And so per the comments, that's being worked out as the bill moves forward. And there are provisions for the state to provide funding. And typically that's negotiated as the legislation progresses. We can certainly monitor this and come back to you on those cost issues. If that would be helpful. And the commission could certainly sort of delay a vote if that was your wishes, subject to some clarification on that. But I think as you heard, there's some, they're working through that.
Did you? Okay. All right. So I would ask Jeff, continue, please.
Commissioner Bontrager,
Aye.
Commissioner Boyd, Commissioner Brown. Aye. Commissioner Bunch, Commissioner Carnavale,
Aye.
Commissioner Carrillo, Commissioner Chambers, Commissioner Chen, Commissioner Cortese, Commissioner Danovich, Commissioner Gordon,
Aye.
Commissioner Mitchell, Commissioner Rolette, Commissioner Tamplin,
Aye.
Vice Chair Alvarez, Chair Madrigal Weiss.
Aye.
Madam Chair, the motion passes.
Thank you so much, Jeff. Thank you, Leandra and Brady. Thank you for being here and sharing the information with us. And again, Kendra, thank you.
On the cost issue, I'm sorry, can I make a quick comment? Is that appropriate? Just to provide any assurances, because I thought I heard a comment come up. It's a little hard to hear online.
There was a question, so if you want to, please.
Thank you for the opportunity. The Senate Appropriations Committee did say that the cost of the training is unknown. And as I mentioned, there's a lot of different ways to get that reduced or free through the state. But if their estimation was, well, let's say it's $150 per person, which it is not. I've seen some folks put it on for $25 to $50 per person, that they would estimate in the tens of millions of dollars potentially. That when you look at the grand scheme of the budget, that is not a huge number when we're that's, and sometimes it's referred to as budget dust. So there is a way to do it without costing the state too much, costing the Department of Education, and we'll continue to look at that and update you all on that as well. So we appreciate your consideration of that.
Thank you. Okay, with that, we are going to move on to agenda item 10, the impacts of firearm violence. We are going to have a panel, as you are aware. This is one of the priority initiatives identified by the commission in January. To highlight the importance of this initiative, the Gun Violence Archive reported that as of May 1st, 2023, 13,959 people have died from gun violence. Of those who have died, 491 were teens and 85 were children. The majority of these were deaths by suicide, but there have been 184 mass shootings in 2023 so far. I look forward to hearing from our panel members and the public on this important issue. I'd like to invite Commissioner Bunch to introduce our presenters and facilitate the panel.
Thank you, Chair Madrigal-Weiss. Today's panel is a vitally important one, but it's also one that may be tough to hear at some points. I want to encourage everyone to take care of yourselves as we discuss this sensitive topic. If you need to step away at any point, please feel free to do so. With that said, I'm really excited to introduce you to our amazing panelists. We have some really great speakers today who are going to share their valuable expertise and lived experience in the areas of trauma, firearm violence, and community-based solutions for intervention and healing. First, we have Kevin Cameron. Mr. Cameron is an internationally renowned expert in threat assessment and crisis response. His model has been used across North America to identify risk, intervene effectively, and respond from a trauma-informed, recovery-oriented perspective. He's a trained marital and family therapist and registered social worker. He has years of experience working with high-risk children and their families, and his work in the field of violence threat risk assessment focuses on understanding perpetrators of violence in the context of their family, peer group, workplace, and society. I've personally taken his VITRA training several times, so I'm thrilled to have him present it to us today. Kevin, thank you for being here.
a long time. Yeah, you hold it. There we go. All right, how's that? Lovely? Bless your hearts. Thank you very much, folks.
If I don't like what you're saying.
Oh, wow, it's actually still not staying on. That's 20 minutes, eh? 19 now. All right. Bless your hearts. Thank you very much. And thank you for the invite. So I actually work on both sides of the border, United States and Canada. And as Commissioner Bunch said, work in actually three areas that usually aren't seen as interconnected, but they very much are. The fields of high-end violence threat risk assessment, crisis and trauma response, and in all honesty, family assessment, family dynamics, et cetera. And I could probably ask you one simple question. Because schools and young people came up, I just pose this rhetorically. But could a student be high risk for violence in school A, yet low risk for violence in school B? And if you actually consider that, then it actually means it's not all about individual pathology either. So that even though we're talking about gun violence and mental health issues, et cetera, the reality is 10 people can engage in the exact same act of violence, pulling the trigger, sticking a knife, et cetera, yet for 10 different reasons. And what becomes so compelling in the work is actually understanding the interconnectedness between a number of different things, including a term we coined several years ago, my colleagues and I, which we refer to as the trauma violence continuum. And the trauma violence continuum, in essence, denotes this. Of course, we understand that serious violence begets trauma. There's no question about that. But we also understand that trauma in and of itself can beget serious violence. What that means is that we could have an individual, for instance, as a child, exposed to a daylight shooting. And in the end, maybe police show up to interview them as a witness. And by the way, they've got nothing to share. They didn't see anything. And we understand that in my career as immersed working with police also. Nevertheless, time goes on, but often no one has thought to cycle back nevertheless to that child, to their parents, to their caregivers, and wonder how they're doing from a trauma perspective. Well, interestingly enough, whether you're aware of it or not, I don't know. I mean, I actually haven't heard it talked about a lot today, so I sat in the back as a visitor thinking it'd be kind of cool to hear the conversation. Everybody's aware that we have come out of a 3-year pandemic, if you will, and there's still lingering effects. But I do want you to know that everything we will deal with, even from a mental health perspective, for at least the next 3 years, is laid on the foundation of what we refer to as a delayed response to trauma, meaning to a 3-year worldwide pandemic. And kind of one of the jingles I use, so in case you don't pick up on it or not, actually, as I said, work in both countries, but I am actually a born and bred East Coast boy from Halifax, Nova Scotia, Canada. So that might explain a few things as I get rattling on here. But suffice it to say that it's become very evident that when we look at trauma and trauma in human systems, including high profile trauma, then I have a little jingle that I like to use, which is this. Generally speaking, high-profile trauma does not create new dynamics in human systems. Instead, high-profile trauma simply intensifies already existing dynamics in human systems. That has to do with mental health struggles, and that has to do with societal dynamics also. So, for instance, in the aftermath of the George Floyd tragedy, I received many calls from colleagues on both sides of the border who are in awe of the protests and or civil unrest that occurred in the aftermath of that tragedy. And as I restated to many that I have trained over the years, the George Floyd tragedy did not create or cause all of the protests and or civil unrest that occurred. Instead, the George Floyd tragedy simply intensified already existing dynamics in America. And by the way, in Canada also, for those of you interested in the broad implications. Well, then as we look at it from that particular perspective, then we say, so what did happen over the last 3 years? And I've heard some conversations with kids. When it comes to gun violence, you know that in the end, we are the most concerned with our kind of 22-year-olds down to maybe 16, 17. But I got a jingle for you, which is, especially coming out of the pandemic, regression is the norm. Regression is the norm. And what that standard means is that if you want to understand what's going on with young people, and I mean 22, I mean 20, I mean 18, 16, all you need to do is subtract 3 years from their chronological age, and then you'll understand what the flip is going on. For instance, when I work with schools and district leaders, principals, counselors, and others, and for that matter, even teachers, I'll say, you know what? If you subtract 3 years, then that explains why grade 12 teachers are going, oh my goodness gracious, that explains why our kids are acting like they're in grade 8 or 9 when they're under stress or duress. Also, if we take it down to, for instance, I joke, but it's true, the elementary teacher was tired of teaching friggin' grade 3s who decides to go and teach grade 6. And all of a sudden now, it's like, oh my goodness, I feel like I'm back in early elementary school. We subtract 3 years. Why are young people in kindergarten and grade have shown up very different, if you will, than they did prior to the pandemic? But also, there are some things that occurred during the pandemic. So, as was noted in my bio, I have a very unique position because of working in 3 intersecting fields of threat assessment, trauma response, and family assessment, family dynamics. During the pandemic, we and my colleagues really focused a lot on the effects of quarantine. Now, I want to be very clear, this isn't me taking a position in relation to quarantining and whether it was necessary or not. The reality is that we quarantined. And we knew, those of us especially who are sort of purists in relation to human systems dynamics, knew that during quarantine, there was going to be some difficulties for some families. And part of it is actually based on this. When I was trained years ago, and by the way, I'm actually a graduate of Loma Linda University. I have a master's in marital and family therapy. I'm not Seventh-day Adventist, but it's a really darn good program. And I was trained in one dynamic that probably was brushed over in 5 minutes or less, called the closeness distance cycle. And I didn't provide any handouts or whatever it may be because I was too busy. But we'll probably provide a link if interested for some of the guidelines that we put out, including preparing for post-pandemic mental health, and this one on the closeness distance cycle, which is a family dynamic. The closeness distance cycle, simplistically put, is this. I don't care how much you love somebody, you can only be stuck together with them for so long before they start to get on your nerves. Would you guys agree? And so, even in the best of families during quarantine, a few folks had some anxiety moments. And another jingle for you. The higher the anxiety, the greater the symptom development. Well, the reality is, during the pandemic, no question about it, families whose pre-pandemic functioning was already somewhat impaired, if they were, for instance, on the cusp of abuse, i.e., a mother, a father, 2 parents, caregivers, who maybe one even decided they were about ready to leave this relationship, they just didn't tell their partner, and part of it was the anger building inside of them. Then the pandemic comes along, they're forced into quarantining, but they still have the anger. We got some kids out there that we have inherited in schools, for instance, who first time ever have been witnesses to abuse behind closed doors, courtesy of quarantine. But we also have others who actually had already been exposed to abuse, off and on have been witnesses to it. And folks, quarantining was not going to make things better. All quarantining was going to do was intensify already existing dynamics. It was interesting, as I consulted with large hospitals and health regions across North America, I want to be very clear that one of the things that I said was, we're going to have to pay close attention to what is going to be our inheritance that is going to come out of this thing. Because first of all, when it came to kids, and I was interested, I had no intention of talking social media or its relevance to what we're dealing with. But courtesy of the conversations today, I want to be really, really succinct about this. We knew that kids, because of the impaired closeness distance cycle, where they were going to be compressed together with their families in some in dangerous situations, that the only way they're going to be able to lower the anxiety and survive is to create opportunities for distance, which happened by the kids staying up till 4 or 5 o'clock in the morning and immersing themselves in online behavior, while many parents and caregivers actually went to bed 2 hours earlier, got up 2 hours earlier, while many of the kids slept till 3, 4 o'clock in the afternoon and then repeated again. We know, interestingly, and I actually confess, I don't know your national statistics, but I'm sure somebody can look them up while I'm here because you've all got iPhones, just like the kiddies. But I will tell you that in Canada, as of the second year of the pandemic, we had an 88% increase in online sexual exploitation of young people. That is only the recorded cases. That does not include those who have not come forward. Well, when we start to look at all of that behavior, then we know that lots of kids got in over their heads and are bearing secrets. And I will tell you that one of the initiatives that we should really be looking at is how do we communicate to parents, to caregivers? Because I'm telling you, when I say regression is the norm, subtract 3 years from the kids, I'm going to tell you that some of us in this room, we can subtract 30 years from us and discover that many adults did not behave as well as they thought they would behave behind closed doors either. And I say that because in essence, and as a trained marital therapist also, never thought this would be so useful this far into my career. Oh, by the way, I've been really busy during the pandemic, considering how many impaired relationships there have been. But I will tell you that from a human dynamic perspective, none of us are half as mature as what we like to think we are. None of us, myself included. And if that statement pisses you off, you're immature. So the reality is, because of the weight actually that has been on many individuals during the pandemic, I'm here to tell you there are some parents who are weighed down and caregivers with guilt because they crossed some lines also. If we really want to look at, for instance, violence, gun violence, knife violence, for instance, we have made it very clear in the guidelines that we put out, if you will, for the world to have access to. We made it clear that we knew we were going to see, not only in our delayed response to the pandemic, but we were going to see a massive increase in weapons possession amongst young people, guns, knives, etc. One of the reasons why we knew that it would occur is, as I already said, all high-profile trauma does is intensify already existing dynamics in human systems. But also we knew that it would increase because the children know the truth. What that means is before they actually came back from quarantine the last time, surely you would concur, the kids knew who was threatening who online. They knew, by the way, who had the naked pics of a peer. They knew who either had already sent pics or was threatening to airdrop them to everyone inside of their school. Because the kids knew all of these things, then in the end, it's pretty simple. If the children, and I mean kids and adults, and adolescents, generally speaking, when it came to threat assessment cases, most of our time was spent dealing with high school kids and sometimes middle school kids. Coming out of the pandemic, we've never had more threat assessment cases with elementary age students than we've had currently. And by the way, more sexualized threat assessment cases than we have ever seen. And so we knew that weapons possession would be huge because in essence, the kids have a simple formula, whether they realize it or not. If children and adolescents feel that we, the adults, are either unable or unwilling to keep them safe, then the kids basically decide to arm themselves. And so that weight, of course, has come on the kids because they've entered knowing everything that has gone on. One of our jingles actually has been to say that we actually need to convince the kids that we can handle the truth, that we need to convince them that we understand what happened during the pandemic. And we also have to convince parents and caregivers also that we understand that it was a difficult time. By the way, that actually means less stone casting, if you will, and more actual genuine caring for what happened to the world and how it did intensify symptom development. Well, interestingly then, when we go and we take a look at our work around gun violence, just around violence in general, a simple standard is that serious violence is an evolutionary process no one just snaps. And that in actuality, it's often a painful evolutionary pathway for many individuals. But some folks have time to think, to fantasize, to build in justification. And then what happens often is the right set of circumstances occur that allows somebody to cross that line. But if we only look at gun violence or violence in general as if it is a mental health issue, then I will tell you, we have more than enough data. And, you know, even the FBI actually did a really good job in a large meta study that they did in relation to mass shootings in America. And one of the things actually that doesn't seem to be fully understood by some, others do, is that the idea was that anybody who would take a gun and engage in a mass killing surely was struggling with major mental illness. But as a therapist, when I use that language, I'm referring to significant thought disorder, for instance, not, by the way, things like depression, anxiety, etc. And what became very clear in 400 plus mass shootings was that approximately 25% of those were carried out by individuals with major mental illness, where it was either diagnosed or could have been diagnosed. But that doesn't account for the other 75%, by the way, who painfully moved on that pathway of justification the way that we have described in our work. Interestingly enough, here, and credit to Los Angeles County, Mental Health, LAUSD, etc. First time I came here back in the day, for those who know some of the originals, Dr. Tony Belize was with LA County Mental Health, Dr. Marlene Wong was with LA Unified School District, and I did early trainings back then that were part of the foundation for the START program for LA TARP and other things. And it's interesting, but from that early work, we recognize that in actuality, one of the most missing links in my early work was the role of undiagnosed or untreated trauma. Now, when I talk about, again, the whole idea of thought disorder versus, if you will, mental health struggles contributing to risk, there is no question about it, folks, that often in the majority of our moderate to high risk VITRA cases, so your name, threat assessment, but
Kevin, can I ask, we're going to go ahead and have the handheld work, so we don't have Kuko.
oh yeah, sorry, I can. This thing here. There you go.
We turn that on?
Yeah, it is on. All right.
Okay.
No, I'm good.
Oh, he's going to get the handheld to work, so that
All
way.
right. Sorry about that.
My finger was starting to hurt watching you.
Well, I'm glad you did that because then I was going to have to hold it for 20 minutes for my colleague here too. So thank you. So for my last 3 minutes, let me just say, is that when we look at even gun violence or violence and its link to mental health issues, there is a difference, if you will, from thought disorder, which by the way is misrepresented by many people as a primary cause, versus individuals who are in emotional pain, including undiagnosed, untreated trauma, that often leads them in distress to eventually consider two potential pathways: one violence, one suicide, or a combination of both. And I'll conclude just very simply, and some of my colleagues who are on the panel will no doubt fill in some of the blanks. I'll say that in the work of violence threat risk assessment and trauma response, three primary hypotheses when people come to our attention, because most people who engage in major acts of violence do give us pre-incident signs and indicators, as subtle as they may be sometimes. If folks are trained, we can see it coming. We can't prevent everything, but we can prevent the most. But three primary hypotheses that guide our work. First hypothesis, many people engage in threat-making, threat-related prior to, as a conscious or unconscious cry for help, is the first hypothesis in our work. Second primary hypothesis is conspiracy of two or more, and that needs to be further discussed, because often one individual may pull the trigger, but there is often a puppet master in the background, adding to the justification process, building their anger, if you will, and then they end up being the one engaging in the act of violence, and we miss the one in the background who often move them to it. We see this in our policing, if you will, cases all the time. And the third hypothesis, is it possible this person who made a threat is actually more suicidal than homicidal? And that, without a doubt, occurs with many types of individuals. And then what we're dealing with in this generation is that sometimes people in emotional pain decide, if I'm going to kill myself, the suicidality, then if I'm going to kill myself, maybe I should go out with a bang. And then often we see, if you will, that played out in a dramatic fashion. But I'll conclude and say, 10 people can engage in the exact same act of violence, but for 10 different reasons. And 10 other people can be exposed to the same traumatic stimuli and have 10 completely different responses to it. And so assessment, and multi-departmental collaboration and plans is one of the amazing ways that we can engage in good violence prevention and trauma response. Thank you.
Thank you, Kevin. Next, we have Jose Osuna. Jose wears many hats, but in all of them, he uses his voice to speak for those who have experienced incarceration. He began his career at Homeboy Industries, the largest gang rehabilitation program, entering as a participant and ending up as the Director of External Affairs. Currently, he is the Housing Justice Manager for Brilliant Corners, a statewide housing organization that focuses on developing permanent supportive housing for many types of special needs communities. Jose is also a member of the LA County Public Safety Realignment Team, a member of the Long Beach City Prosecutors Multicultural Advisory Commission, and the lead coordinator for the Long Beach Coalition for Safety and Justice. Jose's passion for this area comes from his lived experience with firearm violence and incarceration, which he'll tell us more about today. Jose, thank you so much for being here with us. We're ready to hear your presentation. Please. Whichever one, right, the other one, because that one is on.
All right, can you hear me?
We can, thank you.
Okay. Thank you for that introduction. And I want to thank the commission for inviting me to share a little bit about, what I've been able to live through and how that has now turned into a really great professional journey for myself. I want to, since you rattled off, my 20 different hats that I wear professionally, I wanted to start off by talking a little bit about my lived experience. We're here to talk about gun violence and it's the connective tissue that it has with mental health. And so I want to let this commission know that I'm both a survivor of gun violence. I've been shot myself on 3 separate occasions. And I'm also a survivor of a great loss. I lost my 17-year-old son to gun violence a little over 15 years ago. It'll be 16 years in August. But for many, many years, unfortunately from the age of approximately 10 years old to the age of 35, I was a perpetrator of gun violence. I was a member of a very violent street gang in the city of Long Beach for most of my young life and some of my adult life. Fortunately, that isn't the case anymore, but I come to this commission carrying, both sides of that experience. And what I can say is this, that mental health and addressing my mental health issues, my needs, has really been the pivot for transformation, right? Transformation of the way that I saw myself and I saw the world. And my place in it, and a transformation in how to deal with different situations. Unfortunately, I discovered mental health help through losing my son. When my son was killed, unfortunately, there was no team of therapists or mental health professionals that arrived at my home the morning after my son was murdered in front of my home. Unfortunately, what happened for me is that, 50 members of law enforcement showed up at my house and pulled my family outside of our house in order to search my residence in fear of some type of retaliation. And probably justifiably so. I'm not going to say that they weren't justified in feeling that way. I was a very active gang member. I perpetrated a lot of violence, as I said. And, because I had been incarcerated for 13 years of my life at that point, I was very high up on the food chain in the gang world. And so law enforcement was justifiably concerned. But I think that if that was coupled with the mental health needs that my family had at the moment, things might have been different, right? The anger and the grief that I felt probably would have been mitigated as opposed to being aggravated, right? And I'm not proud to say this, but as a result of my son's killing, there was a very sharp uptick in gang violence in that part of the city. My son was not a gang member. He just happened to be my son sitting in front of my house when men came looking for me, and they found him instead. But he was very well known, very well loved in the community. And unfortunately, that overflowed into the gang community as well. So there was a lot of conflict after my son's death. I did not do anything to mitigate that violence because, as I said, all I know is that law enforcement responded the way they did, and that was their job. They were doing their job. But other parts of the system didn't work, right? Those parts that are there are supposed to be there to help a family like mine through this traumatic event. It took a long time for me to get to a point where I was able to receive mental health services. And, you know, there have been some policy changes that have changed that circumstance now, but unfortunately, my son was documented as a gang member one day because he was riding in the car with another documented gang member, which happened to be his father. So I was driving my son to school and law enforcement stopped me. They already had me documented as a gang member, and they said, we're going to go ahead and document your son as a gang member, even though he wasn't. This disqualified my family from receiving compensation, victims' right compensation. That policy has changed now, right? But at that time, we were not able to receive any counseling, any mental health help because he was disqualified. He was a documented gang member on paper, and it took an appeal process, right? Like I actually had to work with the Long Beach City prosecutor, and that's how our paths initially crossed. I now serve on a commission for Doug Halbert, but that's how our paths crossed. I had to go to the Long Beach City prosecutor and appeal that and get my son's name pulled from the gang database so that we could then qualify for the services for victims. And I started to receive therapy, and it changed my life. Through therapy, I started to really look at all of the trauma, and I'm glad that you brought up trauma, Kevin. I have a jingle too. My jingle is causing trauma causes trauma, right? So for me, some of the greatest trauma that I have endured and have had to live with and deal with is the trauma that happened to me when I inflicted violence upon other human beings. I didn't understand how traumatic that could be until I had moments to reflect, until I was able to sit down with a mental health professional and talk about how impacted I was by hurting other human beings and how I was still carrying around a lot of that trauma. That journey began for me when I started to receive, you know, grief counseling with a mental health professional, with a therapist. This mental health professional also pointed out some other things that were going on with me. You know, my substance abuse and how that skewed my judgment, how it made things like committing violence easier when you're numb under the influence of a substance. So he helped me to start to address those things, and my life really started to change. And so, you know, I ended up wanting to change my life, and that's when I found my way to Homeboy Industries. A lot of you here, especially from the Los Angeles area, I'm sure are familiar with Father Greg's organization. And, you know, I really was surprised when I walked through the doors and they started talking to me about things. And one of the things they mentioned that they had was their own mental health department. And so that's where I really like to look at like culturally competent approaches to mental health, right? Like everybody's need is not the same. For a lot of times there was this negative connotation around mental health and folks that live, you know, those type of lifestyles, the gang lifestyle, right? At Homeboy Industries, they tend to really shatter that, you know, that preconceived notion that gangsters don't need mental health help. And so, you know, I started to go to therapy there as well. One of the things that really, you know, tripped me out when I was at Homeboy was the very unique approaches that their therapists take to dealing with gang members that are carrying a lot of different trauma. You know, like I said, both trauma that was caused upon them, that was inflicted upon them, but also carrying the trauma of all the things that they've done in order to survive, in order to raise up in the gang world, all the different things and reasons that we commit violence and end up carrying that trauma. You know, I walked by and they do tours there, so I can talk a little bit. So Father Greg had me, you know, be one of the main tour guides there at Homeboy. And I was walking alongside the mental health offices one day, and I saw that in one of the offices, there was a homegirl, and she was asleep on the couch. And the therapist was like doing like her emails or whatever she was on her computer. And I kind of tripped out, like, what's going on here? And I just did finish the tour, and then I went back and I asked her, like, hey, you know, that didn't look very good. Like, people, like, why are you just letting her sleep? And she told me, she goes, well, this is the only place she can sleep. She lives in a home that doesn't allow her to sleep. They're doing drugs at all times of the day and night. There's violence happening outside of her home. This is the only place where she can actually get some rest. So if that's not therapeutic, I don't know what to tell you, right? And so like I started to really take an interest in their unique approaches. I was able to participate in a process called VOGUE, Victim Offender Education Group, where we were actually able to bring together perpetrators of crimes and their victims to hopefully find some closure and some resolution for all parties involved in very violent crimes, you know, sex crimes, homicides, you know, attempted homicides, things like that. And I found that it was very therapeutic for people to like find closure, find resolution, to face that person that had harmed them and be able to ask them why. And also to be able to hear the real whys, you know. So I ended up taking this journey at Homeboy for, you know, almost 10 years that I was there with Father Greg. Ended up becoming their director of external affairs and handling all of their government relationships. You know, and then I moved on from the organization. I got to meet a lot of great people along the way. So I ended up really now building a career out of dealing with, you know, government officials, politicians, a lot of different folks. And my life is so very different than it was when I first decided to change it. But the one constant thing that I've had to keep addressing is my mental health. Because as a professional, I went from service recipient to service provider. And, you know, there's this thing they call stewardship of trauma, where you deal with people that are carrying trauma, that you end up carrying some of their trauma for them at times. And so it's been a constant thing for myself to keep my mental health up. And how does this all connect to gun violence, right? As I said at the very beginning, I was a perpetrator of gun violence. From the moment I started to receive mental health services, picking up a gun has never been an option in my head to react to anything that has happened in my life, right? And prior to that, it was always the first instinct. If someone hurt me, I was gonna go pick up a gun. I didn't like knives or fight. I like guns. That's the way I was. I was gonna go pick up a gun and I was gonna go commit violence against another human being. If someone hurt someone that I loved, I was gonna go pick up a gun and hurt somebody. And there were many times where like I would look at my life and see how in shambles it was during the worst moments, where a gun and staring at it through the wrong side was a real option for me, right? Where I felt like I'd be better off dead. How can I ever get out of this hole that I'm in? You know? But ever since I really started to address my mental health, ever since that was available to me, I haven't had that thought to harm another human being with a gun, to harm myself with a gun. So I'm a real proponent in understanding the mental health needs of all of our community. You know, I think when we talk about gang members, you know, obviously I have a very narrow like perspective and kind of expertise, and it's really centered around gang members for me, right? But that was what I also got to witness at Homeboy Industries when I was there, is that when folks were able to start to deal with their mental health issues, violence became less of a viable option to them. When they were offered other resources, you know, violence became less of an option for them. You know, I think that when we look at gang members in a way that is very similar, and this may come off the wall, and I mean no disrespect by it, but when I was at Homeboy, I got to work a lot with LAPD. I got to work a lot with their training academy. They would come over to Homeboy and receive training sessions from gang members. And I remember a senior officer brought a class in at one point, and I asked this officer, "What's the first thing you think about when you leave your house in the morning?" He said, "I just want to get home safe tonight to my family." And I said, most gang members, that's the first thing they think about when they leave their house too. There's a parallel there, and I think that we need to look at that as well. Whether it's a lifestyle, whether it's a job, because I'm also concerned with members of law enforcement and their mental health needs, and how we expect them to be like these men and women and people of steel and not be impacted by the trauma that they have to witness and sometimes inflict, right? Like that leads to gun violence as well. When you have to be hyper vigilant, when large pockets of the community demonize you, right? Like that's an experience that I trip out that law enforcement and gang members share now. There are large pockets of community that demonize members of law enforcement. Large pockets of the community demonize gang members. When you got to live with that, it definitely becomes a mental health issue. And your reaction to things and to people and to situations can be very skewed. And so I think that's one of the things that we also have to look at as we look at this intersection between gun violence and mental health. Just to close, I really liked when you talked about undiagnosed and untreated trauma. I think for me, that's like one of the core pieces that I'm going to take away from what Kevin talked about, is how many folks are walking around with undiagnosed and untreated trauma, and how are they going to react to that trauma in any given situation, right? If we really start to look at that piece, I think that we can make a difference. So I hope that my rambling is helpful in some kind of way, that you take something away from, you know, the things that I've been able to learn along the way, both personally and professionally. And thank you for your time.
Jose, thank you so much. Thank you for sharing your story. Thank you for being here. We appreciate everything you had to say. If you could stick around, because we're gonna go to our next panelist, but we'll have questions for you at the end. Our third presenter is Refugio. Did I say your name right? Correct me if I didn't.
No.
Rodriguez.
Kuko's a lot easier.
What is it?
Kuko.
Kuko, okay. Our third presenter is Kuko, who's currently the Chief Equity and Program Officer at the Hope and Heal Fund, a nonprofit organization dedicated to addressing firearm violence and promoting healing and recovery. Prior to his current role, Kuko worked as MHSA coordinator in Santa Barbara County. So he's familiar with the work we do here at the Commission. Kuko's career has been driven by his passion for racial equity, community engagement, youth violence, and gang intervention. We're so excited to have you here, and we're ready for your presentation. Thank you.
Thank you. It's wonderful to be back, and it's great to be here and not have to seek approval for a plan. I was the MHSA Division Chief for Santa Barbara County and the Chief Equity Officer from 2005 to 2016, 2017. And so I'm very familiar with this work. Then I decided to go to work in philanthropy. Prior to that, I worked in the nonprofit sector, doing work, working with incarcerated populations in Santa Barbara County, looking at issues of particularly gang violence in Santa Barbara County. Before that, I was an engineer in my prior career. And yes, it's all systems. I'm going to talk about that. I don't have jingles. I have math. I use equations. It's all math to me. But prior to that, and I think this is important in terms of credentials, is that I was a recipient of care. I received services, and if it weren't for those services, you wouldn't be getting this version of me. This is the better version of me. I would have still been a leader and done things in my community. It's just not, like was said, described, probably in a very destructive way. But because I was a recipient of care and services, and I had a great family, and I had the support and the resources that I needed, what you get is a better version of me. I'll also share with you, my parents are immigrants from Mexico. I grew up as a farm worker. The ideal for me, I thought when I graduated, was to be an engineer, and I had an option to be an artist or to be an engineer, and I decided that where the money was engineering. And I graduated, and I did that for a while, and it was very unfulfilling, and I was very miserable. And so when you set your sights on such things and you think that you're going to receive like there's a benefit and it doesn't, it's still trauma. Like you figure out like, what the heck? Like this is the American dream that we are told. And I started doing nonprofit work, thinking it was going to be me giving back to the community for a little bit. And 30 years later, I'm still here. So I think that's important to state, because those are the lenses by which I look at the work that we do. It should suffice in any forum that I go to speak, it should suffice for me to just say that the leading cause of death for 0 to 19-year-olds in this country is gun violence. And I should be able to drop my mic and walk away, and that should be the impetus for why we do this work. That is especially so if you happen to be a Black male or a Latino male in this country. That in of itself, whether it's a homicide or suicide, should be sufficient reason for us to prioritize this issue. Despite that, I'll talk about a few other things. But that, I want to say that because that is a huge imperative that we must address in our country, that only we deal with in this country. In terms of the work that I do, the Hope and Heal Fund was created after the San Bernardino shooting. A lot of the foundations here in California realized that there really wasn't a fund or a foundation that specialized in gun violence work outside of policy. And so they created the Hope and Heal Fund. We're not that old, we're not that large. Our focus is we are an equity fund. So equity is very central to our work and always has been. We look at the intersection of gun violence prevention, systems change, and equity. That's the area that we work in. And what that means is really typically that a lot of the work that we deal with is not work that other folks are doing. We certainly want to elevate, want to support, but we want to look at the areas. Like I said, I'm very much an engineer. I like taking stuff apart, putting it back together. And sometimes if you've had extra parts and you didn't need those extra parts. So that's my perspective. But I'm the person that throws stuff on the wall. I'm the R&D person. And that's kind of what we do. We're not regular traditional philanthropy. We really are non-traditional, and we try to work in that space. And what that means in practical terms, I'll give you an example. There's a lot of our partners that do national work and policy focus on gun violence. And I tell people, if you removed every gun from this country and you removed access, and again, I'm not advocating that, it's just a scenario, would you call that a win? And a lot of our partners say yes, and we close up shop and go home. I said, yeah. I said, and in our work, we're not done yet. Because our work around equity and our work around communities and our work around healing is not just the access. Certainly the access is important, but who's going to address the mentality that makes somebody believe that it's okay to take a life because I disagree with you? That's where our work is centered. And that's the work that's very difficult, and that's the work that's not being done. And so we try to look at it from that way. We really focus on homicides and suicides. Clearly here, we are the Oversight and Accountability Commission. Suicides is a huge part in terms of access. My equation is you have untreated mental health or trauma, alcohol and drug use, a precipitating event, or as you said, something that escalates and now exacerbates everything. That in of itself creates crisis. Add to that access to weapons, and now you increase lethality. And despite that, most of our mental health system in the upfront risk assessment before decompensation, we ask all sorts of intrusive questions about sexuality, drug use, all these things, when we really should be asking, so do you own a gun? Does anybody in your house own guns? One of the areas that I said was we do systems change. That's a systems analysis in something that is not expensive when you look at the system and the analysis, which are the critical control points that we can move that can significantly move the needle on some of the conversations. Not very expensive to add a question, a lot of resistance. But we feel that when you do these types of systems analysis, you can considerably shift the impact. So again, for us, a lot of our strategies are around system change. We also do some capacity building in terms of supporting small organizations. We don't have a lot of money to sustain ongoing funding, but what we do have is funding for organizations that are focused in doing this work around gun violence to say, you know, there's a huge grant with public dollars. It's either at the county or at the state level. We'd love to give you $10,000 to hire a grant writer to help your partnership leverage those funds. So we're trying to be strategic in how we use our dollars with some of our local partners so that they can leverage public dollars. So that's kind of a lot of the, or other areas of capacity building in unrestricted funds. Having worked in the nonprofit sector, sometimes you can create great budgets, but they're all programmatic and they're all earmarked, just like a lot of mental health dollars. I was a mental health provider before this. It's very hard to increase your capacity, to train people, to do a lot of the mental health capacity building, all these other things that we do, we have evaluation, all of these things. So that's what we try to invest strategically in unrestricted areas so that these organizations can build their capacity, increase their capacity around the work. In terms of system strategies, some of the other systems work, just to be aware, is we are currently engaged in an effort to do GIS mapping. We have mapped every single homicide for the last 9 years in the state of California to the street. That's the initial layer that we have. The reason we did that is to create a real visual for people, have them understand that over 2/3 of total homicides in the state of California, gun homicides, are not in urban centers. They're in Lompoc, in Santa Maria, Ano, in Modesto. They're in the suburbs of LA. And yes, urban centers do have high rates, but 2/3 of total homicides in the state of California are not in urban centers. And the next layer, again, to be clear, and the reason I share this because I think it has some bearing in terms of the conversation here. The next 2 layers that we're working on GIS mapping in terms of actual data to help support the work and the interventions that we're doing is looking at a layer that augments the number of suicides in communities so that we look at total gun deaths in one place and understand the total impact of guns in a community in terms of suicides and in terms of homicides. We separate them out. The equation that exists or the math that exists for us in this work is that typically 1 out of every 2 gun deaths is a suicide. So in most communities, that's what you're going to see. Now, in California, highest risk population, veterans, older white males who are lifetime gun owners. Right? So depending, again, but we're trying to source that information out so that we have an actual assessment of the impact of gun violence in communities in terms of homicides and suicides. And I think that's important. The other final piece I'll say in terms of homicides, it's really, really critical, really important, because I think it goes with some of the data that you're discussing. That's important, and we should focus more efforts on collecting some of this data because I think it's helpful in providing some clarity around narratives and what is going on in many communities is that when we're looking at homicides, the other layer that we're trying to identify is out of those total homicides, gun-related homicides, how many of them were intimate partner and how many were street violence? Because after COVID, just anecdotally, I can tell you that we've seen increases in both. But I think that we've seen significant increases in homicides in terms of intimate partner violence. And that is not information that's readily available. We're trying to decipher that, disaggregate that, because it's very critical, very important in some communities. And it speaks not only to mental health, it speaks to trauma, it speaks to a lot of other things. Spoke a little bit about the mental health system. We're also, very involved in working in systems and county systems and making correlations. As an engineer, I tell people, systems work. If not, they don't exist. Like you may not like it. As a person of color, I as an activist, I was taught to dislike certain systems because they didn't work for me. But they're working for somebody. And I'll tell you, after working 11 years in the county, I can go back and everything's still there. They didn't miss Cuco. It's still going. Like there's 2 people doing my job. Well, actually 3 people doing my job, but okay, it's a different issue. But it still rolls. And so when you do a systems analysis is what is working in that system and how can we apply that process to this? And see, in the county, and when I worked in Santa Barbara, whenever there was a fire, we have a command center in terms of emergency operations. And a lot of us got deployed. Everybody knew their tasks, everything was laid out. And so we're trying to create, and I think, we actually spoke with Sheriff Brown and others, trying to create a parallel and saying, wouldn't it be a good idea to look at an existing strategy that works? Because fire, no one has died in Santa Barbara because of a fire in like 30 years. It's effective. And if I go back today, if there was a crisis, it would be the same as it was 5 years ago with some improvements, I'm sure. We don't have that in terms of a mass shooting. More importantly, from an equity standpoint, let's be clear. We developed a plan in Santa Barbara and other counties to ensure that 2% of the population that lives on the most expensive real estate in the country don't die. And yet in Santa Barbara County, no less than 23 people die of gun violence every year in the last 10 years. It hasn't dipped below 23. I'm not saying we shouldn't have an emergency operations plan for fire, but I'm saying is that in order for us to have equity, we should create something similar that's working to ensure other people don't die. So our analysis and our approach is that's the type of work that we're doing. The last thing that I'll share with you is the other areas that we're looking at to focus on in terms of supporting is looking at cost benefit analysis that correlate with equity, but correlate with gun violence that we're not doing right now. And from an equity standpoint, that's really important. Just like we do in mental health. It's taken us a very long time to say, look, we need to invest in prevention because it's more expensive to continue to hospitalize people. And it took us a long time to put a number to that. It's expensive to have homicides in your community. In terms of investigation, hospitalization, prosecution, just those 3 things. It's expensive. It's a worthwhile investment to ensure nobody dies. This doesn't take into account the economic impact it has, the devaluation of homes, or the impact on your businesses, all of those things. So we're trying to create a very different way and a different formula by which we can look at this to ensure that we're investing on front-end prevention work to ensure that not only people don't die, but to also ensure that our investments, my thing is, look, if it's working, great, continue to do that. But if it's not, why are we doing this? That's our role. The last thing I'll close with is in a few minutes is that ultimately, I think what defines our organization and the work that we're hoping communities look at is there's a story of 4 sisters who come up on a river and there's children drowning. And the first sister runs in and she grabs one child and starts pulling them out, but it's not enough. The second sister realizes that if she grabs one child and asks them to grab another child or another one, she might be able to pull 2 or 3. The third sister realizes that, oh, there's a lot of children getting passed. So she goes downstream and figures she might be able to get them on this bridge. They start looking at the fourth sister and they say, what are you doing? As she starts walking upstream, she said, you know, we should probably try to figure out why children are falling into the river. Our hope for communities is that they view gun violence and a lot of the intervention work and a lot of the issues, social issues that are going on, mental health, all of these things in that way. Without those four components, this is not sustainable. And so I'll end with that and I'll give you back about 4 minutes.
Thank you so much. We'll save our question for you, Dan. Next presentation. Great, this isn't working. Next, we have a presentation from Dr. Sarah Metz. Dr. Metz is the director of the UCSF Trauma Recovery Center and a professor in the Department of Psychiatry and Behavioral Sciences, as well as the chief psychologist for San Francisco General Hospital. Dr. Metz has extensive experience working with trauma survivors, substance use disorders, combat veteran survivors, and perpetrators of violence, and those with complex PTSD. She is a renowned expert in trauma and recovery, and we're so happy to have her joining us remotely to present today. Dr. Metz, we're ready for you.
Awesome. Well, thank you guys. And I'm really sorry that I can't be there in person. I have 2 young kiddos at home, so it makes traveling a little bit difficult. I just wanted to say thank you so much for inviting me to be part of this panel. It's just been incredible to hear everybody's contributions. I have a presentation. I'm a visual person to kind of help keep me on track. So I'm gonna share my screen here in a second. I think everybody can see that, yeah? And please let me know if my sound goes wonky or I lose you on the presentation. So I'll back up for a second. So as they mentioned, I'm the director for the UCSF Trauma Recovery Center. So what we do is treat survivors of interpersonal violence. And I'll go into much more detail in terms of what we do exactly, but just to give a little more context before I start. So this quote, "We can sew them up, but we can't make them well." This is really what started it all for the Trauma Recovery Center. So this was Dr. Bill Schechter, who was the chief of surgery back in 1997 over at San Francisco General Hospital. And by the way, San Francisco General Hospital is the only level 1 trauma hospital here in San Francisco. So that's where any, significant, like where shootings go, significant physical assaults, they come to our hospital. And he was talking with the founder of the Trauma Recovery Center, Dr. Alicia Basaleri, and that really prompted her to figure out kind of a gap in care, a gap in mental health care for survivors of violence, and wanting to ensure that they have access to high quality care and support to help them heal. And so our vision here is a community that heals the wounds of violence and embraces hope for a nonviolent and compassionate world. And our Trauma Recovery Center, we have a number of programs housed within our clinic. That includes the Rape Treatment Center. So San Francisco General Hospital is the only hospital where folks can go following an acute sexual assault for forensic evidence collection. We also have what we call the Neurotrauma Outreach Program, where we serve folks who have an acquired traumatic brain injury. The majority of those brain injuries are occurring in the context of a crime for our community of clients here. Others are just day-to-day life. They got drunk, rode their bike, fell off, hit their head, and ended up over at San Francisco General. We also work really closely with the Wraparound Project, which is a hospital-based violence intervention program over at San Francisco General. And we have a clinician here at the Trauma Recovery Center we call the Bridge Physician that works very intimately with Wraparound to identify clients that might benefit from mental health services, as well, as kind of being a mental health consultant for the team. And then we also serve through a program called Survivors International, asylees, asylum seekers, and refugees who experience persecution in their home country. And so just to give you a little bit of a sense of the types of crime that we serve here at the Trauma Recovery Center, and this is based on our data since 2001, you can see that we certainly have a large proportion of sexual assault survivors because we have the Rape Treatment Center. And shootings are pretty consistently about 6% of the clients that we see here. And then I also want to highlight the family of a victim. So these are derivative victims, predominantly of folks that have lost somebody to homicide, and that can include by police. And so to give you a little idea of the demographics, this is specifically for our gunshot survivors between 2018 and 2022. You can see overwhelmingly they're men, they're Black and Latino men, and they're in the age group of about 21 to 30. And so the TRC is actually, our model of care has been codified into legislation here in California. Our model of care is based on a randomized clinical trial where we evaluated our method, of supporting survivors of crime. So somebody was kind of talking earlier about, identifying gaps. So what's missing? So there was a lot of funding for certain types of crime survivors, specifically domestic violence and sexual assault. But there wasn't a lot of resources being put into physical assault, stabbings, gunshot survivors. And so we really wanted to make sure that our model of care wasn't just limited or focused to one type of crime survivor. And we do a lot of assertive outreach and engagement with underserved population. So we wanted to ensure that we were doing our best to reduce barriers for folks to even being able to access care. And we do comprehensive mental health and support services, and I'll go into a little bit more about what that looks like. And also just to circle back, sorry, to the assertive outreach piece, we go into the community. We will go into homeless encampments. We will provide services at people's homes. We do bedsides over at the hospital, really just wanting folks to learn that we're here. So I think, Jose mentioned earlier, with the tragic loss of his son, nobody let him know what was available to him, and we do not want that to be the experience of survivors in our community. We're a multidisciplinary team. We have master's level clinicians, psychologists, psychiatrists, MFTs, and social workers. So we have a wide variety of disciplines. All are welcome. So insurance status doesn't matter. Immigration status doesn't matter. All of our services are free. We provide really comprehensive clinical case management. So sometimes in mental health, folks just think, okay, it's talk therapy. If I talk to you and I give you enough tools, that's enough. But I think Jose also mentioned, and I'm sorry to keep referencing you, but you just offered such powerful and rich personal experience and context to what we do. But we'll go to doctor's appointments with folks. We will help folks get connected to primary care, get connected to insurance, apply for that victim compensation entitlement, assisting them to avoid getting kicked out of their housing, to help them avoid getting kicked out of school or, losing their job. So being inclusive for clients facing complex issues. So not saying, no, somebody can't come into care because they're presenting like somebody who's experienced trauma. So that means if they're angry, if they're irritable, if they are high on drugs, that's not a reason for them not to be able to access services with us, that we very much understand all the different ways that trauma can present itself. And as a matter of fact, for the clients that are seeking our services, on average, they experienced 4 prior traumatic experiences before they're referring crime. So a lot of our clients struggle with complex PTSD. We use trauma-informed evidence-based practices. And this is because we want to ensure that underserved communities are getting access to state-of-the-art treatments. I think a lot of folks have really, really wonderful intentions and provide supportive therapy. And there's other options. And, you know, we also recognize too that what we do here at the Trauma Recovery Center might not be the best fit for everybody. But we really do very hard to also learn treatments that are culturally adapted to the various communities that we serve. As you saw, you know, we treat an international population, and so we have to be very flexible with the types of treatments that we offer. We want it to be in alignment with their belief systems and their values, that it really can be helpful. We're also goal-driven, so we co-create with our clients a plan of care. What do they see as their primary areas of need? And if it's not, you know, jumping into trauma therapy, that's okay. So for example, folks can just come to us for case management support, and that's okay. And oftentimes that is what jumpstarts the healing for folks after being victimized. And then also being accountable services. So we are data-driven, meaning we do assessment. So we do a very thorough assessment up front to really understand all of the ways that trauma has impacted somebody's life, as well as potential other, you know, mental health needs that they might have, whether it's depression, anxiety, substance use, physical pain, sleep difficulties. And we evaluate that, their symptom experience, every 8 weeks, so that we can, you know, if we need to shift course, you know, mid-treatment because what we're doing isn't targeting their needs, you know, we know that, and we're not just guessing. So as I said, we do a lot of different stuff, really depending on each client's needs. So for the Rape Treatment Center during business hours, our mental health providers respond to the emergency department to provide psychological first aid for acute sexual assault survivors. We do bedside referrals, support, and if needed, treatment. So our bridge position, for example, that works with the Wraparound Project, will go into the emergency department, will go into the ICU with Wraparound to talk to gunshot survivors and their families about the services that we provide so that they know that we're there, you know, assisting with any immediate case management needs that they might have. Any sexual assault survivor that comes to the emergency department is automatically scheduled for a follow-up with us so that they have that space, you know, if they want it. I already mentioned our comprehensive assessment that we do, very comprehensive clinical case management, as I said. So that can include accompanying folks to the police station if they want to make a police report, or coordinating with our local police departments to have somebody actually come here on site to support survivors making police reports if they want to. I already talked a bit about the treatment. We do also offer groups and some limited family work, as well as in-house psychiatry. So we are a short-term treatment model. So we, on average, do about 16 sessions, but we, of course, can increase that if needed. And so just between intake and session 16, we see very significant improvements in things like PTSD and depression. So to explain this chart that you're looking at, that blue dotted line, the 33.6, is actually the cutoff when using the PCL-5 for likely PTSD. You can see that our clients are coming in well above that threshold at 47.1. And just in those 16 sessions, we're seeing a 44% reduction in their PTSD symptomatology. Similar for depression, so that red line is the threshold for suspected depression. And again, our clients are coming in well above that at 14.4. And just in those 16 sessions, we're seeing a 45% reduction in their depression symptoms. All right, so I thought I would just take a few minutes to walk through a case example so you can kind of see, you know, maybe a before or after. So before crime victimization in some respects, and then kind of the impact. And what I really would like to invite folks to hold is just kind of thinking about the ripple effect that I'm, you know, attempting to convey here. You know, that the impact isn't just the direct survivor, right? There's reverberations, you know, for their immediate family, for their community and beyond. You know, as well as just kind of looking at risk factors that can, you know, just increase, you know, somebody's potential for being exposed to trauma. and just what that can look like. And just please rest assured, there's no HIPAA violations here. This is a conglomeration of multiple case examples, and picture is not of a real client of ours. So I want to introduce you to Samuel, and he's a 22-year-old cisgender male born and raised in San Francisco. He has an older sister and younger brother, and he has a 3-year-old child. And prior to victimization, he was working at a fast food restaurant and taking community college classes, and he was stably housed with a family friend. He grew up in a single-parent home in a high-crime neighborhood in San Francisco, where he witnessed domestic violence and was physically and emotionally abused. And Samuel witnessed his uncle get shot and killed at the age of 10. If you think about ACEs, right, he already has quite a number of those. So this is just to give a little snapshot of the incident itself. So the last thing that Samuel remembers is that he was walking home from work. The next thing that he recalls is he woke up in the ICU at San Francisco General. He was told he'd been shot 3 times and he required emergency surgery. He was informed that he coded during surgery and that he's not done. He requires further surgeries to repair all of the damage. He ended up remaining in the hospital for 4 months while having 3 subsequent surgeries. The suspects were never apprehended. So Samuel ended up losing his job immediately when he was finally able to call his employer to inform them of his hospitalization. He soon thereafter lost his housing as he had no savings to pay for rent since he couldn't work, and his belongings were eventually given away. So in a matter of 4 months, this young man that was independent, that was stably housed, that was employed, that was going to school, that was taking care of his child, literally lost everything. So just to give a little example of what happens when folks are inpatient at the hospital as a result of gun violence. So he was visited at bedside by a case manager from the Wraparound Project and our TRC Bridge clinician. He was informed about the services that our multidisciplinary team could provide, and we provided him with some psychoeducation about trauma symptoms and recommendations for immediate coping. While he was grateful for the connection, he decided that this wasn't the right time for him to get into mental health services. He really wanted to focus on his physical health and healing and prioritizing getting a job to pay for his child support and his housing. So after 4 months, he was released from the hospital, and he was able to couch surf with some friends and family for a few months while he continued to recuperate. However, eventually he was asked to leave because he couldn't contribute financially. He then found himself living on the streets, unemployed, and still healing from injuries with still 1 more surgery on the horizon. To assist in pain management, Samuel was prescribed opiates, and he began to take more than prescribed as a means to cope with all of his daily stress and pain. It wasn't long before alcohol came on board. This was a source of comfort as well as warmth, and he was soon arrested for drunken disorderly and held in booking for 3 days where he was physically assaulted and ended up sustaining a mild TBI. At this point, he was once again sent to San Francisco General, where he was once again referred to the Trauma Recovery Center from the neurosurgical unit. This time around, he accepted our referral. So his TRC clinician met him at the hospital bedside and completed his initial intake evaluation. At that time, he was diagnosed with post-traumatic stress disorder, major depressive disorder, opiate use disorder, and alcohol use disorder. And we provided him with quite a bit of clinical case management. So we helped him to complete his victim of crime compensation application. We helped him to access short-term disability, to locate transitional youth, temporary housing. We helped to coordinate the care, his medical care with his PCP. Because of his TBI, he needed speech therapy and occupational therapy. We assisted him in scheduling and planning for his final surgery. We referred him back to the Wraparound Project. We also referred him, we have a TBI support group here. And we accompanied him to his community college to assist him in advocating so that he wouldn't lose the progress that he made in completing his coursework. Concurrent with doing all of this with Samuel, he was receiving individual trauma-focused psychotherapy. He was in a skills-based group. It's called Skills Training in Affective and Interpersonal Regulation, which is specifically geared for folks who have a complex trauma history. And he also received EMDR, or eye movement desensitization and reprocessing therapy. And so despite him receiving all of that support, the reality is that Samuel has a long road ahead of him. He has medical bills looming in the background. He now has to figure out how to accommodate the impact of the traumatic brain injury on his functioning. He hasn't been able to see or spend time with his child because of his hospitalization, houselessness, and subsequent hospitalization. Because of all of this, he fell behind on child support, which impacts the types of resources that his child has access to. He still doesn't have permanent housing, and he's still unemployed. And so just want to go back, to this, that, again, just reflecting on where Samuel was before the shooting, right? He didn't have any of this, shouldering with any of this, or having to figure out how to navigate now really complex systems of care, complex systems of accessing entitlements. He was living his life. And so want to talk just for a little bit. The Alliance for Safety and Justice is a national alliance that works to help with things like legislative efforts for victims of crime. And in 2022, they did a national survey of crime victims. And so just wanted to share a little bit of what they learned through that. And their survey was of 1,537 survivors of crime or violence. So not all the crime survivors are a violent crime. And more than 6 out of 10 were a victim in the last 10 years, and almost half were victims of violent crime. And crime victims are more likely to be young, BIPOC, low income, LGBTQ, disabled, and have prior records. And the one piece that I really also want to kind of drive home is that once you're the victim of a crime, you're 3 times as likely to be victims again of 4 or more crimes. So when you think about the impact that that shooting had on Sam, that's one crime event, right? And so just having that compounded over time, and then in addition, depending on the type of crime that folks are experiencing, even just the physical impact, of those crimes and injuries that it has on their functioning. 74% of crime survivors did not receive mental health support, despite at least 70% of them reporting at least one trauma symptom. And 96% did not receive victim compensation to which they were entitled. So one thing to highlight, I mentioned earlier that the TRC model of care is codified into legislation here in California, but it is also now being replicated across the country. So we are working really hard to get as many crime survivors across the country access to our services. And we have a national alliance of TRCs as a result. There's now 44 of us across the country in 10 different states, and it kind of seems like every week there's new TRCs popping up. There's some coming in New Mexico. I think there's more coming in New York. I don't know if New York is started here. They're popping up everywhere, which is great because that just increases us as an option for support for crime survivors. And so if you're interested, you can learn more about the National Alliance of Trauma Recovery Centers and also our UCSF Trauma Recovery Center online with our website. And stop sharing my screen. But thank you very much.
Thank you so much, Dr. Metz, for that presentation. If possible, can you please stay logged on so we can ask questions of the panel after our last presenter? And finally, our last presenter, last but definitely not least, is Lara Drino. She's joining us to close out the panel. Lara is the director of the Children Exposed to Violence Unit for the Los Angeles City Attorney's Office, leading the REACH team, which was the focus of a really amazing site visit yesterday, and which we'll hear more about in a bit. Alara's worked as a prosecutor for nearly 30 years, and she works closely with many multidisciplinary agencies in Los Angeles to prosecute, develop policy intervention, and more centering on issues of child abuse and trauma. Lara also teaches classes for law enforcement, social workers, and advocates, and is a guest teacher at UCLA, USC, and Cal State LA. Lara's passion is making sure children's voices are heard in the criminal justice system in the community. Lara, thank you for joining us today. We're really excited for your presentation. I've had the opportunity to talk with her for the last 9 months, multiple times, and just they are doing amazing work. Thank you.
Oh. Okay, now it's on. Okay. Thank you so much for having me. And for those that were on the site visit yesterday, I'm sorry I couldn't be there. I was actually speaking at a child abuse conference in Denver, but I jam-packed your schedule and I'm sure you're all exhausted. I just wanted to make sure that you really got to see all of our partners and the work that we're doing. I feel like you planned this panel because I sat on the board of Women Against Gun Violence for 5 years, and Hope and Heal Fund is a big supporter of Women Against Gun Violence and our TALK project. And that is talking to parents about safe gun storage. And then Kevin is going to be training as part of one of our new grants, all of our partners from the police officers, mental health workers, the whole REACH team, LAUSD, and we are going to do a pilot in Watts to really just saturate that area with a trauma-informed approach where all parties are speaking the same language. We're all trained the same, we're all speaking the same language. So I was so excited when I heard that Kevin was going to be here as well. And then Jose, your story is why we created this program. So, and I have had many men say to me, I wish your program was around when I was a kid because I could have used it. And so with that, I will explain to you what the Children Exposed to Violence REACH team is. For 25 years, I prosecuted domestic violence and child abuse cases, and for 14 years, child sex abuse cases. And so I witnessed a lot of trauma with the victims on my cases, and I really did love giving kids a voice in the courtroom and letting them know that they were believed, and watching the transformation from the time I first met them before I filed the case to when the perpetrator was held accountable, and just watching that growth and encouraging those children to get mental health help. And I would have long talks with them about why it was important to do it now and not wait till later where it will affect their relationships. And so in 2017, I became the director of child abuse policy and prevention for the city attorney. And I didn't have like a lot of guidance of what I was supposed to do when I first got the position. And so I wanted to come up with some kind of prevention program. So I went to Southeast LA, and for about 9 months, I just listened. I went to meetings, I talked to community members, I went to schools, I talked to parents, I did surveys with parents about what are you most concerned about for your children? Is it gangs? Is it graffiti? Is it domestic violence? Is it gun violence? What are you most concerned about for your kids? And what I learned after talking to all these people, listening to people, going to meetings, and what really struck me was the first meeting I went to was the Watts Gang Task Force meeting. And it was the day after Easter of 2017. I'll never forget it. And the meetings always started with everyone holding hands and saying a prayer. And they said, let's give ourselves a hand. There were no homicides this weekend. And that had such an impact on me because where I live, there are no homicides usually in a year. And so to think that they were clapping because nobody had been murdered over the weekend really made an impact. And I realized in listening that gun violence was causing so much community trauma and causing trauma for children. And so I lucked out because Children's Institute has a campus in Southeast LA in Watts. And on the Watts Gang Task Force board, one of the secretaries the secretary of the Watts Gang Task Force works at Children's Institute. So I knew about Children's Institute from prosecuting child sex abuse cases. So I went up, I talked to her, and pretty soon I met with the team over there and asked them to help me develop the Children Exposed to Violence, the REACH team. And we partnered with Children's Institute and with LAPD because I wanted to be a crisis response team that had therapists, that had care coordinators, case managers, that went to the scene when gun violence, shooting, homicide, robbery, anything with a gun happened. I wanted there to be crisis counseling right there, not a phone call, not a referral, a person that holds that family's hand, a person that works with that kid right when it happens. Because everybody always says, and I know you all know this, and most of the people in the room know this, but the root cause is adverse childhood experiences. And when that's going to get out to the general public, where people really understand that, I'm just waiting for that day. I just did a training with LAPD where they had a whole day training on trauma, and they had me come in and talk to them for an hour. And none of them had heard about ACEs. And I completely depressed them because when I explained it to them, they all have 4 or more. And that's part of why they became police officers. And I had them fill something out anonymously and give it to me. And honestly, what you said, Jose, is so true. They witnessed domestic violence. They, grew up with physical abuse. They, lost or were raised by a single mom. Their dad abandoned them or whatever, all the ACEs that are there. And they're out there with untreated trauma too. And there's a stigma for them to get mental health counseling. I see the younger police officers don't have that. When I've talked to the younger ones, they're okay. They understand about self-care and mental health. It's okay not to be okay and all of that. So I feel hope there. And I spend a lot of time talking to the police officers about their trauma and how it must be really hard to see dead bodies and to see children injured and to see all of the horrific things they see on a day-to-day basis. And they need to process it. They need to not just stuff it down. And so what I tried to do is by bringing them in, and because I'm a prosecutor, they can tell me everything. I can read police reports. And so the way the REACH team really works, and I'm kind of going off my PowerPoint because there's so much to say here, but I guess I have control of it, don't I? I'll play a little video that was on A&E. A lot of newspapers and television, they want to do a story on the REACH team, but they want to follow us and follow a family. And I say to them, I love that you want to tell the story, but we don't do this work for publicity. We do this work because we care about the families, and I will not violate their trust. And kind of like when I prosecuted child sex abuse and they'd want to do a press release, I'd say, that's not why I do this work. And so they followed us in a way, but not with a family. So, I don't know if the volume. Maybe not, no volume. Oop. We can skip it if, it's okay. We can skip it. We'll just skip it. Okay. So as you all know, the reality is that gun violence causes trauma. But the problem is that trauma therapy is not usually offered unless the child is the victim. So through like the Victims of Crime State Fund, victims were not identified if they were indirectly affected by gun violence. And many times the children that were affected by the gun violence weren't listed in a police report because they weren't the direct victim, but they were definitely affected by it. And so that's another reason why we wanted to make sure that children were receiving the support that they needed. And the way to do that was we have started with $150,000 was our pilot. We had one care coordinator, a part-time therapist, and myself. And we were making sure that when the kids needed therapy, they didn't have to rely on reimbursements and other types of funding, that the therapist would be available for them right here and then. Now we have a lot more money through grants, and that's the beauty of this program is our therapists are just REACH team therapists. So there are no wait lists for our kids. And now, literally today, we're uploading another grant to add adult mental health with Tessie Cleveland, one of our other partners. And I see Robert Bird here from DMH. We are partnering with DMH as well to help train everybody through CTIP, which is part of Kevin, and Lionel is in the audience too. And we're just really trying to find a way to bring all these agencies together, because the only way we're going to really tackle this is if we're all working together. So what the REACH team, well, I'm going to skip through this because these are all the things that we will respond to. And in 2022, because of COVID, because children were locked inside behind closed doors, we added children exposed to any violence. So we now handle domestic violence, brother and sister, any kind of violence, we now will respond within the first 24 hours unless LAPD calls us out to the scene. So if they call us out to the scene, we go with therapists and care coordinators right then and there and do crisis counseling, talk to the parents, come back the next day with care packages, a therapist, and get them started right away. One of the things that I learned over time, so the REACH team stands for Respond, Educate, Advocate, Community Healing for Kids. And what I learned over time was these families needed so much more. They needed to be stabilized before they would be able to accept mental health counseling for their kids. And so luckily with an agency like CII that has, philanthropy funding and other kind of funding, we were able to do that. So one of the things our care coordinators do is we respond to the scene when LAPD calls us, or we make contact with the family the first 24 hours. I read all the police reports in the morning, first thing in the morning. They usually come in 6:30, 7 in the morning, and I then go through them and I send out notification to the supervising therapist at Children's Institute. She then will assign a care coordinator and therapist to that family. The care coordinator reaches out to that family. It might be 6 hours after the incident. It might be 24 hours after the incident, but they start trying to make contact with the family. They set up a time to come visit. It's usually that same day, same week, definitely or the next day, and they bring care packages to the kids. We partnered with My Stuff Bags, who donates all the care packages, and then they explain what our program is. But what the care coordinators do when they get to the house that first time is they find out, what does this family need? Like, yes, they need mental health, definitely. But if mom needs diapers or they need food, or they need to get out of the house that they're in because of danger, we got to work on that first before we can even talk to them about mental health. And so as this has progressed over the years, not only have we expanded geographically, but we've also expanded programmatically, if that's a word. And so now we will kind of assess the family, see what they need, get their basic needs met. And we've also created something, and I know you that went on the site tour yesterday, met a lot of our LA Community Resource Coalition partners, which are other nonprofits that are really doing the work. And that's a huge thing. And I think I've said it to some of you. I get so frustrated with people that say they're doing all this stuff, but they're not really doing it. And so one thing that I do is I go with the team. I go out occasionally with them. I go to every call when we get called to a crime scene to make sure we're really doing what we say that we're doing. Because I don't want to be that program that looks pretty on paper, but it's not doing the work. And so what we can do is we can kind of look at the whole family once we start working with a family and say, hey, does dad need a job? Because that would lower the stress. Okay, let's call Manny at Driving Hope because he does career counseling and he has 2 trade schools himself and he's connected to all the trade schools and he has grants where he can house people who are just getting out of prison or just, have a prior record, and he can get them into trade school for free and then they are guaranteed placed in a job. So in Nickerson Gardens, where some of you went the other day, we have 6 bounty hunter bloods who just graduated from welding school, and they're going to make a good living now because they are going to get placed into a job. So now we've just helped stabilize that family a little bit. Maybe the children are stuck at home right after school and it's not safe for them to be outside. Well, let's get them into Strive. You went to Strive, those of you. Let's get them into Strive where we can get them up to grade level education-wise, because a lot of them, because of COVID, are very far behind in school. And Strive will do tutoring and homework, but also enrichment programs. Maybe you went to Operation Progress. If the children are in 3rd grade, maybe Operation Progress is an option for the kids. So we have all of these community partners that we work with. We also put on community events that we always invite our families to. You met Sisters of Watts. They're amazing. As they say, they put the unity in community and they do the work. They do the work and they are a great partner. And they will call me and say, hey, Laura, we have a family that needs the REACH team's help. And so we start getting referrals from the people in the community who we work with. So it's not just through the police reports, it's through our relationship building. We're always building relationships in the community through outreach events and, through our partners. So let me just switch this here. So a lot of times people say to me, well, you're a prosecutor. Why are you doing this? This doesn't make sense. And I always say, this is like my dream job. I went to college to be a social worker and everybody was so negative. They're like, oh, that's an awful career and you'll make no money and this and that. And I met someone and I decided, you know what, maybe as a prosecutor, I'll have more power to really help people. And I've always done that, even with people that I'm prosecuting. If I want to get to the root cause, and I've always felt that way for 30 years. Why is this domestic violence happening in this home? What can we do to help this person? Do they have a drinking problem? Do they have an anger problem? Now I understand adverse childhood experiences. And I'll be honest, I didn't know all about that. I lucked out right when I got this position. The study came out, the 20-year study came out about adverse childhood experiences. And I just, I met Dr. Folletti and Dr. Nadine Burke-Harris, and I went to lectures and I learned all about it. And I feel like once you know that, you never look at someone the same way. And when you were talking about untreated trauma, I mean, sometimes I'll see people and I'll think, oh, that's what untreated adverse childhood experiences look like when they're acting out unreasonably. And so that brings me back to the kids. So educating the parents about trauma is so critical, because so often kids will say like, oh, I can't go to school, I have a stomach ache, or I have a headache. And the parents are like, you're not sick. And explaining to them that that could be trauma physically manifesting itself. There have been a lot of aha moments with parents about that. When I first drove around and I saw the candle memorials where somebody had been killed the night before, I thought to myself, wait a minute. So these kids are walking to school. They're like 8 years old. They're walking to school and they know someone was murdered there. They know that's why the candles are there. And then they're supposed to go sit in their chair, not talk to anyone about it, and learn their times tables. It's not realistic. It's just not realistic. And we have LAUSD Mental Health, Pia and Joel in the room, and they're great partners, because when we're working with kids, I will reach out to them and members of their team and say, hey, we're working with a family and the kids go to LAUSD schools. Can you make sure they're getting extra support at school? And I heard somebody asked about Handle with Care yesterday. Was it? Okay, so we are launching Handle with Care in Watts as part of our overall program, and we'll be doing that with the CSP officers. So I will train them on how to use it, and we will be using San Diego developed an app. So, are you? Okay, yes. Oh, okay, so you know Brooke probably, who runs it. Okay, so yes, so we have an MOU with San Diego and they're going to give us the app. So we're really excited about that and working with Pia and Joel and their team. And so that's like another thing, another layer of what we're going to be doing. But just educating the parents, educating law enforcement, going to community meetings and educating the community about trauma and what it could look like in their kids has really made a big difference, and a big difference as far as people accepting mental health services. COVID made it okay for this community to accept mental health services, because we could say, your kids are suffering because of COVID, being locked inside, having no socialization, and then this happened on top of it. We want to help. And we saw a big difference in our numbers as far as, especially in the Black community, accepting services. When we first started, it was about 65-35, 65 Hispanic accepting services and 35 Black. During COVID, it went 50-50, because all of a sudden it became okay. And one of the things with our new grant is it's the RECAST grant, and it's about creating community resilience and breaking stigmas of mental health. And so we are going to be working with the youth on campaigns, social media campaigns. I know we had the talk about social media, but we want to use it for good reason, to make TikTok videos about mental health, about how it's okay to get help for mental health. And we really want to engage the youth in that. One thing that I'm trying to do is change the narrative between the police and the community, and especially this next generation. And I think those who were there yesterday saw that what the media portrays is not always accurate. In Watts, the CSP officers are not hated. They're the community safety police officers. Obviously, there's some people that don't like them, but Sometimes those are the people that are breaking the law, so they don't like them. But they work with the community. They work to help kids excel. They are coaches of sport programs of the Watts Rams with community members. So there's dads from the community and police officers that are coaching the Watts Rams, an after-school program that's sponsored by the LA Rams. So I'm really working hard to do that by having groups of kids with police officers, and we sit around and we talk about gun violence. And what does that look like? How does it make you feel? And the number one thing kids say to me is they're tired of the grownups there saying to them, it's normal. Like, get over it. This is normal here. And it's not normal. And the kids say that. It's not normal. This shouldn't be normal. I shouldn't have to lay down on the floor because 12 bullets just came into our house. And that happens every day there. And I say to people that I know that have no idea, do you realize what's happening 20 miles from your house? It's a war zone. Every day there's a shooting. I just ran the statistics last night, and year to date, in the city of LA, there have been 106 homicides. There are 21 LAPD police divisions. 33, so almost a third of the homicides have happened in Southeast Division, where the REACH team is, 77th Division, where the REACH team is, and Southwest Division, where we're just starting. And the majority in 77th and Southeast. And they're not all gang violence. Some of them are neighborhood disputes. It's almost like COVID just unleashed this fury, and then people have guns. And so that's how they're solving problems. The way people used to solve problems, maybe they'd punch each other or yell at each other, and now they're shooting each other, road rage. We are seeing things with gun violence that is completely different than what we used to see. And so COVID really exacerbated it, and the numbers were rising, every day. There were weekends and weeks, I shouldn't even say weekends, because shootings happen on a Tuesday at 11 in the morning. There's never a time when there won't be a shooting. I've learned that having worked there for so many years now. So we work with kids who are directly exposed or who are indirectly exposed. You all already know this, why it's important to treat trauma early. And I always say there are no bad children. There are bad circumstances that happen to children that cause them to act out. And so if we can intervene early while their brains are developing so they don't become a victim again, or so they stop whatever path they're going towards ending up in the criminal justice system. And that's really why I chose to do this and put this together, was because I don't want to see this next generation in the criminal justice system. And if we can intervene and get them the support that they need while they're young, then maybe we have a chance of keeping them out of the system. So I already told you how the REACH team works. And we have an 800 number. And with our new grant, we have added Tessie Cleveland. Everyone they hire is from the community, looks like the community. And we are hoping to get this latest grant where we will have a therapist in the car a couple days a week with the CSP officers who will be willing and able to get out of the car and do crisis counseling and de-escalation. We did it one day to see how it went, and it was amazing. The therapist was able to completely de-escalate a situation, and she was also able to offer crisis counseling right away. I know we need to save time for questions, but I guess, and I have so many stories I could tell you of families and things that, we've worked with, but I guess what I would say is this model's working, but we need funding across systems. We really need, we can't keep chasing the grants, because what happens is one grant ends, and then I think we're going to be able to hire 2 more care coordinators. But now we got to switch the care coordinators where the grant ended over to the new grant, and we are expanding because it's so needed. I mean, LAPD, just, they love this program because we take care of the stuff that they can't, that they're not trained for. And so, you know, captains will call me, and people really want this. The community wants this. Like I said, I've had people say, you know, where were you when I was a kid? This might have helped me. And so I guess if there's a way to get funding across systems, like, you know, we need for the city, for the county, for the nonprofits, for even agencies like, you know, nonprofits like Sisters of Watts. I mean, they're doing amazing things, but they are hustling to try and be able to feed the community. They feed the community all the time. The East Side Riders, I don't think you met them. They're a bicycle, and they teach kids how to ride bikes, and they go on bike rides around Ted Watkins Park. And all of these partners that will help really heal a community by giving kids opportunities and maybe getting them off their phones, because they'll be busy. They'll be doing sports or enrichment, or you didn't even meet Marching Beauties. That's like for a self-esteem for young girls. And they learn all sorts of things. And I was just at an event where one of the Marching Beauties, she got accepted into 12 colleges. And she said, I never thought I was going to college, ever. But because of this program, this 10-week program, she is now going to college. And the partners are raising money to make sure that she can succeed in college. And so I just don't know how we can just keep chasing grants, but I have a model for this that could be replicated. It's just funding is the difficulty. And so I'm thankful that we have DMH here and LAUSD, because they are partners as well. And I'm hoping that we can all work together more. Thank you.
Thank you so much, Lara. And I've had the opportunity to hear about the REACH program so many times now, and I wish you had more time, because what you guys are doing is so inspirational. And I'm honored that I've gotten to go out and see what it's like on several occasions. And I'll just say, you're such a big part of that community that even yesterday I was given a ride back by one of your officers, and people were stopping him every other block to like do a fist bump through the window. So I was like, I gotta go. But thank you so much. Everyone, all the panelists, this has been such a great presentation. I think the timing is great. It's meaningful. Yesterday was the anniversary of Uvalde, I believe, which is what triggered, one of the things that triggered us kind of stepping into this work. So thank you all for the work that you do. I'm going to go ahead and turn it back over to Chair Madrigal-Weiss to open up for commissioner comments.
Thank you, Commissioner Bunch. I'd like to thank Kevin, Jose, Cuco, Sarah, and Laura for being here. Thank you for your presentations. And I'd like to thank Commissioner Bunch and all of your guests again for the wonderful presentations today. Again, this is such an important topic, and we appreciate the opportunity to have a thoughtful, deliberate discussion to inform the next steps the commission would like to take. At this time, it's been a long day, I'm sorry. I would like to invite commissioners to offer comments or ask questions of the panel.
Sorry, I just gave it back to you, but I'm going to start by thanking Courtney Ackerman for all the work that she's done over the last 10 months. Amazing job.
Is she back there? Yes. Courtney, you got to stand because we can't see you behind the podium. There she is. Round of applause for Courtney. Yeah, I ain't standing. Commissioners, questions or comments to our panel, please? Commissioner Carnavale?
You know, sometimes I feel like government is an insane asylum. So am I getting, so first of all, the panel incredible. Now I understand everywhere we went, people were like, oh, too bad Laura wasn't here. She's the reason I'm here. Too bad she, amazing. So it's such a powerful panel and then connected to our site visit yesterday. So we listen to these national debates. Every time there's a mass shooting, it's like, gotta control guns, gotta have mental health, and then nothing happens, of course. And have I got this wrong, or is this like an answer? It's not the only answer, but it's a piece of the puzzle. And my understanding is we're talking about standing up firearm violence and trying to educate more, but do we not go beyond education and start to say, here's a solution. How do we get this funded? How do we stand these programs up more and say we've got answers, but we're just not doing them? And, to me, I guess and I may have missed it, but my viewpoints shifted from education to action. And everybody knows we have to do something. So here we go. But people don't do it because they don't know what's actionable. We say mental health, but sure, okay, let's get more therapists. But here's a program. This makes sense to me. Why are we not doing this? Sorry, I could go on, but an amazing panel. Thank you.
Thank you, Commissioner Carnavale. Commissioner Brown?
Thank you. Well, I just want to say to all the panel members, outstanding job. You are one of the most powerful, if not the most powerful panel that I think we've had at the commission. I've been on the commission for 13 years, and I think this has just really resonated with everybody that's been here. So thank you all. And individually, the things that you brought to the table, Dr. Metz, thank you for sharing what you're doing up in San Francisco and how deeply that illustration of the case study of how deeply this problem goes into the person who's affected directly and the people who are indirectly along the way as well. Kuko, great to see you again. Thank you for your passion and your quest for a change. And thank you for, you said something that really resonated about that thing about if you could take all the guns away magically from everybody, would that solve the problem? Some people thinking that it would, but the deeper question of what you said is what makes you feel that that's okay of a response to shoot somebody because you disagree with them? And that's really the core of what we have to try to figure out here. And unfortunately, this issue has become so polarized politically, and people oftentimes will use that as a way to have people paint themselves into corners and to pick up or choose a side, when the reality is this is something that affects all of us and in our communities, and we all need to get behind doing something about it. Kevin, outstanding insight, some great takeaways. Really appreciated your perspective and insight as well. Jose, thank you for sharing your experience, your journey. Thank you for your recovery and your redemption, and for taking negative experiences that you were on the receiving end of and were on the embroiled in, and turning them into something positive. It's very, very fulfilling to see that you're doing that and turning it into something so good. And Laura, so nice to see you again. I didn't get to go out yesterday, but I was there a few months ago and visited, and can't speak highly enough about your program. Just amazing work that you're doing, and you're just such a class act to head it all up. So thank you. Thank you all for a great job.
Thank you, Commissioner Brown. Any other questions, comments? Please, Commissioner Mitchell.
All of your presentations, they were absolutely excellent. I think it was Kuko, you made a comment. I think you said 2/3 of gun violence is not in urban areas. So I kind of wanted to comment on that. And then Laura, I know you're the city attorney, but I'm just curious, what's your relationship with county behavioral health? I mean, like those programs that we saw yesterday, how do you guys play a role with intersecting with the county behavioral health?
And
So I don't
do you
care.
mean like DMH? Is that, I'm guessing? Well, CII and Tessie Cleveland both have contracts with DMH. So when the kids, so the Reach Team therapists are their salaries are funded through grants so that there's never a wait list. And so our program offers up to 6 sessions with no paperwork, just consent of the parent. To make it really easy, our therapist will go to the house, we'll meet the kids wherever is most convenient. If the kids need long-term therapy and the parents agree to it, because of complex trauma, or maybe it was a loss, a homicide of a family member that, that's really causing a lot of trauma, then they will be referred into one of Children's Institute's long-term programs. And those therapists, I believe, and I don't know all the nuances, are funded through DMH. If the DMH therapists that work at Children's Institute or that's funded has a wait list, they can't see the kids, our Reach Team therapists will stay with the kids until the long-term therapist can take them. So even if they have to stay with the Reach Team therapist 10 sessions, then we'll do a warm handoff. So at the first session with the long-term therapist, the Reach Team therapist will be there with the child to do that handoff so that the child feels like this is an okay person for me now to talk to. And the Reach Team therapist can talk to the long-term therapist about what happened, what's going on, where they're at in their therapy. So that's kind of how we work right now with them. I have met with the Office of Violence Prevention. We're in talks. We have an MOU with the city and the county agreeing to work together on gun violence prevention. And so I'm trying to bring us all together, and my LAUSD partners and DMH partners, we all want to work together because the city and county never seem to work together. And I go to all these meetings where I'm the only city person and I'm always like, wait, the city. And I say the city's in the county, so we should all be working together. And I feel like we're finally getting there. I mean, I'm 30 years in, so I'm like, I gotta see it work before I retire. And so we're working really hard to all work together to address this problem and maybe find a way to have Reach teams in the county as well. Because the thing is a lot of people will say, oh, we have a crisis response team. But when I ask them, that's where my prosecutorial skills come in and I cross-examine them. They don't have therapists going out doing prevention work. They have therapists going out declaring someone 5150. That's not what the Reach team is. The Reach team is prevention, and they don't have the hand-holding. They hand them a piece of paper and say, here's a list of therapists that the state will pay for. And that's not going to work in these communities. That's not going to work. They need someone to be there, to support them, to hold their hand, to come to their house to provide services. And so that's the model that Children's Institute, LAPD, and the city attorney's office has created, and it works. And that's why I want to see people follow that model and not say that they're a crisis response team when they're not actually doing it. So, and I, might make somebody angry for saying that, but that's what I've seen, so.
Yeah, I mean, what was it specifically? I mean, the data, to be honest with you, one of the reasons we're doing, and I'm sure many of you are familiar with GIS work, is that the data in California and even across the country around gun violence is very difficult to collect. We have having worked in the county system, I think the challenges is sometimes the infrastructure doesn't exist or the technology doesn't exist for us to do EHRs or all the other things. Systems don't talk to each other. Here we have a case where the state has an effective data collection system, CalDVRS, and only like half the counties participate. around gun violence. So we looked at a variety of different data sets and including the gun violence archives. And that's what we utilized to map homicides. But really because mathematically it wasn't adding up when you know the total gun deaths in the state of California, you also know the population sizes. For LA, you know the data. So when you add those up, you're like, okay, this isn't adding up to the majority. And what happens is what gets lost, and the reason we did this is what gets lost is the 3 and 4s, or the 5 homicides or 6 homicides or 7 homicides that occur in Lompoc, which is Latino, African-American, and white, which doesn't seem very high when you total that population with the total county population of Santa Barbara. But if you live in Lompoc within a 1 mile radius, that's super high. That's 3 times the state average. So that's part of the reason we set forth. So this is new data. We'll probably be releasing this in the next 3 or 4 weeks. It allows counties and communities to look at their own information. And unfortunately, I can tell you right now, when we work in some communities for people like Jose and others that do this work, say, I remember when that shooting happened. Because we can map it in terms of homicides to the street. So that's helpful. It's helpful to be as an artist. I think I told you, I chose to be an engineer, still an artist. This is like the visualization of math and data. It's beautiful because you can see the pictures and you can see that. So I would urge folks to, like I said, I do want to come back when we map. We're not mapping locations. We're mapping it by county. When we map suicides. Because then when you combine the two and also intimate partner violence, you get a very different visualization. It also is for us as a philanthropic partner, but also a partner with government entities, that should help dictate the direction that you fund and the interventions that you're funding and where. The geography is important as well. So I don't know if that answered your question.
And can I just tell you, for our new grant, I had to pull all the LAPD statistics. And just this year alone, just up until May 21st, in the city of Los Angeles, there have been 1,296 shootings across different kinds of crimes, and 421, about 32%, were in the area of South LA. So kind of matches up with the homicide numbers for this year as well. So just to get an idea of Los Angeles.
I don't see anybody online.
Madam Chair.
Please.
So question, how much money does it take? How much money do you need to sustain this program for what Reach does today, for the city, for the county, for the state? Have you done any of those calculations?
I have not done that because it hasn't been an option, so I haven't done that. And part of it is, when we first started, it was just the mental health. And then we learned it's so much more than the mental health piece. It's stabilizing the families, having the kids have something to do that's of interest to them, to keep them off the streets, to keep them from wanting to join gangs, to keep them from being victimized. And so with that, in our new grants, we'll have, $40,000 towards youth programming and another amount towards training. So our amounts have gone up because we're trying to do so much more. All of our grants right now are federal grants. Difficulty on that is you cannot buy any food and you cannot have an outreach event without having some kind of food. So that's always a challenge. So I mean, I've looked at the city of LA, and LAPD is divided into 4 bureaus. And the way that I've looked at it, ideally, if we could have 8 care coordinators and 4 full-time therapists in each bureau, I think we could do it. But I'd have to talk to my nonprofit partners to see how much that would cost. And I also have started looking at other nonprofits in other parts of the city because they have to be reputable in that area. So like in the Valley, I know I have a relationship with Strength United. CII is not known in the Valley. So we need to bring in different nonprofits. And I have other nonprofits that would love to be part of it because they believe in it too. So
And I would add that I hope that part of the analysis is also, what does it cost you to do nothing?
Right.
Because that's the part that we forget.
Yes.
Absolutely. So
Yeah.
Madam Chair, I tried this last month, not so successfully, but let me try it again this month. I looked at our fiscal transparency tool, and I believe it said that LA County has $1 billion of unspent money that comes through our system. So how is it that they're not standing on their tables pushing money into a program like this? How is it that Karen Bass is not standing on her table demanding these solutions as part of, to address these problems? What can we be doing to cause that to occur? It just seems crazy to me.
Yeah, that's the question.
Want to say, I don't know that she knows all about it. And I do have a meeting coming up with her Deputy Mayor of Community Safety to talk to her about it. So we are trying to let them know about it.
And hopefully we have this meeting uploaded so that, you can maybe share some of the footage of the questions and what we're saying here. Also, I wanted to, and I'll get to you, Commissioner Mitchell. I want to ask, with recent changes in Medi-Cal, will any of that allow you to bill for services?
I'm not the person to ask as a lawyer. Probably maybe DMH or LAUSD knows that better than I do. Do any of you know?
So
There's a new bill, managed care, that allows. The reimbursement rate is so low, it's not, you're better off through mental health, which that's where I started my career, having a licensed clinician do paraprofessionals. A lot of what gang intervention specialists, violence, a lot of these violence interruptions is reimbursable. But they created another avenue, but the reimbursement rate is so low that there's no way it can be sustainable. That's my opinion when I look at the numbers. So, but anyways.
Yeah, and we need to increase salaries for therapists so people want to become therapists. And for the care coordinators, people that are doing this work and they're in the street and they're putting their lives at risk. I mean, I drive around South LA now going, oh, we helped a family there. Oh, there was a shooting there. There was this here and stuff. It's traumatic just working in that environment, knowing that at any moment there could be a shooting. And so we need to pay people for their worth, for the work that they're doing. And I'm just not seeing that. And so it's hard to get people to want to do that work. And I really feel like even with the reimbursement, I mean, I have good insurance and I can't find a therapist for myself or my daughter. I have to pay out of pocket tons of money because insurance doesn't reimburse enough. So nobody wants to do therapy with insurance. So and then imagine, like, I'm a lawyer, I can try and figure things out. If you can't navigate systems, I mean, you just give up. And that's where kind of I come in, and any prosecutor, not just me, comes in as an attorney, is navigating the system. I call DCFS, I call the coroner's office to get a body, released to families so they can have closure and bury their loved one. My care coordinator wouldn't get to the top of DCFS. That's why it helps to have a lawyer or a prosecutor on the team to navigate those kind of systems.
thank you, Commissioner Mitchell.
They absolutely, it does not make sense why they don't have a swimming pool. So when you have that conversation with the mayor, it would be very, very helpful.
Are you talking about in Imperial Courts or where are you talking in Imperial Courts?
The one next to the Sisters of Watts. There's a park right there.
Oh, Ted Watkins Park.
Yes,
Yeah,
Correct.
one they don't charge for.
Right.
that's right, that they don't charge you.
That's that one's a county park. So yeah, I don't know.
$1 billion.
Thank you, Commissioner Cardavali. I did want. My comment is this, Google, thank you so much for gathering the numbers that you can gather. The fact that only some counties participate, I'm assuming it's not a mandate. And so with only some, we only have half the picture. So I think that's something for us to continue to ask about. Kevin, I could not agree with you more. When we talk about regression, we're seeing that in schools. We're constantly trying to remind everybody, think of age, count 3 years back. I'm a mom of a 19-year-old and a 24-year-old. I was waiting for that at 25, the brain develops, and I am now back down to 21. And I am back down to 16, and that is my reality. And so that is so true. When I'm talking to third grade teachers and they're like exhausted, I'm like, it's really kindergarten. And we just have got to give ourselves grace and understand and focus on the fact that until we stabilize, until we really build in the compassion and understanding, the academics is not happening. So let's focus on the love and the compassion before we can even get to the other pieces of it. So thank you for sharing that message again. Jose, when I heard that because your son was identified as a documented gang member and the family would not then qualify for services, that doesn't even compute. How do we break the cycle of pain and suffering, right? So we got there somehow. As you said, right, the trauma causing trauma. So for the system to say, no, you don't then get services that you absolutely could benefit and that could help serve to break that cycle, there's something really wrong when we're doing that. It's subjective. It's people making decisions towards other people's lives that are outside of the circle of human connectedness, which is just touches me at the core. So I hope that we continue to stay grounded in what's really important and how, and I think this goes back to when we were talking about this earlier, how important it is our community's voice here, because we have to be, it's the community that needs to be shaping the policies and how we make these decisions. So thank you so much for sharing that. And thank you for being here. And thank you for being here. I appreciate that. Laura, your name came up probably every 15 minutes yesterday. And so it is an inspiration from the PD to the law enforcement officers who spoke highly. Their stories, how they describe the community, very different language than, you know, I work with different law enforcement agencies and I think it's gotten better. What I saw yesterday though, really unique, really beautiful. And everybody's connected. The language is braided together between the systems. And so that was powerful to see. I agree, we need to do something. You know, when we're talking about charging people for their local parks, something's really wrong with that, especially when we need a place for young people to be engaged. So you have our full support and we're listening, and we definitely want to find ways. When the city attorney's office is leading the effort with law enforcement and the mental health partner is not front and center, then we need to continue to ask questions and see what we can do. I hear you, Commissioner Carnevale, the $1 billion, I hear you.
I have to say something.
Please.
The National District Attorneys Association told me that they did a study, and for whatever reason, I don't understand it, but prosecutor-led programs are more successful than any other program. So I don't know why, but they did a study and that's
Well,
what they
hats
found.
off. And I will tell you that Handle with Care is being led by our DA. So there you go. So I want to congratulate you all. Thank you so much for being here. Thank you for all the work that's happening out there. And I'm going to invite Vice Chair Alvarez to say a few words.
And I'm not going to take very long because I know we're very short on time. I also just wanted to express my appreciation to each of you for your leadership and for being with us today. And when I really emphasize what I'm hearing you, Laura, say is what in the health space, but also in the education space, we're calling a whole child approach, that it's not one division's responsibility, that there is a responsibility of our agencies to work across sectors in order to take care of the whole child, the whole family, the whole community. And I'm also hearing that we need to move the responsibility of navigating those systems and funding streams from families and organizations to government itself, and find ways to blend our programs and braid our funding in a way that works for people. And so, in our work again around strategic direction and the way the commission is headed, how do we center these experiences to think through our whatever oversight role we have that really holds our county partners accountable to working across departments in order to be able to fund initiatives such as this? That's one. And then second, we talk a lot about learning communities, Toby, and uplifting best practices and sharing them so that other counties can benefit. I think this is one incredible opportunity to do the same, to ensure that it's not only Los Angeles County that benefits from such initiatives, but that we have the opportunity to take such programs to scale across the state. So again, thank you for your leadership and your heart and everything you do for our communities.
Thank you, Vice Chair. So at this time, we are going to move for members of the public to make public comment on this agenda item by clicking the raise hand button on your computer and on the app of calling in by phone *9. Once the public comment period for this agenda item starts, we will close the public comment queue. So please make your request to comment now. Are there any public comments? Please raise your hand now as the queue will be closing. We would ask that you please limit your public comments to 3 minutes or less. Mariani, please open the line for public comment on agenda item 6. And let's start with comments from the room.
Madam Chair, we have one comment in the room. Steve McNally.
Hello, my name's Steve McNally. I'm from Orange County, and I have a son with schizophrenia, and all his relationships are restored. I'm also on the county board. I'd suggest you get this in front of the LA Mental Health Commission. One thing I'm truly inspired by a couple of things. One is people do make a difference, even when they work in very bureaucratic settings where people would rather push reports, almost like that movie Office Space. I don't get the same dedication, the feeling of being patient-centric or person-centric from a lot of our state agencies. And the other thing I was struck by is what you piece together might already exist in the current funding streams, except nobody talks to each other. And it's not a say yes culture. It's not, I do what I do and I do it really good. And I only do this podium, but I can't tell you what feeds into my podium. I can't tell you what my exit is. And I don't really care. And so I'm not looking to leverage the money. The other is that most of us who are curious learners want to know how the thing works in simple terms. And so the data that you presented looked at it a little bit differently. And we live in a state that doesn't really care about data that much, even though it's available. It's almost as if I hoard the data, nobody knows the data, then I can just create my own narrative and say something's terrific. And as people who live the journey, the silos only hurt one person, and that's families and loved ones. It doesn't hurt the system. The system continues on. People get paid pretty good, I think, in some of these jobs. And yet they don't take ownership of recovery. And recovery isn't really that difficult. It's complicated, but it's really simple, right? It's acceptance, awareness, and meeting people where they're at. And it's so frustrating to see us spend so much money not doing that. So I'm really excited that when I see people can make a difference and make a difference in other people to get other people excited. Commissioner Carnevale asked the question I was going to ask, which was, how much money do you actually need? And that's always a good be able to answer that question. And the second thing, and the last thing is, because I got to go to my Chatty Steve 12-step program, is I always wish that in addition to being informed, that every presentation empowered everyone in the room to do something for you, whatever that might be. Could be as simple as put 988 in the phone list. It could be something else, but
Thank you, Steve. We're at time. If you could please wrap up your
thank you very
comment.
much.
Thank you, Steve.
Line, we have Mark Carmax. Your line is open.
Hi, this is Mark Hymatz. Again, I'd like to talk about the California Association of CAPS Academy, and that started with San Francisco, and also it's Project Return is part of it. A lot of your things that you were talking about today, that would be applied under some of that stuff. I would say take a look into those programs. And also, I'd like to ask the last three presenters if they have peer supporters within their programs. And I would like to hear the answer.
Yes, we have peer specialists and parent helpers in our program that are from the community.
Which one are you?
Oh, this is Laura Drino from the REACH team, Children Exposed to Violence. You said the last presenter, so I thought you meant me.
Yeah, you were one of them. So REACH does have. Okay. Continue to work with Project Return and to try to get some of their people into that, because they're doing trainings. They're going to start again on June 6th. So please get some of your people involved in that. And I'd like the doctor. How about the doctor from San Francisco?
Yeah, hi. Hi, Mark. This is Sarah Metz from UCSF TRC. So right now we do not, in our specific program, have peer support, but we work very closely with the Wraparound Project that are, all peer counselors, and we also partner with other community agencies that are peer-based, like, for example, Us for Us Bay Area, but we don't currently.
Thank you, Sarah. Thank you, Mark. Thank you to everyone for joining us today to continue the work and discussions around mental health. We would especially like to thank members of the public. We value your input and participation. Our next commission meeting will take place on June 15th, 2023. It will be virtual via Zoom. We look forward to meeting you then. Today's meeting is adjourned.